Yeah, Dr. Ashok, are we ready?
We are live, sir.
Yeah,
Yeah.
we are live.
Okay, I welcome you all for this Delhi Orthopedic Association PG Teaching and Training Program. Myself, Dr. Manish Dhawan, and with me, Dr. Vivek Jangira, we are the moderators. And we have a very learned panelist with us, and Dr. S.K. Asmaria, Dr. Anil Mehtani, Dr. R.K. Arya, and Dr. Mukesh Kalra. And now I request Dr. Vivek to please introduce the speakers.
So let me start with the first speaker. Our opening batsman is Dr. Alok Sood. He has many years as a teacher. In his circle, he is known to be a very hardcore academician. Let us first invite him for his first lecture in clinical teaching, improvisations and outcomes. Sir.
Thanks, Vivek. Thanks for the kind words. I'll start sharing my screen. Yeah. So good morning, everybody. The topic I have been interested with is postgraduate clinical teaching, improvisations and outcomes. See, I begin this talk with the basic premise that educating patients and colleagues is a routine and fundamental part of any physician's work. So these two cannot be separated out. The clinical work as well as the teaching cannot be separated out, and that is why the teaching is extremely important. Now, what is the aim of the postgraduate teaching? The basic aim of the postgraduate teaching is to pass on the skills. Now, these skills can be of two types. These can be objective skills and these can be subjective skills. We all know about the objective skills because all of us are known by our objective skills, which are clinical skills, history taking, examination, reaching a differential diagnosis.
आलोक थोड़ा आवाज नहीं आ रही.
Interpreting the. Am I clear now?
Yeah, you are clear, sir. Your sound is okay, but your sound is actually a little bit less. Otherwise,
Okay.
clarity is okay.
Okay. So the relevant investigations to be how to interpret them, and the surgical skills, the research and evidence-based practice. But besides these objective skills, there are more skills which have to be passed on, and they are actually more important than the objective skills. These are ethics, the empathy, and learning from your own mistakes, and setting an example for the postgraduates of a true professionalism, staying away from personal criticisms of your colleagues. Now, basically, what do you mean by ethics? So ethics are your decisions and your actions, right? The actions and decisions which a physician takes in the interest of the patient, they are silently absorbed by your postgraduate training. And basically, when you are practicing the ethical practice, empathy follows itself. So these subjective skills are much more important as compared to your objective skills. And maybe you're not talking about them, but your behavior and your body language, the PG will learn from that. Now, coming to the aim of the PG learning, having talked about such lofty aims in the previous slide, the aim of the PG learning is basically tumbling to passing the exit exam. And therefore, our teaching also has become like that, right? In first 2 years, the PG gets accustomed to the hospital, to the working environment, to the thesis. And in the last year, we keep on adding on certain lectures and certain PG classes, and we start molding their thought in a certain direction. So clearing an exam is not at all difficult because there will be typical cases, there will be stereotype questions, there are even books which are existing on these, and there will be right answers. Any trainee who has undergone few classes in a medical college, be it Maulana Azad, Lady Harding or UCMS, will be able to crack the examination. However, this examination, it doesn't test the aptitude. It is not skill based, all of us know that. It will not be necessarily truly evaluative. And as I was telling you that it just promotes a conditioned thinking. It doesn't encourage independent thinking process, creativity and research ideas. More than that, a failure does not mean that that particular candidate lacks aptitude and knowledge. Even vice versa is true. A person who has passed the exam, it doesn't necessarily mean that he knows everything. So all in all, the summary is that passing the exam is not equal to acquiring the skill. And therefore, we see that there is low interest in conventional teaching. However, exit exam is not bad, right? It is a time-honored policy. A time-honored principle which works on the principle of carrot and stick. What is stick? Stick means fear, right? So basically, fear is to pass the exam. So with this fear, the candidate goes through the literature and research at length, thoroughly, and probably this is the only time in his lifetime when he will go through the literature so thoroughly, and this is induced by the fear of the exam. So it is not bad all the time. It gives the confidence that only a well-read person can have, and it prepares you for objective assessment. The reward is that you become eligible for the degree and for practice, right? There is feel good factor of passing. It brings in the competitive spirit, and maybe you may be evaluated and rewarded as a best resident. And sometimes in certain medical colleges, these marks are also used for appointment as a senior resident. So what are the current teaching methods or learning methods for the postgraduate students? Currently, the postgraduate students, they learn in the OPD, during ward rounds, operating rooms, right? All of us do that. Teaching rounds, which are taken by faculty and the senior resident. Dedicated clinical case discussions, which we take as classes, seminar and journal club presentations, difficult case presentations, and supervision, protocol, and thesis writing. So these are few of the methods by which currently we are teaching our postgraduate students. Now, these current methods are traditional, right? We learn from our seniors and we are teaching the same to our juniors. So it depends upon the principle of see one, do one, teach one, right? You see a surgical procedure or a skill, do that surgical skill or procedure, and then teach one to your junior. So that is how it is built. So this involves picking up the skills opportunistically. As and when the patient and situation arises, we learn by osmosis. This is called learning by osmosis. So this kind of teaching and training is unstructured, and this is not changed for last 60 to 70 years. There is hardly any well-defined curriculum. There is no subspecialty training, and all the more the training period is insufficient. We are just training our postgraduates for 3 years as compared to 6 years in the West, in the developed nations. The training is non-uniform. There might be discrepancy in between training between Maulana Azad and Lady Harding. There might be discrepancy in training between Delhi and South India. So this has to be uniform. So there are several reasons for such training deficiency. Some of them are physician dependent. The physician dependent are that we are unable to always practice what we preach because of logistic reasons, right? The patient might be very poor, the patient load might be too much, so we are unable to uh, manage in the manner he should be managed. So the postgraduate student picks up this duality that, okay, reading the book is something else, and in practice, it is something else. Second, paucity of research and literature, especially from Indian subcontinent. And very, very important is lack of education training for the physicians. There are hardly any reasons for trainee dependent because it is the duty of the faculty to arise to interest of the trainee in the specialty or subspecialty. So let us take these factors one by one. Yeah, and a third factor which is very important is population dependent. As I was saying, that ideal practice may not always be possible because our health structure is extremely unorganized. So the administration has a lot of flack to take. It is not only physicians. So I was talking about less or no literature or research from India on problems which are peculiar about developing nations. Now in day-to-day practice, we keep seeing patients of infections, sequelae, tuberculosis, congenital deformities which are presenting late, neglected trauma. You will hardly find any literature in the Western literature. Now, how do we teach our postgraduate students in such scenarios? So we keep on taking Western principles and we keep on applying them on our patients without any indigenous research. So that way, there is no literature or research which is coming from India on these topics. And that is why there might be paucity of literature, there might be duality in what we say and what we practice. All these things are being silently absorbed by the trainee, right? So don't think that they are stupid. Though trainees are seeing everything and they are learning whatever we are doing, either spoken or unspoken. Then very important, lack of training for us, right? Now you will be surprised that a teacher cannot teach in a nursery students or school students without education training. But at such a senior level, at such a complicated level, we are expected to teach the students without any education training, right? Although such kind of trends are changing and there are medical education cells now being set up in each medical college. Now there were popular beliefs in our time that teachers are born and not made, and most of us had charismatic teachers who were few, right? Most of us are average, but some of them were charismatic teachers. Now these charismatic teachers were can be made, right? They are not always born. If we are properly trained, like you can make a charismatic surgeon, you can also make a charismatic teacher. So what is lacking is training. Now coming to the lacuna on the presenting in the present teaching methods. Now there are various lacuna in our teaching. I'll be taking out few of them. Now the most important of this I thought is the communication skill, right? We do not teach our trainees how to communicate with the patient. Now this the communication should include how to take a consent, especially in the medical legal aspect. It should explain morbidity, risks, and implant costs. Sadly, this is largely learned by observation. There should be separate teaching time. Now, the MCI has separated out resources and time for the undergraduates. Similar thing should be done for the postgraduate students. Lacuna number two, which is very important and will become more important in future, is record keeping, right? So written or digitized records, how to keep them is never taught. It was never taught to us, and we are not teaching it to our postgraduate students. Similarly, keeping the discharge and mortality records, MLC records, pre-op and post-op clinical pictures and videos, they are becoming increasingly important because the teaching will be becoming more and more digitized. So special time and resources should be spent by the college and by the university on developing these resources. Presently, most of us are not good to teach this skill to our students. So this has to be done separately in separate classes with separate funds and separate time. Lacuna number three, we lack in statistics and research, right? For most of us, the research is limited to giving the thesis and supervision of the thesis, right? We do not know anything about statistics. We don't have any research orientation. And because we don't have any research orientation, we are unable to pass it on to the postgraduate students. So the solution is both simple and complicated. There should be mandatory publications for faculty and trainees in index journals. Time and resources for learning the statistics should be kept aside, right? Lacuna number four. Now, this is the lacuna where most of us will concentrate, keeping the communication skill, the record keeping behind, right? Even in passing on the clinical skills, we lag behind, right? That is because this is an old system, right? It needs revamp, which is consistent with the present times of availability of state-of-art imaging and diagnostic methods. This can be overcome by including integrated teaching. We should include people from radiology to teach our postgraduate students about CT scan, MRI, ultrasound, and their uses, right? Most of the times, when we are taking case discussions, our case discussion stops short on differential diagnosis. We do not want to take up management because management part there may be disparity in what we are doing actually and what is written in the literature, and that is why we might shy away from taking the management part. Now this has to go away. There is more than required emphasis on clinical methods and certain clinical tests which have no relevance or less relevance. We keep on harping about certain names and of some obsolete tests, and the passing and fail of the candidate depends on that. I think this kind of mindset should be done away with. All of us should acquire a more mature approach and Case discussion should not should not beat around the bush on the names of the clinical tests which are no more useful. Surgical skills. Now this we do not teach at all, right? There is absence of skill labs, there is non-existent cadaveric dissection, there is absence of digital tools for surgical skills and dissection, and uh, the future belongs to the digitization. So we should all prepare videos, we should all take help from publishing houses which are involved in making animated and real-time videos, because the skills, the surgical skills in future will be passed on in this manner only. There should be ideally regular cadaveric dissection courses at least twice a year, and there should be skill labs which are common to all surgical specialties, as well as specialized on specialized sawbone models and mannequins for learning the skills in orthopedics. Like number 5, which is very important, is that we are not doing any rotations. Now we all know that all medical colleges cannot develop all subspecialties. So there should be at least intra-hospital rotation within the units, if not inter-hospital within the university. Ideally, there should be inter-hospital rotation, and it is possible if it is within the university. And I think improvisation should be done at this level. So what are the improvisations which have to be done to improve the PG teaching? The improvisations can be done at the government level and at the university level. At the university level, we must develop a very well-defined curriculum, a uniform structure training, at least in the university. As I told you, there should be rotations, both intra as well as intra-hospital. Emphasis should be there on skills and competency rather than clearing the exam. The training time should be increased from 3 years with the focus on developing subspecialty, as this is the genre of subspecialty, so you cannot do away with this reality. Assessment pattern has to change. There has to be more emphasis on periodical assessment, skill acquiring, and logbook assessment rather than a single exit exam. The government can help us by providing funds and by organizing the health structure. At the institute level, there should be integrated teaching, and one of the best way for integrated teaching is monthly or fortnightly clinical case meet for selected cases, where the pathologist is involved, the radiologist is involved, and the clinician is involved. Mortality meet is yet another very good way of auditing the cause of death and preventing the morbidity in future. Medical education cells should be established in all medical colleges, and they should not only cater to undergraduate teaching, but also postgraduate teaching. Orientation first for the faculty and then for the postgraduate student should be there necessarily in research, statistics, and paper writing. Communication skills and medical legal workshops should be actively participated in. And as I already discussed, that mandatory skill lab posting, access to cadaveric dissections, simulated surgical skill dissections, and skill developments, and access to international libraries through institute has to be there. National and international participation for the postgraduate should be encouraged via workshops and symposia, and quality assessments should include the teachers also, right? The last slide is that we must do away with this kind of assessment, because this kind of assessment does not, it changes altogether the focus of the PG teaching. It just goes on to passing the exit exam rather than picking up skills. So assessment should be done on rotations and logbooks, and all those methods should be employed, which I have already discussed. As far as theory is concerned, the questions should be more structured rather than unstructured, with the help of OSCE, MCQs, etc. Thank you very much. Now, this was prepared only by my personal experience, and I am sure that I have missed a lot of points on PG teaching in this, and I'm open to receive all these points. Thank you very much.
Thank you, sir. Now, the talk is open for discussions. Panelists may ask questions or may add up.
Can I ask a question, Dr. Vivek?
Yes, please.
Dr. Alok,
Yeah, good morning. Yeah,
Good morning, sir. How are you?
yeah.
Sir, fantastic talk. And sir, you rightly said there are many of the tests which are obsolete. For example, telescopy in a fresh case of intertrochanteric fracture. This is one of the, we all tell our PGs कि ये test करना होता है. So you rightly said, are we still practicing it? I mean, in a painful knee, just to test a knee when we have an X-rays and CT scan and MRIs, are we still doing all this in the medical colleges?
Actually, Dr. Samit, you are right. What I'll answer in this fashion that we have to introduce the clinical methods to the postgraduate trainees. But uh, in this state, in the modern times, when there is so much of diagnostic methods are there, we have to corroborate these clinical tests with the diagnostic methods, right? We cannot, the diagnostic methods cannot be done away, right? So the diagnostic method should form part and parcel of the examination in today's time. And we should teach them the diagnostic methods without losing the focus on the clinical methods. So it is a tightrope. We have to teach them both. Right now, our focus is more on clinical methods, or rather only on clinical methods. But
Correct.
this pattern should change, and we should bring in the radiology. Since we are in orthopedics, we should bring in radiology and imaging into teaching, into regular teaching in the management when we are discussing our case discussions.
Correct, sir. Very rightly said. Because this clashes with the empathy part. When the patient is in pain and we are only concerned with कि हमने test अच्छा कर लिया. So I fully agree. Thank you very much.
Vivek,
Dr.
can I
Alok,
just
Dr. Alok, you have just missed one point. In India, I have seen that surgical audits are not being done properly or at all in most institutes. We usually shy away in discussing our surgical cases in most institutes. That is a very big learning platform, which I've noticed and seen and experienced, especially in UK, where each case of every unit is discussed, and that gives a lot of teaching to the postgraduates. That should be made compulsory.
Yeah, you are extremely right, sir. I mentioned that in difficult and interesting case discussions in the last, and this is one of the very good ways to know our shortcomings.
Vivek, can I comment?
Yes, sir. Please welcome.
Actually, I have seen this undergraduate and postgraduate teaching in a number of medical colleges in India physically, and I have seen abroad also. To be honest, we differ from the West is that we are very good clinicians. There is no match in the world as an Indian clinician. And it stands true, look, feel, and move. It stands true, that appellate teaching stands true even today. But the problem here in India is a system. See, all stakeholders are like Medical Council of India, National Medical Commission now, universities, Delhi universities at vice chancellor levels, and at the college level. And that should be structured in such a case so that as a medical teacher, it is imparted in a structured way. That the fault is not on a medical teacher or a medical college or a setup. It percolates from the top. So that is a big problem, and which is not in our hands. We retire just teaching and becoming a charismatic teacher, as he said it. So that is my point. It should be taken care by all stakeholders.
Thank you, sir.
Yeah, Vivek, may I?
Yes.
Yeah, just one comment. Uh, discarding the comment about discarding certain tests. One thing I think I must point it out, we usually don't say a postgraduate to do a telescoping test in a fresh case. We rather say telescoping should not be done in a fresh case of fracture neck femur and fracture trochanter. Second, whether these tests should be taught or not to be taught, everybody as a student or as a postgraduate or as a resident is not going to stay in Delhi, in Lady Harding or in Maulana Azad. Maybe they are placing themselves in a peripheral center somewhere in the periphery. And at the first instance, CT may not be available. You have to wait for the X-ray. So it is very, very obligatory, and it's very, very good to able to diagnose clinically also, and it gives you some pleasure also, because if you're diagnosed something clinically by the way of certain tests, so knowing test has a clinical relevance for diagnosis. This is one. Second, Alok pointed out that there should be rotation, and we need, maybe government should help us. I think we all should sit together, all the people of all the institutes, including private institutes. We can decide ourselves that PGs, postgraduates, and even residents also, they could be rotated in different hospitals in Delhi. We don't have to be dependent on the university for that. We can, if university agrees to it, it is fine. If the university doesn't give us any clue about anything or doesn't help us, we can all sit together and we can always decide. We can always send our residents to some other place, and those can send to some other places. This can be organized by ourselves also. If we keep depending on the government or keep depending on some administration or other system, probably we will never achieve it, or it will take too long. So it is a good time that we should do all those things. But first we should settle our own house. There must be interdepartmental rotation. There must be interdepartmental rotation in important departments like plastic surgery, neurosurgery if it is available, and radiology. And these departments, and general surgery also, because modern orthopedic surgery involves opening of chest also sometimes, involves in when you go for extensive spinal surgery, you need other parts of the body which general surgeons are more tuned to. So we must rotate our PG ourselves and should decide to rotate in different institutions also. We can do it ourselves. Thank you.
Can I just add a bit now? Can you hear me?
Yes, sir.
Yeah. So I think it was one of the most well, structured and concise presentation by Dr. Sood. Difficult to find points, but just to elaborate, first thing is that, as Dr. Mehtani just said, we were teaching postgraduates in the private sector, from where we had great help from St. Stephen's, Maulana Azad, and from Safdarjung, where our PGs went and did very well, considering that we had limited both training experience as well as limited pathology. So what we always feel is that we should have regional PGs, as we have heard in different languages, PGs who are trained in the region and not in the center. And we should call them our PGs and not my PG. This philosophy of his my PG is also, very restricting, both for the teacher and for the PG himself. Because if you feel that they are our PGs, you also get a lot of learning from people who have gone, the trainer is being trained. Now that is most crucial. Other thing which I must emphasize is documentation as well as management strategies. We will have to go in, whether they are virtual or they are on path or what, we will need to learn these two things to the highest order, because out there are waiting people. There are people who are earning out of creating trouble. So you have to be very careful. Your PGs should also learn that along the line. So one point which I liked about his was, in brief, that a longer PG training, but a person comes out as a super specialist. Maybe starts initially on basic skills, which is multidisciplinary. Have you heard surgery, pathology, radiology, etc.? Then comes the broad speciality. I'm afraid today what we are noticing is immediately after MS, after learning a lot of theory, everybody wants to become a fellow. They don't want to do senior residency. Believe me, I feel very nervous about it, because it is like an orthopedic surgeon doesn't know anything about general surgery, cannot palpate an abdomen or worry about a urinary retention. Similarly, an orthopedic surgeon suddenly wants to be, say, a spine surgeon or a pediatric surgeon or a joint replacement surgeon without having basic knowledge of how to laying down a proper plate or inserting a nail. So I feel that then the final thing in continuity should be a super specialty in the end for 2 years, so that when the person comes out, he is now a super specialist with the knowledge of everything that an orthopedic surgeon should carry.
Thank you, sir. We would like to take one or more 2 points before we wind up this talk, because we are already 15 minutes overshoot.
Can I say something, Dr. Vivek?
Yeah, Dr. Anup.
Yeah, thank you. Dr. Alok Sood, you have really pointed out very well about the lacuna. There are two things which I want to say, that we need to put in every conference a lecture about medical ethics and evidence-based conservative management. which our PGs have forgotten. The other thing, whatever we are discussing today for the PGs, can we have association coming up something like a joint statement for the PGs that what are the things should be done? Unless until we jot down the point and do a recommendation either to government and the university, all these exercises, whatever we are doing, goes in vain, just limited to the webinar. So to put it into the paper and as a recommendation from an orthopedic association is going to do really good work for our PGs.
I think the
Dr.
Delhi
Arya,
Orthopedic
please.
Association should take up this and should include the communication skills, the medical legal aspects, and record keeping and statistics, these four things for PG teaching in all their sessions. That would be a great thing from DOA.
Thank you.
Dr. Arya, please, for last comment. Dr.
I think,
Arya, are you with us?
yeah, I am with you. All already said about it. I think the most important thing, I think all senior people are sitting here. We should note it down as far as the interdepartmental, inter-hospital and intra-hospital posting is concerned. I think these can, ourselves can start from the very next session. That is most important. Second thing is about the surgical audit. I think we ourselves are afraid of surgical audit. I've started myself in our institute, but then the criticism, we are as a surgeon don't able to really take it more personally, and they shy away from taking all this criticism seriously. I mean, including my own colleagues, and sometimes it becomes too personal. So there are a lot of limitations to what we are suggesting. Finally, as Dr. Maria said, I agree. The basic training need to be done. Like I work in now a super specialty center. I see people do away with all good part of the sports injury management, but they are not even aware of the basic pathology like tuberculosis and infection. Even a stiff shoulder to them is always surgical release and surgical arthroscopy. And then they don't even think of differential diagnosis as tuberculosis. I mean, there are a few things. I think all this fellowship should always be on, but they should come after seniority when basics orthopedics is learned and been trained to do practice. And they don't miss the differential diagnosis in general practice when they come to field.
Thank you. Dr. Vivek, I think we should move forward to the next speaker.
Yes, I hand over to you to invite the next speaker.
Yeah, I'm very happy and very proud to invite Professor Lalit Mani, a well-known academician, and he'll be speaking on fate of clinical research and outcome for thesis. So Professor Mani has a wide experience in postgraduate training, and I request him to start the presentation.
Thanks, Dr. Manish. Am I audible?
Yes, yes.
Is my slide visible?
Yes, sir.
You have to put it on the play mode. Now it's okay.
Now it's
Please
working.
start.
Okay.
Please start.
Thanks a lot, and thanks, Professor Alok Sood, for setting this very, very important area ignited. And I'm thankful to the organizers on putting this in the agenda of the conference, specifically to me on this topic on fate of research and outcomes of thesis. So if you ask me to sort of conclude before I start, I think the fate of research and outcome of thesis is almost mandatory and compulsory, and it happens. Nothing more than this pandemic area, which has made this term research a meaningful word even to the layman and to the general society at large. And suddenly we have understood why research is a pillar of how we can maintain the health of mankind. So I would take you through in the next 10 minutes through the ground realities and the larger goals which have been achieved and which go on to be achieved all the time. So thesis, now the various full forms you will be able to dig out if you want to. One of them is true happiness and its since it started. So I'm looking at a postgraduate student who's just joined his training program, and he might get this full from his immediate senior who is sweating it out to complete his thesis. And it would be nice that you could visit this website phdcomics.com, which connects you to reality of research at the ground level when you begin medical research. And when I look back and see at my own thesis and my postgraduates doing the thesis, this pie chart is very, very depictive in the way that we really stress out and burn so much of adrenaline thinking about writing our thesis, and then fiddling with formatting and coloring and various other things, and the actual thesis writing becomes a real small part of the whole game. So in this complex area of research and thesis outcome, let's look at the thesis. What are the stakeholders into it? The most important base would be the area of research which we are looking at. And I'm putting the supervisor as a second part, because the postgraduate is coming an absolute raw person into their specialty. He has been exposed to orthopedics in his MBBS, but then into core research and as a thesis, maybe he comes in as the third player. So these are the three main players in thesis, which will finally get concluded. But then there would be three more, I feel, which are the college, the university, and the time zone. Now let's go from down above. What is time zone? Meaning the theses which were done maybe 50 years before and what are done today have a different outlook, a different approach, and a different area of research. More so, I think another time zone which is getting added is the COVID time, the pre-COVID and the post-COVID time. I'm sure with so much happening in the COVID time, our ways and practices of doing research are going to get a boost after this COVID era. Universities will have their own guidelines which will affect the thesis. The college will have their own guidelines which will affect their thesis. If you read literature on thesis, there is lots written about supervisors as a research entity, because he is the person who sort of guides a student first time in his life into a structured research process. So there are various publications which talk about how a role of a supervisor is there. What type of a thesis happens when it is the first thesis of a supervisor, and what happens when it is the last thesis of a supervisor, and what happens in between in the journey. What happens when a supervisor has one postgraduate to guide, and what happens when a supervisor has three postgraduates to guide. So there are so many factors which actually affect the outcome of a thesis, which actually is to be looked into. There is literature on what happens to thesis and what is the outcome. The most measurable outcome would be a publication. There would be other non-measurable outcomes like getting a residency or a fellowship program or a future progression of a person's academic life. If you look at the measurable publication measure across all specialties in medicine, the range of publication of a thesis varies from 5% to 25%. The rates of publications and conversions of thesis into publications is more in medical branches than in surgical branches, for reasons most of you could understand. And still, if there is a lot of paucity of literature, I've done some literature review, and to my surprise, maximum number of publications on conversion of thesis into publications is from Turkey, and they really have done this in all specialties, even beyond orthopedics. We did our small bit of an informal survey in our own institute since I was given this topic. And what we could observe is the era of 1990, when I joined my post graduation, till around 2010, we were able to contact around 104 postgraduates, and we found out that there were 22 publications. So we are reaching somewhere around 20%. And then we again sort of surveyed the last 5 years, where there were around 48 theses which we covered, and 13 got published. A slight increase in the publication rate, but almost the same. And probably this is a very important factor to look into as a department of an institute, that what is the publication rate of your department. Suddenly, and on one day when you take over a department as a head of the department, and you announce that all theses should get published, it will never happen. Every department, every institute and university has a history, and you can change the history, but it changes gradually. So the world literature says around 15 to 25% conversion rate, and different universities would have their different rates, which definitely would get changed with efforts. But when you ask a postgraduate student, for him, it is the endless cycle of making edits, showing the edits, getting the corrections, and getting more edits to do. A classical graph of a postgraduate student, now I'm talking like a PG student. If you look at a week, it starts with a bright Monday, with bright eyes opened up that I'm going to achieve the moon, but it ends up by the weekend with a head down on the pillow that I'm terribly tired. However, I'm flat on the graph on my achievement on the thesis work. And why this happens is because trying to do so many things, and not even trying, you have to do so many things. As a human being, everything is important: relationships, family, your thesis, your health. Obviously, you ignore your free time and your eating. And this new colorful thing which has added so much onto your volume of work, and that is the social media response and the time you need to spend on that. And then this group of people, the thesis committee, an impossibly difficult group, none of them will actually read your entire thesis, but they would have a very, very specific and important roles in your research project to take it further. So to the first part of the talk, which is on outcomes of thesis, I think it definitely has a mandatory outcome, that it creates a culture of scientific inquiry and writing into a postgraduate who is just stepping into this specialized field. So the second part, the research, the word itself sends some shivers, that it seems to be a very, very complicated and a serious area of survival, and it brings with it so many difficult terms like opportunity, idea, and earnings, and development, and innovation, experience, curiosity, and growth. And if you really sort of go deep into research and research methodology, you get into quantitatives and qualitatives, who, what, how, when, and why, and the various types of research designs. But let me tell you, all of us as medical doctors and orthopedic surgeons are researchers, and we are doing research day in and day out. It would be connected to one patient of ours, and then all the patients which we collectively treat. is there an evolution of an intellectual freedom, or if you can say, is there an evolution of a researcher? Yes, definitely. Before grad school, I'm going to research whatever I want. And then when you get into it, I'm going to research whatever my professor wants. And when I get a faculty job, I'm going to research whatever my tenure committee wants. And when I actually become a professor, I'm going to research whatever my grant committee wants. And the emeritus professor, I'm going to research whatever and rest in peace, or say research in peace. So what I'm trying to bring out is that another factor, which is the environment or the phase of life you are into, also dictates about the research. And don't forget the entity which you're trying to research. And today's time, the coronavirus, the entity itself is so tricky that it'll always put you off. And each research will only create more questions and more answers to be looked into rather than straight away a solution. So in 2020, research is about learning and sharing. It is about a question, and to answer that question, you need to accumulate data, and that data is guided by its accuracy and honesty, and the facts which finally come out lead you towards a theory. So if you have to actually solve this pandemic, you need to share your data. The simple question is how to come out of it, and only if the data is accurate and honest, the facts will be right and your theories can be applied. So one example I picked up from orthopedics. This is one recent paper on implementation of research evidence in orthopedics, a tale of 3 trials. Now, these are very, very extensive and important trials on very basic problems of distal radius fracture, proximal humerus fracture, and ankle injuries done in the United Kingdom by the Health Technology Assessment funding, as well as the NHS guidelines. And because it is very often asked that does research mean anything at the end of the day? Does it actually change your health practices, and is it really a solving game, or it's a confusing game? And these 3 trials are, real eye openers, which ultimately, as you can see in the bottom line, favored a totally different type of a treatment than uh, the treatments which were evolving in the last 1 decade. So I would summarize by saying this, that thesis is a process. It goes through phases. It is actually the introduction to a postgraduate student on the methodology of research. Publication is actually a byproduct, and it is not the ultimate goal of doing a thesis in a postgrad education program. It is to educate the PG on how to do a research. And actually, we are more than happy that we are able to churn around a good byproduct from these theses. So to encourage an optimal culture of research, orthopedic organizations in leadership positions like the Delhi Orthopedic Association need to explicitly support while inspiring and rewarding those researchers who can harvest new solutions. I think it is up to us, as has come up even in the first talk, that we need to take it on ourselves to make this more meaningful. And research has been defined as a coin with a tribute on one side and a responsibility on the other. And I'm really happy that we've had this important topic in this conference. And I can ensure to you that, as Dr. Anup has suggested, that we will note down and deliberate on what has come out and maybe try to implement it at the society level. So to end, I would conclude by saying that fate of research and outcome of thesis is almost mandatory and happens. What happens is it creates a culture of scientific inquiry and writing. And you may ask, so what? So actually what happens after this is it actually leads you back to the question which was raised, that the culture of scientific inquiry and writing actually decides the fate of research and outcome of your thesis. Thank you very much.
Thank you, Professor Manny, for such a nice presentation. Now his presentation is open for discussion. So I request any of the panelists have a question.
A small comment only. Can you hear me?
Yeah,
Yes,
yeah.
sir. Yes, sir.
Okay. The comment is that in the West, we have a research as a separate degree, and a clinical degree is a separate one. So if we, at a structural level or a regulatory level, if we can separate both things like MSc or PhD degree separate and clinical degree separate, that will make a sense. I don't know how can we help it.
You're right, Dr. Kalra. I think the PhD provision is available in University of Delhi. Somehow it has not been tapped because probably neither the guides nor the students know that it is available. So if a senior resident who is joining a rotation of 3 years, he can very well sort of do a PhD attached to Delhi University.
Manish, can I ask a
Yes,
question?
sir.
Good morning.
Sure, sure.
Dr. Mani, you very beautifully explained the intricacies of writing a thesis. My one observation, like I was sitting one of the papers couple of days back, and I think what I could gather, the role of supervisor is very important. That how to conduct and how to conclude the results of a paper, of a research. One of the researchers who presented, like an example I'm giving, a case of avascular necrosis, about 10 cases the person had done, did the code decompression, did bone grafting, then put in PRP also. And he concluded that after 10 cases, in such situation, the PRP is working beautifully well and is giving much better results than all others. As conclusion like that is become a bit atrocious. So here comes the role of a supervisor, how to conduct the research and how to conclude, make a conclusion about it. And of course, comparative studies and other things should come into it.
You're absolutely right. The supervisor has a very, very pivotal role in this. And as Alok suggested, that even the supervisors need to go through a training program, because we are fortunate the research methodology has become very structured. So if we follow the guidelines of research methodology, we are always going to be on the right path. And I'm sure Dr. Rajgopalan would comment on that. And definitely, I think the supervisor is a central keystone of the whole thing.
Hello, may I? Am I audible?
Yes, sir. Yes, sir.
Okay. Dr. Lalit, very well presented. I fully agree with you. Thesis is basically just to guide postgraduates how to do research. And byproduct may be there, may not be there. But if I also support the point of view of Dr. Sharad, that it is supervisor which has to be deeply involved into that. At each and every step, he has to guide the students. But one thing I just want to, I realized that in all the researches, most of the time, we always say result is good. I think we must learn to say when result is not good, we must learn to say that this method is not good, and we must learn to put our point forward. In the research also, in the thesis also, or in the paper also. Or most of the people always say whatever I have done is the best, is the good. But it may not be always. So we should learn to say the truth every time. Whether it is good, it is bad. Something is not good, I think it is more important to say rather than something is good. Because we must tell people that this method is not good and it may not be attempted. Thank you.
Very right, sir. Very right. I think negative research was never understood. And suddenly everybody understands, because we started with ventilators in COVID. Then we went with antiviral drugs. Then we went with plasma. And now we have realized the role of negative research, meaning that the result is a negative one and it doesn't have a role. And people have understood that it needs to be published so that people are told about the right path.
Dr. Maria, please. Dr.
You're not
Maria.
audible, sir. You're muted.
Sorry. That was not so that I don't disturb you, basically. But what a fascinating talk, Dr. Mani. Now, some of my things are that one, research, I feel, is the ultimate, evolution of an academic. After learning, after observing everything, then the person goes to add or contribute to the subject in a positive or negative manner. And research, what we should be understanding, should be investigative research to try and find out. So it should actually be a search. Research is that you know something and you're trying to see it again, but yes, it's a new search. Now, everybody is not a born researcher. People are, what we are doing with our thesis perhaps is we are giving a topic more often than the student asking for something which is interesting him or what he's trying to go into. Exceptions are always there. So what happens is, God knows how much deep interest is there besides completing the decorum. I feel that things like what we just spoke earlier, audit, if we are to give them something to look in, then we have broad shoulders and say, okay, go and research the work that we are all doing without naming anybody, and please find out what can we improve or correct. That is the research, rather than saying that a fracture of this kind should be treated this way. We will then have this thing to say that since so many fractures of this kind were treated, so many things didn't go right. And finally, I feel there should be a specific reward for people who spend extra effort, extra time doing research. Well, now, reward cannot be just, it has to be in a direct evolutionary pathway or a promotional pathway or something like that, because the effort put in research and the time put in is far more constructive than the results of going and doing 2 surgeries in the evening.
Dr. Arya, any comments? Otherwise, we go to the next speaker.
Just wanted to say that Dr. Mani has started a point saying what part of the life supervisor got involved into this thesis, at the beginning, in the midway, or at the end. I mean, just like to highlight, when the first thesis comes to a supervisor, he's very enthusiastic. He actually takes a lot of interest, and it is not the thesis of the student, it is his first actually. Then comes the midway, when it becomes a routine part of his life, and he gives some interest but not much time possibly, and at the end he is done away. He doesn't take. I think that is one. Second thing, PG is doing research in which institute, which area, which geographical area, also fact. Like people in a most busiest hospital where he doesn't have a time, he damn care about what the PG learns from the previous year students and write. And in a most academic institute, he learns from not only the colleagues, from the professor, from the others teacher in the department. And the same thing in the otherwise. I think as an institute, we should allot thesis to only entrusted supervisors. Second, PGs also should take adequate interest. And finally, ethics. Ethics are very important, as everybody is stressing again and again. The result should not be modified or should not be actually touched. Whatever comes should be explained in that perspective. That is all I need to comment. Thank you.
Dr. Hitesh Lal has raised his hand. Dr. Hitesh?
Yeah, yes. The problem with thesis today is the time period is too less. Why the theses are not converted to publications is because the follow-up is less than 1 year. And each and every journal asks for 1 or 2 years of follow-up. So I think the thesis time period should be increased, could be to the first half of the third year, start from late first year. It should be increased so that the candidate has at least a 1 year follow-up. That is why the student takes less of patients and the follow-up is less. So they don't get converted into publications.
Hitesh, can I comment?
Yes, sir.
In DNB programs, I think what you said is implemented. I think in our MS program in our university, this is what the status, what you are trying to say. In DNB, I think almost like 1.5 years is given, or rather 2 years are given them to write.
Manish, can I make a comment?
Yes, sir. Yes, sir.
Thank you, Manish. I completely agree with what Dr. Sharad said, that the role of the supervisor is going to be very, very important. And the good thing is, in the last few years, becomes mandatory for the faculty. General knowledge has increased a lot, but still, many supervisors do not really unable to guide the student properly with the methodology, and that's what the most important thing. Most important thing in a PhD thesis for a postgraduate student is the methodology, and that they are not able to guide. I totally agree with what you said. And quite often, when you see some of the thesis, it is the conclusion is totally not relevant to their aim or is not proper methodology. I think, but this is improving. That is the one good thing. Thank you.
Okay, I request Dr. Vivek, sorry.
Dr. Manish,
and,
just last comment. What Dr. Hitesh said, that the time period is too short. Is it possible to have an ongoing research in a department? And if each PG who comes done a certain segment, and end of the say 4 or 5 years, there could be a consolidated results we have, which can be presented, including all the researchers over the period. Can that be an ongoing research in a department?
Can I answer that, Manish, if you don't mind?
Yes, sir. Yes, sir.
I want to stress this. Sir, about, I think it's more 10, 20 years back, I had put up there was a MCA meeting where I was there. I suggested that the first and foremost thing is, like Alok said, the 3 years is not enough. You have to have more period, at least 6 years minimum, when this can be done. This can be kept away from the exam. In the present system of 3 years, there's hardly any time to increase. Thank you.
Okay, Dr. Vivek, please, because we are falling short of time. Can you invite the next speaker and introduce him?
Yes. I may invite Dr. Ashok Shyam. He is a well-known name to almost everybody now in orthopedics in India. Dr. Ashok Shyam, sir.
Hi, good morning, everybody. And to begin with, I'd like to thank DOA and Doacon for inviting me to speak on this topic, which is like my first love, research. So today my topic will be on case report, my first publication. Since this is a PG section and Dr. Mani already spoke about thesis, I'll also recommend that writing and publishing a case report should also be included as a part of mandatory research for PG students. And it will serve a lot of purpose as we go on with my talk and we see. So this is my disclaimer or my conflict of interest, also being the founding editor of JOCR since a decade now. So let's begin with the historical aspect of how the research developed. And as we believe, and it's true even now, that careful men note what is generally answered better and then begin the same to their patients. So this was in way back in more than 200 years. And so it has served us for a long time, the same observation and same thing. So this is what case report is actually. These are observational studies, careful observations, clear recorded descriptions, and deductive reasoning. I think this forms not only the basis of case reports, but any medical research. And it is also the basis of all our experience or experiential learning, as we call it. I'm sure you all know the story, the tortoise and the hare. Okay, so this is what I call as an ideal case report. Very clear and precise, easily recalled when needed, and strong practical message. So I think this is the best example of a case report, how it should be written, how it should be appealing to the reader, appealing to the editor and the reviewer. It should be simple, strong message, and easily recalled. So getting your first publication, getting started. So I recommend that most of the people who are starting their research or even starting their thesis career, start with a case report. There are a lot of things about writing, about submitting, about review of literature gets cleared by when we are doing and writing a case report. So first question that arises in mind is what qualifies as a case report? Are only rare cases accepted as a case report? I think most of us now understand that this is not true. And I already wrote a editorial on this point. So the point to stress is that any case that has a clinically valid learning point is a case report. So that's what my definition of a case report is. So you need to ask the question whether publication of this case will enhance the knowledge of reader and help them provide better treatment to their patients. So providing better treatment to their patients is the basis of all medical research. We do research to do this, provide better treatment for our patients. And if the case report publishing will help in this point, then that is a publishable case report. And this is the first key learning point of this lecture. So you need to establish the clinical relevance of your case before you go ahead with anything. So I'm sure most of the PGs or most of us working in clinical settings have a lot of challenging cases. If any of your case answers this question as a yes, that should go ahead and we should go ahead and publish that. So what qualifies? Very rare diseases, associations of diseases, uncommon presentation of common diseases, cases which contradict current knowledge. So these are like the general bag of what qualifiers that is given in most of the websites and most of the journal guidelines. So all this are there as the qualifiers. But for orthopedic surgery and specifically surgery, there are few more qualifiers. Improvisations in decision making, intraoperatively, and in rehabilitation, even in a single patient, provides a lot of insight. And complications, specifically complications of any case, I think should be published because there is no clear-cut guideline to deal with complex complications, and these needs to be published so that people know. So I have a dictum for that called DIC points: deviations, innovations, and complications need to be published. So those are all qualifiers for a case report. So I've been asked this question very, very often. Hey, editor, I got this great case. Is this publishable? So in a conference or when people just meet me, they just ask this question because they know I'm the editor for JOCR. And it's a very difficult question to answer just offhand. Of course, I go through the case. I tell them, okay, this is good. But what will answer this question? If you have this question, me as an editor or anybody as an academician often cannot answer this. What will really answer this question is literature review. So you need to do a literature review to get an answer to this question. So key point 2 is thorough literature review. And after the first 2 points, you need to, once you establish the clinical relevance and you did a literature review, you start writing. Now, this is the structure of a case report, which is a standard structure: abstract, introduction, the case report, discussion, conclusion, and clinical message and references. Of course, you can find this in any journal guidelines that are there. I'll just give out basic points on this content writing. These are actually accumulated over years with my experience of writing articles and getting a lot of rejections. And so this is like a summary of those, what points to be included. So what is an abstract? Abstract is a brief summary of your case report. It is to attract attention. So most of the time people will read your title or your abstract only. So you need to attract attention through your abstract. Introduction is background information and why the case is being reported. I think this is, introduction is one of the biggest misnomer in clinical writing in manuscripts, because people misunderstand it as introduction of the subject and go on writing about the subject. It's not that. It is actually justifying why your case or why your study needs to be published. So introduction justify it is whether it is worthy of reporting. Then this is the review of content, how you write the case report. You have to give all the details so that the reader can construct the entire case in his mind and knows everything about the case, and he can even make his own decisions about what he will do if similar case presents to him in his clinical scenario. Anonymize the patient as much as possible. Avoid names and initials. Tables of other authors. Tables and results possibly compare and contrast with literature. I always ask in GOCR to provide us with a table of comparative literature, maybe last 5 years or last 10 years. Photos of clinical science, surgical pictures are very, very essential. So discussion has to be focused on the main learning point. So in the beginning, we established the clinical relevance. So discussion is the part where that clinical relevance is highlighted to the reader, to the reviewer, and to the editor. So that's the part of discussion. You have to compare with existing literature, synthesize your own experience with evidence. So case report is actually a very good balance between experience, personal experience, and evidence. So this is the part which actually at the cusp of both and balances both and conveys a very good message. Do not write a book chapter. This is one of the major things that I've seen about discussion. People go on writing it like a long question in a theory paper. References should be recent ones. Incomplete literature review is one of the most common cause of rejection, especially in case reports, but even otherwise also. Literature review is the foundation on which all your research is built on. Focus on your literature review always. Key point 3 is to follow the journal guidelines. You have to be very, very thorough with how the journal wants you to format the article. And it's one of the common causes of rejection. So you have to go through it, read it properly. I suggest that you read 4 or 5 articles of the same journal, which are published in recent issues, and formulate your paper. So after you have written your paper, what next? Get help, second opinion, third opinion. You need to send it to your colleagues, send it to your guide, your mentor, your research group, whoever is involved, whomever you know is good in reading, writing, and publishing. You need to get their opinions and it's like an external review that you do before submitting. So last advice is read and revise as much as possible. You need to read all the published case reports on your topic. Read at least 10 case reports in different journals. Think about why they were reported and how the author got the message across. See, this is very important because case reports have 1 or 2 important messages and you have to give it across. Okay. Ethics in publishing even apply to a case report. You have to have a consent. You have to consider privacy laws, and you have to have the confidentiality in place. If possible, deliver a copy of published paper to the patient or relative. I mean, they feel happy, and I've done this few times, and it's really great. Common pitfalls: using sensational languages, writing is as a theory exam short note, unnecessarily trying to establish the rarity of the disease. This is a very common practice. So this part is reported only 10%. Out of this, one part is reported only 2%. You don't need to establish the rarity too much. I mean, don't focus on it too much. Like I said, clinical relevance is the selling point for case reports. Not reading enough, not doing enough literature review is one of the very, very common pitfalls. In summary, the key points are: establish the clinical relevance of your case report, do a thorough literature review, follow the journal guidelines, and read and revise. So every case is a potential case report. Like Raju Vaishya sir was saying, surgical audits. I'll go ahead and say that each of those cases is a potential publication, either as a part of a case report or a part of a case series or a part of a randomized trial. So every case that you see in your clinic, in your hospital, is a potential publication. Case report may be the beginning of a glorious and successful academic career, and I'll suggest all the postgraduates to start with the case reports. Simpler to write, and I mean, it introduces you to very good research concepts. So thank you very much. Tell your story in a best way. Thanks a lot.
Thank you, Dr. Ashok Sham, with an excellent insight into reporting a case report. Since we are running already out of time, we are 2 lectures behind. We may club discussion part later on with other lectures.
Sure.
Thank you. So may I now invite Dr. Rajgopalan Iyer. He will elaborate upon how to choose a subspecialty. Welcome, sir.
Yeah, I'm going to share my screen. Good morning, everybody. Am I audible?
Yes, sir.
Okay, good morning, everybody. At the outset, I'd like to thank Dr. Dhananjay and DOA for giving me this opportunity where I could get so much information from the colleagues who have already spoken. Now, I have been asked to talk on how to choose an orthopedic subspecialty. At the outset, let me make it very clear that when we talk about a subspecialty, our aim is that we as orthopedic surgeon, whichever subspecialty we take, give the best evidence-based treatment for each and every patient of our own. So in that way, all specialties are equal. There is nothing which is better than the other. So whatever I am saying in my further talk is only a evidence-based literature proved incidents of opting by the various residents of the whatever published places. So it doesn't mean that one is better than the other. I think all are equally good, equally interesting. So I am supposed to tell the residents who are finished, who are doing this in residency, or even a consultant, how to choose a specialty. Now, one thing is, this is difficult because the whole thing is evolving quite fast. When I finished post-graduation roughly 40 years back, there was no concept, at least for me. Today, every postgraduate who finishes wants to do a specialty training. Unfortunately, it is not as easy as choosing which shirt you want to wear today. Today, now, the fellowships have definitely increased, subspecialty is also increasing, but the postgraduates also increased. But what are the factors which influence, what has influenced somebody to take specialty is still not very, very clearly understood. It would have been much easier if I today want to choose, I can decide what I want to do, have a committed experience in that and succeed. That would have been very easy for the person choosing. Unfortunately, it is not. And even if today I finish my senior residency and I want to choose, I get everything I want, even then I may not know what to do. It is not easy when everything is available too. This is because each of us have that right to change our opinion. The first joint replacement, I want to be a joint replacement person. The next scopia I saw, no, that is better. Then I saw a spine, I think that is better. This is something which happens to all of us. So that factor is there. So it is not easy to choose when you have, this is not a complete list. There might be something I left out. There are some things new. Spine can be a pediatric spine specialty, adult spine, adult hip, pediatric hip, so many. So this is not all inclusive, but just give an example. In this, to choose something is not going to be that easy. So I have taken some where we have some published data. This was an article just a year back in JBJS, where they had looked at the factors which influence the residents, fellows, and even some consultants. Let's see what we can gain from them. So this particular one, the maximum choice, as you can see there, the initial top of the list were sports medicine and arthroplasty. And the bottom of the list, leaving out those who are undecided, is oncology. Surprisingly, shoulder and elbow was just above that, but oncology was in the last. What is very interesting, if you just go back by 8 years, in 2011 JBJS, in a study in a totally different part of the, compared to the previous one, it showed almost the same thing. The sports and sports medicine and arthroscopy, probably, that was inclusive one. That again was the top of the list by joint replacement. Again, oncology was in the bottom of the ladder. And the foot and ankle came down, shoulder went up. That was the report. So 8 years, it has not changed much, which indicates that particular group of people, wherever they had done the study, the things were similar. Now, if you look at a person who was already say, I have finished mine, I have taken 2 fellowships, I have seen joints, I have seen spine. Now, what do they feel? That will be very interesting because he has already seen more opportunities. Let's see what happens. This is the same publication. There, they said they chose that, or they think that that is better, mainly because the surgical variety. Let me say, if I take spine, I probably have so many surgeries to do, different type of pains. That may be the one. And second thing, very interestingly, because you are finished, was the job opportunities. And quite surprising for me, the salary came up right up to the bottom. I don't know whether it's realistic in our scenario, but that is the way it was. And things like location and mentorship and prestige. I suppose something like one-upmanship, we'll come to that later. So the volume and variety of cases and reputation of the program, it seems to be important to a group who has already done. There was also in some other studies the personal interest. I mean, that is definitely, I would have thought of higher, but personal interest and diversifying my subspecialty area. These were also some reasons. Now, if you look at this particular article, where you have the volume and variety, this is also for same study, volume and variety, what came down into a single digit is research opportunities. Now, we know that we don't have a separate specialty as research, but there are universities. One of the best example I can think of is the McMaster University in Hamilton, fantastic independent research institute, a specialty of its own. But every specialty has a research opportunity. That is what is meant here. That was not given, unfortunately, importance in the data collected. Whereas surgical independence was an important factor, which is understandable. Every fellow who decides, who comes and asks me, who discusses with me, they only ask question is, if I go to this place, how much cutting I get. So that is one of the factors. And mentorship came a little lower down in this one. So if I had actually gone through quite a few articles, including Kovalas and there are others coming up later, there were many factors. One of them is market pressure, which I really don't want to go into that. But the improvement of surgical experience, clinical experience, excellent outcome, all these things were important, including what I meant by outcome is they are talking about prognosis. Does that decide a person? Yes. One of the colleagues I spoke to said he was first interested in spine. He worked in spine. He found that so many patients don't improve. So he switched on to arthroplasty, prognosis better, every joint, such a good outcome. So these are some of the factors which also were reported. So if you put all these things, whenever somebody asks, I always ask them, do you have a special interest in anything? And one practical problem, is it possible? Because the number of areas to get is more difficult. Then I told about all these things. Colleagues' advice, income seems to be very funny. In some of the articles, some of the people, they keep the income very important, but some has given it as low down. In publications, that become low down. In practice, probably that becomes higher. And things like working hours, particularly we'll come to that later, somehow even there's a gender difference, the working hours makes a difference. Professional upmanship, that's what I said, it is the way it felt. In practically, I suppose everything is the same. So there's another article from a little different area. So there they found that the surgical experience and autonomy was much more given important than research resources and income. So this was a publication entirely about foot and ankle fellowship. That had a totally different result. Most of the fellow people whom they interviewed, they said they chose this particular specialty only because the relationship between the consultant and the fellow was the best. I suppose that is very, very important, but this was a thing found only in foot and ankle fellowship. That's also something that we have to learn, that is probably because of the good mentorship. This is from Saudi Arabian one. Why I have included is because their working conditions and their things are totally different from the other studies which were from the Europe and the USA and that area. American continent. So in their studies, you can see the highest was pediatric orthopedics, totally different from others. And second was foot and ankle, third was joints. And sports and oncology were in the least. Sports was 7.3%, oncology was 0. The explanation given by the authors were that probably there were no oncology infrastructure there. And the other reasons were there according to the infrastructure. Whatever be that, it was totally different. So if you take most of the studies, if you combine, sports medicine seemed to be the most desired specialty, oncology the least. This is what the well, some abstract view conclude that appear to be like that. So what was the reason for this? Probably those who preferred the sports medicine were more influenced by the outpatient surgery factor, because these articles were all three were from JBJS, an American edition. So there arthroscopy is mostly, so that may be one of the reason. And second was about the oncology program. The oncology program being the last is mainly because you need the infrastructure that comes in an institution. So those who were interested in academic practice were the only people taking it up. Pediatric orthopedics, probably the conclusion was that those who think of that, they are not worried about the outpatient surgery facility and altruism and similar feelings probably why they prefer pediatric orthopedics. Gender difference, I think we all know the number of female gender in orthopedic subspecialty is comparatively less compared to the males in all over the world. But in the study published from there, what was interesting was when you apply for a subspecialty, the matching rate for a female orthopedic surgeon was almost 99%, which was much, much higher than the main applicants. But the total trainees, almost 85% were males. So this difference is probably because maybe I'm not, this is what again they have commented in this particular article, that probably they were thinking of more free time, so that probably less duties, lesser working time. This may be the reason why some of the female orthopedic had chosen hand or pediatric orthopedics or sports medicine. Other motivation was personal satisfaction and interest stimulation. So the last about this, some of the participants was mentorship. I think this is where we came with the supervisor, which we talked earlier. Like in research, in everything, mentorship is probably a very, very important factor. In some of the published data, that was given a good percentage, but not in the top, somewhere in the middle. And second interesting thing was, as a consultant now, if I think what I want is totally different from what the resident who has just finished his postgraduate, that is different. The resident thinks most important is where he can have, they took the importance of the prognosis and surgical chances, things like that. Whereas the person who's already experienced both, he was talking about where, specialty where the lowest was the lack of competition. That meaning that he was looking at getting a job and things like that. So when it comes to that, when it comes to look at a job and career, it's an income deciding factor. This was an article published in 2012 JBJS, where they looked at how the medical students choose orthopedics as a career. So even though that is one of the high income group there, I think so, they said that income is not a deciding factor. So at the end of the talk, if I'm going to choose now, after almost 45 years since I entered orthopedics or more than that, I think first thing I can think of is what I want to do. What is my career setting? What I want to do? I want to be in institute, if I can decide about it, or I want to enter into a private multi-speciality hospital, or I want to be individual practitioner. I think that should decide where you want, how much independent you are going to be. And second thing after that is the people who are going to train me. How good, I have a good mentorship program, have educational opportunity, how much variety of cases, and what surgical independence I get, how much I learn to do. So the top two factors to me seem to be that, including all other factors, is when you choose a subspecialty, among the other factors mentioned, surgical variety and job opportunities, But when you choose a particular fellowship program or when you particular institute, you think of a volume of variety cases and overall academic reputation. But as my last slide, before I conclude, these are all some of the conclusions I have drawn from whatever literature I could get. And it is up to you when you choose to draw make it from this particular insufficient information I have given. You should have the art of drawing sufficient conclusion from whatever I have given, as said by Samuel Butler, who is a famous English author. Thank you.
Thank you, Dr. Rajgopalan. Uh, because of shortage of time, I think, Dr. Vivek, you agree that we should go to the next speaker? Dr. Vivek?
Yeah, because the other two lectures will nature to previous two lectures. Yes, yes.
Yeah.
Am I audible?
Yes, sir,
Since
yes, sir.
the other coming two lectures, they are similar in nature to previous two lectures, so we can take all discussions later on.
Sure.
Okay.
All the four
Now
talks.
Sure. Now we invite Dr. Raju Vash for his presentation.
Good morning, friends. My topic is slightly off the line from the theme, but it's quite relevant. As an editor of a few journals, I have noticed, and most journals have experienced in the recent past during COVID time, that there has been a surge in research and publication, which is a good thing that has happened. And that has really ignited the researchers to come forward with their research for publication, which was pending for quite some time. But from the editor's point of view, it was a tough task to deal with enormous increase in the numbers of submissions that were happening especially during the lockdown period in the COVID time. So the surge is like a strong wave-like forward movement that rushes and sweeps everything, and that was happening in the field of research and publication. The causes could be divided into pre-pandemic and pandemic time. In pre-pandemic time, PubMed had made a significant impact on researchers to publish because it is considered to be the gold standard. If you have a publication in PubMed, your reputation and your recognition definitely increases. Then advances in information technology help researchers to access the research material and to do publication much more easily than what used to be in our times 30, 40 years ago. There has been, therefore, increased research, increased researchers, increased enormous number of journals across the world in all specialties, and number of institutions and research labs that have been increasing. But in the pandemic time, there has been an urgency for the information about this disease and the virus. So there was a need for information on this crisis, and hence everybody got into gear to find out in their specialty what has been happening. There was an urgency, there is still for the solution to their problems and about this disease. Therefore, most of the publishers have actually instructed their teams to fast track all the manuscripts that come for COVID, and that has made a very early publication of any accepted COVID articles. And whether your journal is indexed in PubMed or Scopus or not, they would accept COVID articles on their platform. Priority for publishing COVID articles was therefore certainly there during COVID time. But because of this surge of publication, a lot of imbalanced publications also got through relatively easily through the net, which were hardly read by the readers, and they may not contribute much in future in way of publication. In the Journal of Clinical Orthopedics and Trauma, we have seen a significant surge in the submissions. As you can see, we had the first lockdown announced on 25th March until 31st May. So you see the graph in orange shows submissions compared to 2019 in the same month. There have been almost 2 to 3 times submissions during the peak of the pandemic, which is now the rate of submissions have been decreasing to sensible limits. So we had almost more than 4 submissions per day compared to around 2 previously, and we had published quite few number of articles. COVID had a positive impact, highly positive impact on the research and publication. And the main reason was the lockdown, I feel, because people were forced to stay indoor in their houses. They had this opportunity of looking back on their own work, on finding new research areas and do the research and publish it rather easily than going to the hospital and doing their clinical work instead. So they had spare time to finish the pending jobs. Then there was a peer impact because a lot of publications were happening. So people were sort of indirectly forced to do the research because their colleagues have been publishing. And every one of us has a deep desire to publish. And this was the COVID has given us the opportunity to do so. Plus, there was initially an increased acceptance by the journal, especially of the COVID-related article, and faster also. And there was a rapid editorial and publication process. This has slowed down in recently. I will come to that later. Our Journal of Clinical Orthopedics and Trauma also published and received a lot of articles related to COVID and orthopedics. And now we have almost 140 articles that have been submitted. We accepted about 1/3 of these and published. And all these articles are now available in our website, COVID Resource. The significant thing about COVID-related article is that high number of citations that they have received in a very short time because of a lot of urgency to publish and a lot of information to publish because of this crisis. So we have received a lot of citations on these articles. We have also published our own experience of analyzing the data of various journals through PubMed and found that the medical literature has responded almost as quickly as the spread of this virus. Actually, it matches. The orthopedic related articles were mostly published in the American journals of bone and joint surgery and JAJS. But we also published plenty of articles in our journals, and the JCOT has in the top 5 journals that are published on COVID and related orthopedic problems. So friends, there have been an infodemic of publications in the recent past. Infodemic may be a relatively new term for most of us. It means an excessive amount of information concerning a problem like COVID, such that the solution is made more difficult. That's an INE, because a lot of things are being repeated or being presented as personal experiences, etc., which may not be true or applicable everywhere. So this pandemic has given us the opportunity to publish on this crisis exorbitantly, and most journals have seen an exponential rise in new submissions during the peak of COVID, which I have also shown you in a chart, in a graph. But it would be, and we predicted that, it would, however, be interesting to see if there would be any reciprocal future dip in submissions, because all these stocks of your data research has finished, and that will lead to decrease in submissions in future. That has been happening now. So what I noticed that we have been receiving, what were the type of publication submissions that were receiving during COVID-19? There were, of course, newly conducted research or reviews, especially on COVID. The researchers which have done research in the recent past but could not submit because of lack of time, waiting for submissions. But the last two groups were also there. The older research, which was pending somewhere in their database, waiting for submissions, and because everybody was publishing, so I must also publish, was also there. So a lot of people digged out their old theses or research work, 10, 12 years old also, trying to publish it after so many years, and hence all the data and information was outdated. So how did we, as an editor, have to deal with such increased submissions? The most important thing is screening of submissions before sending it for reviews or to associate editors, whether it's out of scope of the journal, are these data and information outdated, or the authors have been sending repetitive messages through their manuscript, which has already been published many times before, or there is no quality or relevance of their information or research in the present scenario. So a lot of desk rejections need to be done to control this surge in publication. And the editorial process has to be quick because the data related to especially COVID becomes outdated within a week or so. And hence, if you really want to help your journal or the author, the decision, positive or negative, should be taken pretty quickly. So early review process and decision making is very, very important. The role of editor-in-chief is very important because he is sitting in a hot seat where he is getting so many submissions. So his role should be higher than normal, and he should be proactive in taking decisions and delegating the submissions for review and editorial process. So you increase your reviewers database, recognize and empathize with the reviewers and editorial board members because you're putting them under stress by giving more work. And also the journal office and managers during COVID time have reduced because of the disease and other reasons, but the work has increased. So you need more support from the journal office and managers during this time, which we got through our publisher Elsevier, and we are very happy that we could publish 11 issues instead of 6 issues in 2020. So the implication of this surge is that there is a flood of information that is coming, which we may or may not be able to cope effectively. And most of the submissions may be missing important evidence. So we need to be very strict that we filter out good research from the bad research and do not allow the bad research to get published because of COVID time. And so stretching of coping mechanism must be there. We have to reduce the burden of overload of submissions by identifying high quality publications. As we know from the higher level of hierarchy, evidence article must be published, and single case reports and other things which may not be that relevant. So data from randomized controlled trial, systematic reviews, and meta-analysis take the precedence over the lower hierarchy evidence submissions. Now, what has changed since the lockdown, that there has been a decreasing in submissions rates. Non-COVID submissions have started to increase than the COVID articles now. And there has been increased rejection rate of COVID articles because primarily most of the COVID articles that are coming now have repetitive message which have been already published by many authors in several journals before. So there is nothing new to add on. So there is better hierarchy and quality research papers now started to come. And now we are reaching to a normalcy, or you can say a sanity of submissions with reasonable control. So to conclude, we know the saying publish or perish, which is true, but as has been mentioned before, publication is the end product of any research, and that must be achieved by all authors. And hence, publication is very important. There is always a deep desire amongst all of us for a publication, which is a good thing, and that should be harped on even after COVID has gone. We must find time to do that. There are, of course, several hindrances and obstacles that are present in this journey. But once you start writing and publishing, and if you publish a couple of articles, then you know the art and it then becomes easy. COVID-19 pandemic has contributed significantly in developing interest in the research and publication. It was also mentioned by Professor Lalit Mani, the editor of IJO. Editors, reviewers, and the journal managers have got an extra work or burden on their shoulder in the recent past, but they have no choice. And now things are coming back to normal. We have already crossed the more stressful time, and now we are coming to the real world. Thank you very much for your attention.
Thank you, Dr. Raju Vash. Dr. Vivek, please invite the next speaker.
Okay, may I now invite Dr. Anup Agarwal. He will be delving upon fellowship and training opportunities in this COVID times. Thereafter, we may take few discussions part. Dr. Anup Agarwal, sir, please.
Thank you, Dr. Vivek. My screen is not sharing.
What problem you are facing?
It's not sharing.
No, you had opened your presentation in the background?
I have.
Okay.
Sir, you are using Mac or Windows?
I'm using Mac.
Okay, then what you are getting on the screen, sir? There is some sort of desktop 1, desktop 2 sort of thing.
Sharing desktop 1.
Okay, that's good. तो डेस्कटॉप 1 पे सर नीचे आपका जहाँ पे पीपीटी सेव्ड है सर वहीं चले जाइए सीधा. वो डेस्कटॉप 1 के बाद तो आपका मेन डेस्कटॉप खुल गया होगा.
I can't see that it's shared. My PPT is already open. Actually.
Yeah. No,
PPT is already open.
Sir, close the PPT, put it on the desktop, and then share the desktop 1.
Okay. I have closed. Now I'm sharing desktop 1. Can you see my screen now?
No, sir.
No.
Sir, can you unshare it? Just do it.
It's not shared. So how would I unshare actually? Share computer sign
on your side actually.
Timing, what we can do till Dr. Anup Agarwal is setting his screen, we can take one question.
Manish
Yes,
sir, by that time you continue your discussion.
Yeah,
Can
yeah,
I-
we can take it. Yeah.
Can I comment, sir?
Yes, sir. Sure, sir.
Actually, the case report part presentation was excellent by Dr. Shyam. Just I want to make aware of the House new regulations by the NMC regarding medical colleges. They have come out with a regulation that every postgraduate student and a senior resident should have one national publication or international, national presentation, and a national poster presentation. These three are mandatory in all inspections now for all postgraduates and to appear in final exams. I don't know whether colleges are implementing or not, but these new regulations are there with every college now.
Dr. Mukesh, nowadays it is very difficult to say national or international journal because all journals are now international.
Agreed, but the problem is these
So
are
if someone is publishing in IGO, it doesn't mean that it is a national journal. It is an international journal.
these are the wordings of the regulations.
I think this needs to be changed actually.
Anyway, it is not in my hand.
No,
but
no,
they
I
have
know.
come- they have come.
Dr. Lalit may put it in white paper. This is wrong.
NMC, they have done it. Another one is this regarding choosing a subspecialty. Just I want to make a comment. I tell you very honestly, I was a flute player and I got 20 rupees in a radio audition.
Yeah, Anup sir, now it's coming, sir.
Okay.
Anup sir?
Dr. Mukesh, you can complete your comment.
So I was telling you that it is 20 rupees I was getting in audition. So that was not the point. Why should I choose that where I don't get a bread and butter?
Right.
So the point was I choose my parents forced me to become a doctor, which I never wanted to be. Then the choosing a specialty, subspecialty was the same problem. So in India, we have very little options. The first comes is the bread and butter. That's all. Thank you.
Thank you. Now I request Dr. Anup Agarwal to carry on with his presentation. Dr. Anup.
Thank you. Thank you, Dr. Dhananjay, Dr. Hitesh, Dr. Manish Dhawan for inviting me to Doacon. My talk for today is fellowship and training opportunities. What is happening?
Sir, just click on the slide. Yeah.
Yeah. Okay. So I have taken a leaf out of Dr. Alok's talk that what are we actually missing in postgraduate teaching? It has a direct impact on the fellowship training, why it is required. Communication, data keeping, research, clinical skill, and surgical skills. These are the points which we actually missing during our postgraduate training. So do these points can be covered up during fellowship programs? So I looked into, is there any study which talk about the fellowship program, how it is happening? So this is one of the study which was done in Department of Medicine in Canada, where they talk about fellowship training, a qualitative study of a scope and purpose across one department of medicine. And they concluded that fellowship serves as a variety of purpose which benefit both individual trainee as well as the academic enterprise. And fellowship can be categorized within distinct categories. It could be individualized, it could be clinical, it could be research. So they also concluded with reviewing the different fellowship program and talking to fellows that what are their purpose actually. So their purpose was to increase the clinical competence, increasing their confidence, to gain a specialized skill, and very important, acquisition of marketing skill. This has become the key story for many of the young surgeons, and pursuing an academic career was the last. So perhaps our fellowship programs which we all are running does not cater to the need which is required for all the fellows and for the research. And that is what we see when we look at the fellowships. The research fellowships are the least one which are opted out by most of the fellows. So we all know word is one, and we have about 1,000 fellowship and training opportunities all around the world. And out of that, half of in India. Now, these are approximate things. There are nothing collective data which is actually available. And if you look, there are about 200 state chapter fellowships in India, and there are about 250 private institutes which are offering fellowship and training opportunities. And amongst us, the Indian Orthopedic Association is one of the leader, and that provide both international fellowships and national fellowships. And what we have done as the fellowship committee is that in 2017, we had only 28 fellowships. Then in 2018, we increased to 34. In 19, we increased to 51. But COVID had as its own impact. We were planning to make it 17 2020. But since many of the fellowships could not be completed in 2019, so we did not think about it increasing it this year, because we have extended it, and this year we are not offering any new fellowship. This is what has happened during the pandemic. So this is the offering from Indian Orthopedic Association, and these are the fellowships which are international fellowships: IUA Orthoplasty, IUA Singapore, IUS UK Junior, IUA Hong Kong, IUA Malaysia, IUA Turkey, IUA Korea. All these 7 fellowships are for less than 45 years of the age. So these are for the younger fellows, and these 2 are for the senior fellows. So we do have fellowships for more than 45 years. They are UK Senior and IUA Ireland. So these are the international fellowships which are available through IUA. And then we have IUA Inland Fellowship, that's the national. The N number on the left side, these are the fellowships: Dr. S.S. Babulkar, Dr. G.S. Kulkarni, IUA Traveling, IUA JMRF Pediatrics. These are the one of the most wanted fellowships. But if you look on the right side, the Panacea Biotech Research Fellowship, Research Grant for Implant Instrument, Dr. Ashok Sen Gupta visiting, and Orthopedic Research Foundation. These 4 fellowships, we hardly get any applications during our fellowship program. So what we lack is that most of our fellows do not want to go into the research. So we hardly get 1 or 2 applications, or maybe we don't have any applications for these research fellowships. Then, so that is a point of concern for all of us. Then other fellowships which are offered by IOA are UA mentorship and senior fellowships. There are about 10 senior fellowships and 30 UA mentor fellowships. Senior means more than 45 and UA is less than 45. I need to tell you a word about IOA UA mentorship program. It's a wonderful program which was started by IOA 2 years back only. And this is only for the younger people. It's a simple program. Suppose any person, any PG, any resident wants to look for an orthoplasty and he wants to get a train under Dr. Raju Vaishya or Dr. SKS Maria. So he need to contact Dr. Raju Vaishya, fix up his program 3 to 4 weeks, and then he need to inform the IUA office, and we can then coordinate with the mentor and the fellow, and this program can be conducted. And every year these 330 fellowships, and we had this year 54 applications for this. So this is one of the most hit fellowship. Again, all these fellowships are for the surgical and clinical skills. None of them are for the research. Then there are other fellowships which are offered by different Indian associations. These are Indian Orthoplasty Association. They offer 5 international and 3 national fellowships. These are again wonderful fellowships. The international fellowships which are offered by Indian Orthoplasty Association are Indo-UK, Indo-Irish, Indo-Australian, Indo-Korean, Indo-US. All these fellowships again are very sought after. All these are for less than 45 years of age, and most of these are finalized during the November, and application start during the month of the April. Then Indian Orthoplasty Association again give you the national fellowships. These are 7, 2 Dr. K.T. Dholakia, 2 IAA Chennai, and 3, 1 at Delhi with Dr. S.K.S. Maurya, 1 at Chandigarh at Max Hospital, then another at Jaipur. So these are the fellowships which are offered by Indian Orthoplasty Association. Then another subspecialty society, Indian Arthroscopy Society, it provides 10 fellowships every year, 3 as CASSM International Traveling Fellowship, 4 as National Fellow of Dr. Gopal Krishnan, and 3 IAS CSM National Fellowship. All these fellowships required for the person to have a minimum 2 years of experience of arthroscopy before they can apply. And all these fellowships are for younger people less than 45 years of age. Then we have few international common and very sought after fellowships. The CEQUAD provide 50 fellowships every year. You can see the whole chart: Alexandria, APOA, then APOA, EOA, Hiranandani Orthopedic Education, APSS, Asyut University, Casablanca University, Ganga Hospital, our Indian hospital, HKU CEQUAD fellowships. Then there is Lagos National Orthopedic Khola Fellowship, Marker College, Wurzburg, then PKU Shenzhen Hospital, CEQUAD Mid CEQUAD Fellowship, TCH CEQUAD. So these are 50 international fellowships which are offered, and by the end of October, these fellowships closes. Again, this year it has already closed. Then another association, International Association, Asia Pacific Orthopedic Association, it provides another 50 fellowships every year. They have 9 sections, and every section have 4 to 5 fellowships: trauma section, hip section, knee section, foot and ankle society, pediatric society, spine society, sports, infection, and research. And let me again tell you, the research society fellowships are the least opted fellowships, which are again opted by the fellows. Then AO Foundation, we all know the Synthes AO Foundation, it provides through AO trauma. They have about 140 centers all across the world. And out of that, about 80 are into Asia Pacific. And then there are about 100 centers, training centers for AO spine. Apart from these 2 clinical fellowships, which accounts for almost 250 training fellows, there are 2 research fellows. These again, AO Foundation fellow research fellowships are very sought after fellowships, and there are n number of applications. They have a strict criteria for looking for this. And we had Dr. Vivek Trikha, who was the research officer for India, who were looking after these fellowships also. So what has actually changed? During COVID, none of fellows could go to the hospital for almost 2 months of lockdown. Everything was closed. There was no clinical work, limited number of people. So it has changed the way we were learning. Our learning process was only through the web. So almost all the clinical fellowships of attaining the surgical skills had stopped. The world has stopped. But should we stop? Is there anything which has changed for us? No. Post COVID, we have again come to the same. So I would conclude with the saying of Swami Vivekananda: arise, awake, and stop not until the goal is reached. So for all fellows, word has not stopped. We have started again. People, hospital have started. All the fellowships have been started. Thank you.
Thank you, Dr. Anup Agarwal. You may now stop sharing your screens. Now, last 4 sessions, they are open for discussions. We may limit discussion time because we are already trailing by 2 lectures.
Dr. Vivek, can I please start?
Yeah, be brief and
yes.
short. Thank you.
Yes. So my first discussion would be towards the fellowship part. Dr. Anup, that was a wonderful presentation. I want to talk about the criteria that most of the fellowships have. Now the criteria is a number, or the main criteria is number of research papers. And I would differ in this. I always differed in it. Now research, when we talk of, now most of the medical colleges, well established institutions in cities, in class A cities, well, they have a very research oriented kind of atmosphere, where there are PGs and there are interns, and there is a proper protocols. Now you will agree with me, most of the panelists here will agree with me, there are so many class B, class C cities where there are medical colleges, and there the atmosphere of research might not be so. Even your HOD or your guide may not. Thesis is a compulsion, like everybody said. So
We can't hear you, Dr. Samir.
So probably he's talking about the criteria for selection and some moderation into it.
Yeah.
So yeah, please.
Dr. Samir, probably even you can't hear. Oh, what has happened?
You're audible.
We can hear you. Please continue.
How come I have started sharing?
Oh, yeah, okay.
Okay. So probably you're right that there are n number of orthopedic surgeons. Dr. Samir, are you back? We can't hear you. Please unmute yourself.
Okay, you may continue.
Yes, sir, I'm there now. Dr. Anoop, I'm very much there.
Okay, so your point is well taken. Actually, the criteria which we had for fellowships, there is an application form where we do talk about that, how many publications you have done in national, international journals, what was your thesis and everything. And that is what has actually changed my perception, because I come from a private practice where I could see that a lot of younger surgeons who directly go to smaller cities, not involved into the research, they could not enter into the fellowship programs. And that is where comes into this IOA UA mentorship program. We have opportunities where research is not the only criteria we are putting in. You want to work under somebody, you want to learn arthroscopy, you want to learn arthroplasty, you want to learn spine, you choose your mentor. We are there to cooperate, we are there to coordinate with your mentor, and we'll be able to give you. And let me tell you, that is the purpose that we are steadily increasing these IOA UA mentorship program. It is I would say, the flagship program of IOA, where I'm really working, where I want that every person who is willing to get trained under anybody inside India should get an opportunity without a fail. And that is where we are working actually. And that's the reason that I had already proposed that we should increase it from 30 to 50 this year. We do have a lot of money, and we need to really invest this money for training of these young fellows. So I do agree with you, Dr. Samir Mehta, and that is why we have this IOA UA mentorship program, where research is not the sole criteria for taking them for the fellowship. It is their interest into that subspecialty. It is their interest to get trained, which we are considering.
Thank you very much. That very rightly answers. So one point for Dr. Raj Gopalan Iyer, if he's there. On the basis of what you put up, the highly sought after is fellowships for the last 8 years or so is sports medicine and arthroscopy. And sir, I'm also an arthroscopy and sports medicine surgeon. Just want to make a comment on this, that why a young person gets attracted towards sports medicine. One reason is that they relate with the patients. When I was young and I was myself a sportsman, I was a swimmer and I'm still a racket player. So I could relate with his problems, and I got very interested in his problems of hamstring strains and of ligament tears and all that. So this was an extension, or the subspecialty chosen by me was an extension of what I was already doing. So this is one big reason that young attracts young. That this field, unlike spine, where the patients are little in morbid conditions. So can be one reason, and I was doubly lucky that I was given a thesis by my boss, by my HOD on arthroscopy. So this was divinity that helped me getting this. So this is one reason of getting this. Thank you.
Dr. Samir, people are very attracted to arthroplasty also. So there's no reason why you're saying to spine only old people will come, huh?
No, I'm not saying, sir.
Well,
Just lightly colored.
my perception is people go in for arthroscopy because it's easier to set up and practice. I mean, it doesn't involve too much of infrastructure, and it doesn't has to be institutional practice like in spine. No, in the spine, you need an ICU backup. You need a bigger infrastructure, more risk. Arthroscopy is relatively, it doesn't require that much of a setup, and probably, it doesn't require too much of, I guess, risk also, and ICU backup and those sort of things. Patients are relatively fit. I think that is the reason, not because you're saying.
Yeah, but I would slightly differ. No, the glamour of orthoplasty is really surging into orthoplasty fellowship is higher than any other subspecialty.
I just share some short comment. Like having more publication is a disadvantage for a government job, honestly. As a part of many expert in many interview boards of the top, I'm telling you this, I have seen people having 50 publication in last 3 years, and that became a disadvantage for that candidate. So this is very common. So we have to see how much time he has put in publication and how much time clinics he knows. These are the part of interviews of assistant professor, I'm telling you. So having more publication sometimes is a disadvantage.
I'm not really sure about that, sir, because most of the criteria for selection, they have taken publications and stuff like that. So that's not really true. The only other thing I would say is that in countries like UK and all, where they have a set program for training, automatically after finishing their CCST or the PG level training, they opt for a fellowship. It's somehow inbuilt in their system. So maybe, if we can have, and second point I would like to state is that we started quite a few fellowships. So that doesn't require any publications or research. It's purely based on a MCQ system and plus interview. So
yes, Dr. Faruqi rightly said. Many younger people, they are very much looking forward to all these fellowships and all. If anybody else wants to comment, I would like to invite. Otherwise, we may hand over the session to Dr. Tomar and Dr. Samardit Singh.
Vivek, one comment.
Yes, sir. Yes, sir. Please.
I really thank Dr. Anup on bringing forward the details, and we will archive this and maybe relook at them. You can also add ISCSA fellowships, which are robust over the last 10 years, and we've helped around 500 people on arthroscopy and arthroplasty. So that we do around 50 fellowships every year from US till New Zealand, covering almost all the globe.
Can I ask a question from Dr. Anup?
Yeah, please.
Dr. Anup, so many centers offering fellowships, different mentors offering fellowship. Is there any regulatory body who can assess whether this infrastructure is adequate, the mentorship is adequate, proper teaching, proper guidance has been given? Because so many people are, even private centers are coming up with that. And at times maybe the purpose is other than giving the fellow, just collect more people around, more hands there to help for them. I mean, is there any regulatory body?
Yeah, Dr. Sharad, there is no such regulatory body as of now in India which can coordinate and do the thing. So with the same thought, we started looking at the centers all around in India, and we try to do an accreditation process. We did a thought about it, that can IUA Fellowship Committee do that we have different centers, private institutions who wants to take the fellow, they have fellow through the IUA accredited fellowship program. But the problem we suffered to get an accreditation was it's a long process. If you want to accredit any center, you need to have the data from there. Then you probably need an inspection. Then probably you need a committee who can look after that and then categorize center into A, B, C type of fellowship. So it's a long process. We already have started a thought process into that as an IUA fellowship committee, can this project be taken up to accredit the different fellowship centers all across the India who are willing to participate in IUA fellowship program? But otherwise, there are no such coordination or accreditation body in India who are doing so. And you're rightly pointed that most of these private institutes are luring the fellows for the sake of hand rather than giving them actually training. So it's probably mutual benefit. Trainees think that I'm getting trained, and the mentor thinks that I'm getting a hand also. So yes, it is there.
So Dr. Anup, in ISKSA, what we are doing is we are getting a form filled after the fellowship. So it is like a testimonial which says that I did not assist any case. It says I saw 5 cases. So, and those testimonials are uploaded on the website. So anybody who is applying can look at the testimonial, and since it is coming from the fellow, the next person who applies knows what he is getting.
Dr. Lal, we are doing the same thing, that we have a fixed pro forma where mentor has to sign that he had attended such clinical settings, the OTs and all that, but we are not uploading on this platform of IUA. So probably, as soon as we update our IUA website, I'll take this point of yours and we'll try to upload those things, testimonials also.
Dr. Lalit, I think a simple solution would be to have a logbook, isn't it? Like they have in the NHS, they have a logbook, and you write down how many cases you have done supervised, how many you have done independent, how many you have observed, and based on that we can have a criteria so that at least the students who are going, they are not used as working hands.
And the problem is logbooks are filled here by hand. In abroad like NHS, in other countries, they are computerized.
No.
Whatever you assist, whatever you do, it is entered into the computer. Data is hospital based. Here the data is cooked. The problem is this. That is a problem. Here in NHS, what you do is you put your ID number. The whole year it comes what you have done.
Sir, but वो sign तो करेगा ना supervisor, whoever is.
But the sign is you. How do you sign? How do I sign? You know it.
अब कुछ तो integrity और sanctity रखनी पड़ेगी.
Let us be honest. I'm honest. I'm telling you, this is very difficult in Indian scenario, because we are not having the true moral values.
And we don't have surgical audit and a central record keeping system. So we can't actually say that if any surgeon is saying that this month we have done 100 surgery, and we can really put a thing that yes, he has done or he has not done. And that's where I said no, we want to start a process of accreditation of the private centers for fellowship program. And I am doing a bit of work on this, that how it could be done. So it may take some time, but I definitely looking forward to you all to send me your suggestions that how it can be done really.
I guess a beginning has to be made somewhere. Otherwise, ये तो कभी आगे चलेगा ही नहीं. I mean, because young surgeons, then they won't have an opportunity to, because they'll be used as just working hands. They, even if they have done 2-year fellowship, they are just second or third assistant. So it doesn't make sense. I think we need to start this somewhere.
Okay. With this session, there are many things which came out. Hope it practically to our next session on COVID pandemic and impact on orthopedics, to Dr. Tomar and Dr. Samarjit Singh.
Yeah, good morning all, everyone, and I welcome you all. Am I audible?
Yes,
sir. Yes,
sir. So this was an excellent session on academics and publications, but the next session is going to be even more interesting, and this is of interest to all orthopedic surgeons. That is COVID pandemic and its impact on orthopedic practice. This is very unprecedented times that no one has ever faced earlier, and we are facing so many challenges. There are no specific guidelines. We have to work for the safety of ours, safety of our finances, and safety of our patients as well. So we have a highly learned faculty to enlighten us on the various aspects of orthopedic practice. And we have 3 luminaries of orthopedics as our panelists. 2 from Delhi, Dr. Anmol Maria, welcome you. Dr. Rajiv Jain, welcome you. And Dr. John Mukhopadhyay from Patna, we welcome you, sir. And the first talk is by Professor Vivek Trikha from All India Institute of Medical Sciences, that is Impact of COVID Protocol on Golden Hours in Emergency Management. We welcome you, Dr. Vivek Trikha, for your talk, please. And we have two moderators, me, Dr. Al Tomar, and Dr. Samarjeet Singh. We will moderate the session.
Sir, we have Dr. Ajay Shukla as panelist also.
Okay.
Okay, so am I audible and visible? My screen says visible?
Yes, sir.
Okay, so without any further ado, let me thank the Delhi Orthopedic Executive and Dr. Dhananjay especially for giving me this opportunity to be speaking on this topic, which is impact of COVID pandemic on the golden hour in the emergency management. So just before we start that, I'll just like to give you one overview that right now, 10 days back on 20th November, India's COVID tally was more than 90 lakhs. And the death rate and the death toll right present is more than 135,000 patients who have died in this COVID times. Just to give you a perspective, what we deal with in trauma every year, we nearly have 1.5 lakh deaths every year because of road traffic injuries in India. And because of COVID, we already have around similar sort of deaths till now. So we are dealing with some basic problems out here. And the basic fact of COVID is that it is going to be here to stay. Come what may, the vaccines may come, but for the next 1 year, we are dealing with COVID pandemic, especially in our country. It has led to unprecedented challenges for our routine clinical care, but most importantly, it's the trauma care and the frontline warriors, I would say, not the COVID warriors, the frontline warriors who are dealing with the brunt of managing this challenge. If you remember the Tiananmen Square scenario around 30 years back, one person taking care of the entire tank brigade which was coming to him. So it's just a similar scenario for the emergency department people because they do not know what lies in store for them, and every patient might be a COVID person. Another perspective, majority of patients, nearly 15%, are the healthcare workers. So there have been over the last 8 to 9 months, you would have seen a lot of blueprints regarding how to have a dedicated COVID center, how do we sift the COVID positive patients here, COVID negative patients there. We make it different wards for everyone. But these cannot be copied to a trauma emergency because the basic premise of all these centers and the blueprints is that you are having a COVID test and you can segregate between COVID negative and COVID positive, which is not possible in a trauma emergency where the first hour or the first initial few hours are going to decide the life or death of a patient. So the questions we need to answer for this is, how do we maintain the quality of trauma management without spreading the virus in these times? How to follow the international guidelines, the principles, while reducing the risk for healthcare professionals, and how to protect our infrastructure from getting overwhelmed. The first thing first, we have to have some protocols which need to be implemented, and proper monitoring of these and their compliance needs to be done whenever we are dealing with these protocols. So the approach to a trauma patient, the basic principles which we follow is, we know that we have to reduce the morbidity and mortality, minimize the disease transmission among the people who are there in the trauma area, which may be the healthcare professionals or the other trauma patients who may not be COVID positive, but they also can be infected by having a lot of patients together. And also prevent the healthcare professionals and the healthcare system functioning, because you might have your trauma team getting infected, and once it gets infected, where is the next line of force that you are going to bring, which will be trained in an emergency department care for dealing with this scenario? Looking in the world literature, there are very few literatures evidence which says that what and how the things have changed in the trauma scenario. This is from Hans Christoph Pape from Switzerland in a European level 1 trauma center, where they found in a brief span of around 2 months post-COVID that the patients of trauma had decreased in the emergency area. The ISS, or the injury severity score, of these patients was relatively less as compared to the pre-COVID times, because maybe the things are slightly slowing down as our pace of work is going to happen. But the most important thing which you can notice out here was that the time duration spent in the emergency area had increased. And also from admission or the arrival into the hospital to a whole body CT scan, this means you have stabilized the patient till that time. That has also increased, which can be a possibility because we have to take extra care and we slightly go slow during this time because you have to take care of the other patients as well as the healthcare professionals while dealing with these patients, and which may not be best for the patient himself who is having those life-threatening injuries. If you look at our own scenario at AIMS Trauma Center and the trauma center which has been shifted to the main center now in the emergency department, in the last 5 months from April to August, we had nearly 8,000 patients who were managed, and the red critically ill and the severely ill patients had around about 4,000 patients had to be managed. So it's not that the trauma scenario in India has decreased considerably, I would say. It is nearly the same, or it is around 75 to 80% for what was there in the pre-COVID era. So what is the emergency management and the key points which we need to take care? The first thing first is you have to consider all trauma victims are COVID positives until you prove them otherwise. You cannot ensure and see, even if he's my relative or your relative, that he is COVID negative. You have to first test him and ensure that he is negative. You cannot do that in a trauma scenario. So what you do, you continue your initial assessment and management as per the ATLS protocol or whichever protocol you are following to ensure that the life of the patient is taken care of, making sure that he does not suffer from any threatening injuries. You have to be very pragmatic and practically oriented to decide which treatment you are going to do, and you may have to stop on slightly unnecessary or which can be delayed. The methods or procedures which can be delayed should be delayed and not taken otherwise straight away in managing these patients. And all life-threatening, I'll repeat, all life-threatening injuries will need assessment and stabilization before testing for COVID-19 infection. So you need to, on one hand, consider all as positive, not test them, and at the same time, ensure that all the life-threatening injuries have been taken care right in the same way as it was done previously. So that brings us to the question, which is the COVID test which we are going to do, until what time we are going to wait for that. So we know that RT-PCR roughly takes 6 hours to 24 hours in the best of hands. The CB-NATs and the TrueNATs take around 4 to 6 hours in the best of hands. Again, I would say the rapid antigen test, which takes around 20 minutes, is not so sensitive. So even if it comes negative, you have to consider the possibility that the patient can be positive. And there is a new light in the horizon, which is the Feluda kit, which has just been launched around 10 days back, which takes around 30 to 40 minutes for the test to be done. It is an indigenized method of testing, CRISPR method, which is used. It is very cheap, around 400 rupees is the cost. Its sensitivity and specificity is around 98%, equivalent to or better than the RT-PCR, and can give results within 30 to 40 minutes. So this may be the game changer now for the trauma emergencies in all over the country, where it is being marketed by Tata as Tata MD Check, which is Feluda kit developed by CSIR, will be giving us the immediate or at least 30 minutes test of the COVID, and most of the orthopedic fractures, which are not so life-threatening, we can have this test, get the report within 1 hour of their injuries, and manage them accordingly for most and 99% of the trauma orthopedic injuries which they suffer from. So right now, we take care with the gene expert in our hospital, the TrueNATs, because it gives a test within 3 to 4 hours for orthopedic patients. And subsequently, I think the Feluda kit is going to be the beneficial, because we can get the test early enough for the orthopedic surgeries and the interventions to be managed in these trauma victims. Primary survey and resuscitation, the golden hour period. The principles of life, they never change. They remain the same. You have to take care of airway, breathing, and then you take care of the limb-threatening procedures. However, what has changed in COVID era is the safety measures for the healthcare providers. You now need to be more cautious of the safety for the healthcare equivalent to the trauma victim. And for that, as I said, you need the protocols and specific regulations. Again, I would say, don't forget that there are nearly 100,000 health staff patients in COVID era in India who have been infected, and the first top two states for them are Delhi and Maharashtra. This was in September, so 3 months before, where around 90,000 health staff was infected. So patient and healthcare personnel safety is the #1 priority in the trauma care, because here you do not know whether the patient is COVID positive or negative. This is one ad or one message which had come and which I always keep. Take care of yourself before you take care of others. This is for the healthcare professionals, because there is no need of heroics. All you will get is a garland. Either way you end up. Either the saving of the life of the patient is there, or your life is at danger. So how do you reduce the risks? Number of personnel should be reduced. PPE has to be imperative and mandatory for such people who are managing these patients, reduce the aerosol generation, and have a proper decontamination and disinfection process right there in the trauma area. How do you reduce the direct contact? So here in our hospital and in most of the hospitals, what they have done is the ED team has been divided into hands-on and hands-off team. The hands-on team is the one which is directly dealing with the patients, taking care of their intubation, their primary assessments, and all the emergency interventions which have to be done for their airway, breathing, and circulation, especially for the red area patients. And the hands-off team are the relatively second line, which do not come directly for a long time with the patient. They are mostly for consults and the technical supports and the logistics. So you can divide them, and so that you have a team which is getting experienced and a second line of defense also whenever there is a problem with the first line. Most important, which brings us, is the personal protection equipment. You need to have the level 1, level 2, and level 3. The level 1 are the routine things which we are using right now, the gowns, the masks, and the gloves. The level 2 and the level 3 are the ones which you require in a trauma emergency red area patients and the healthcare professionals. Because those who are dealing with the secretions, with the airway management and the intubations need to have a coverall, N95, a face shield, gloves, and covering all their body, because you do not know which patient is COVID positive or negative. And during the heat of the moment, when you are saving a patient's life, you might be putting and endangering your own life without realizing the fact. When you are doing an intubation or a suction, or you are managing a bleeding in the axillary artery or in the proximal humerus area, you may not remember when the patient is coughing, and you may get down with this COVID area. So the golden hour, most of the aerosol generating procedures, like we give oxygen to all the patients of trauma, many of them require ventilation or tracheal intubation or suctioning. All these are aerosol generating procedures which have to be done mandatorily in the trauma area. There's no alternative for them. You have to deal with that. So what can we do? We can just protect ourselves while dealing with them. We cannot keep them aside. So let's face it with full protection on. There's a high risk of infections which we need to avoid. And you can see an intubation or a bag mask ventilation being done for a small child, and all the people are wearing a proper level 2 or level 3 PPE kit with a face screen, all the gloves, and the N95 mask. And every precaution has to be there right beforehand while dealing with these patients. When you do an intubation, you need to have a complete PPE as they are using. And this is one of the patients in the trauma area. Even the nursing professionals who are dealing with these patients and dealing with their nursing care also need to ensure that personal protection is at the paramount area. Then comes the minor OT procedures in emergency, which may be some chest tube insertions, suturing, debridement, putting in a lot of saline, washing the open wounds, and the abscess drainage. All these, again, I would say, come in the PP2, level 2 and level 3 equipment, where you need to cover entire body of yourself, have a face screen, wear the masks, and ensure that personal protection is kept to the maximum. Orthopedic management, this is our own setup where people are wearing gowns. And if you do not want to, we have been lucky enough that in our hospital, our orthopedics department has been providing us and has provided us with respirators, with our full respirators, which have been given to the residents as well as the consultants who are dealing with these patients, and which gives us more than 97-99% full protection for the prevention of aerosol which comes into our breathing system. We have been managing a lot of orthopedic patients in our emergency department since the lockdown is over, and the patients in the level 1 center, like, you can have the gowns, masks, or the PAPR which can be used. Diagnostics is also important. Ensure that there is a proper imaging of red area which is in portable way. Patients are not shifted, rather the diagnostic comes to the patient. Non-emergent imaging should be delayed. The routine CT scans which we do for the orthopedic injuries can be delayed till the COVID result comes, and a dedicated CT room should be there in the proximity for the emergency management. This is how the ultrasounds and the DSAs or the angiographies which required can be done and are being done in our setup. We have done nearly 4,000 CT scans over the last 5 months, and all these precautions are paramount. It has to be inbuilt in your system as a protocol based, because you cannot do and change into a PPE when the patient is going to come to you. You need to be prepared for that. Even in life-saving emergency surgeries, you need a specific dedicated operation room if possible, or if not, at least ensure that you have a OR which has been set to be a COVID area or a COVID OR, where all the precautions will be taken care by all the personnel working there. There has to be a special passage, a unidirectional flow, and all should be wearing level 3 protection, which should be used. Surgery which we are doing in acute emergency life-saving should only be for damage control and life-saving methods, and all focused efforts should be made to shorten the operation time or the OR time for the patient as well as for the healthcare professionals. So this is what we follow. If it is a life-threatening, we straight away take him to an OR where the pelvic stabilization, vascular or laparotomies are done, to a OR which has been designated as COVID OT, where without the reports, because you cannot have reports and the patient's life is paramount, everybody is wearing a PPE, and later on during the time of intubation or so, you can take a swab and send it, but the report is going to come later. You save the life of the patient first. Most of the other fractures of orthopedics, they can wait for 4 to 6 hours. So by that time, you will get your CD-NAT, TrueNAT reports, and then you can manage them. If they are positive in a separate center, or if they are negative, you can get and manage them in your own center in the proper protocolized manner. We have been doing nearly 200 surgeries every month over the last 7-8 months, and there has been no let up from our department, and we have been getting good care and expert guidance from our seniors in our aims for this. Finally, biomedical waste management is one thing which we miss out, especially in emergency department, where all the PPEs, face masks, the suctions, the tubes and the gloves which have been used on patients who were not tested for COVID positive or negative should be properly disposed of, because we remember that the person who is taking out that infection material from your hospital is also a vital part and a key part for your hospital management. So let's not think not of him. We should be taking care. Make sure all the infected things needs to be incinerated in a yellow bin, and other plastics to be sent for autoclave in the red bin. If possible, you should have a specific and separate laundry where the patients have not been identified as COVID positive or negative. And wherever you can have these controls, use the 0.5 hypochlorite and then wash them with 70 degrees centigrade. I would say that in this present COVID times, we were till now taking care purely and purely of the patient's survival. But now we have to make a very fine balance between the patient safety and our own protection as healthcare professionals. Because if we do not take care of our own self right now, which may look selfish to some people in idealistic circumstances. But remember, until unless you are alive, you cannot fight the war the next day. So you have to ensure your own safety at this moment. The take home is the trauma care cannot be compromised come what may, even if it's a COVID pandemic or not. The ATLS guidelines need to be followed in the golden hour. All trauma patients are COVID positive until they are proven otherwise. Life-saving measures take precedence over everything else. And you need to be prepared as a service care provider that you take proper precautions while saving the life of the others. Ensuring that you have standard protocols which are written down and followed properly with the proper brief and reversing and taking care of them, that is what is going to ensure that you have a smooth recovery for all the trauma patients and also ensuring good safety for your healthcare professionals. Thank you very much for your hearing.
Thank you, Dr. Vivek, for wonderful insight into the thing. Now I invite Dr. Sudhir Kapoor. I think questions will take it at the end of it will be better. That will save us some time. Is it fine with everybody? Dr. Kapoor is teacher of teachers, and now he is going to give us insight into going back from lot of surgeries. Is there a scope for CAST? So let's listen to Worldly wise experience.
Is my PPT visible?
Yes.
Is it visible?
Yes, sir. Visible, sir.
Okay, dear. Well, good morning to all of you. I must appreciate the combined wisdom of the scientific committee who have given very, very apt article titles to every faculty. I think Vivek has done a wonderful job. I like to do similar thing with my presentation regarding application of CAST and conservative management. Well, the plan of my talk would be, I'll tell you some historical facts which are relevant to us, to this talk, like POP, Sarmiento, and even AO also. And how orthopedics has changed in COVID, I think Dr. Vivek has done it with, nicely. I need not elaborate upon that. Then fractures which are amenable to conservative management, like fracture tibial diaphysis, fracture shaft humerus. What are the factors or peculiarities or contraindications to conservative management? I cannot cover all the fractures which can be managed conservatively or which can be in the CAST, but I feel fractures like, let us say, tibia or a supracondylar fracture, I like to tell a few final points, and finally I'll summarize my talk. Well, while researching for this talk, I was going through the AO manual. There was a lot of, in the historical aspects, they did talk about Hippocrates and other cultures, but they never mentioned about Indian ancient culture, and I was surprised when I was researching that I found this thing in Sushruta Samhita. Anchana, Pidana, Sankalpena, and Bandhana. Well, these are similar to traction, manipulation, and plaster application. This is from Sushruta Samhita. I think we need to be knowing this fact that our ancient people did know about conservative management of fractures, and they were treating the patients properly also with all the things which are following now. Talking of plaster of Paris, I think that it was introduced for the first time in 1952 by a Dutch military surgeon, and it was discovered accidentally during a fire in a gypsum setup, where they found that the footprints made by the shoes set rock hard after it rained on the baked mud, telling them about the importance of using semi-hydrated calcium sulfate impregnated bandages for the plaster application. I think that must have changed the way of immobilization of fractures, and the things must have become very, very handy in that regard. Well, the conservative management of fractures, which I have been dealing with, will not be complete unless I mention about Sir John Charnley and about the Thomas Sprint. Though Dr. John Charnley is known for his invention of THR, but I think his manuscript on close treatment of fractures is a wonderful thing. Any person who is interested in managing the fractures conservatively must go through this. The understanding the different forces acting against the across the fracture site and how to immobilize, how to reduce is given wonderfully well. I think every orthopedic surgeon must read this. Thomas splint, though devised by Sir Thomas, it was popularized by Robert Jones, and it did change the treatment of fracture shaft of the femur in World War I and later also. We have been, until this date, we are following it for primary care of fracture shaft femur. It will not be out of the place if I mention about the fracture shaft femur being managed by different fracture shaft femur and fracture in the intercostal area also being managed by different types of traction. I have seen all this traction in my lifetime, in my career, and I am sold to Hamilton Russell traction. I have yet to come across any more mechanically balanced traction than Hamilton Russell traction. This is one traction which can aptly reduce intercostal fracture and will unite with almost 100% certainty. In a patient who is PSC fit, there is no harm in trying this traction even today also. This is the most mechanically balanced traction and very comfortable for the patient also. Well, why I'm talking of AO, the progenitors of internal fixation in this talk, the reason will become obvious in a minute. AO, which founded in 1958, they had three cardinal principles of fracture management, that is restoration of anatomy, internal fixation, and the early mobilization of the limb and the patient. But mind you, over a period of years, they have been intelligent enough to shift from rigid fixation. When AO was introduced, we all know that seeing a callus on a post-operative X-ray was taboo. It was thought to be a sin. The fixation was supposed to be inadequate if one could see callus on the X-ray. Gradually, they have understood and they have changed to stable fixation. It is not a bad thing to see a callus and interlocking nail. If you see a callus, you are happy. And recently, they have understood the importance. They have stressed upon the importance of soft tissue coverage and keeping the blood supply intact, and shift to biological fixation by sliding plates and so on. So we have seen a shift towards conservatism even in AO also, from rigid to stable to biological. This talk will be incomplete unless I mention about Sarmiento. The storm created by AO, by everybody fixing the fractures, was halted to some extent by Sarmiento when he introduced the principle of functional bracing. In his principle, he demonstrated and proved adequately that in a closed system of brace, the dislocating forces of the muscles across the fracture, they become compressive forces. And the controlled micro motion allowed while wearing a brace promotes callus formation and maintains good position. I think this was a wonderful monogram which you must read even today also, and we must thank him for introducing the concept of PTB, patellar tendon bearing cast. We used cast and the splint, which we use now also. It is a wonderful thing, and all of us understand the importance of regaining knee movements in a fracture of the tibia, which is possible with this cast. The audience must be made aware of this thing also. It is not orthopedics, but still we must understand that since 1981, there is a village or a small town by the name of Puttur in Andhra Pradesh, where for the past more than 150 years, they have been managing fractures by conservative management, even without the help of the X-rays. And they are using different things like bamboo sticks, herbal paste, egg white, and they're quite popular in South. And I have seen few cases treated by them, and they are reasonably good results. Anyhow, that is besides the point. Let us understand that in this COVID time, it has been again proven that cast is not evil. It can be of help to an orthopedic surgeon wherever judiciously used. I will not elaborate much upon this. Dr. Vivek has dealt wonderfully. It has affected, the COVID pandemic has affected our practice to a very, very large extent. Hospital resources have been diverted to management of COVID patients, and the orthopedic surgeries have decreased. That is, the cold orthopedic surgeries have decreased to a large extent. Even the patients who are got life-threatening conditions, even they are able to get some orthopedic help in the emergency. The patients who are not so emergency, not suffering from so much emergency fractures. They are being delayed. And during that period of delay, we must understand that we can get over that period, we can use that period by traditional techniques of skeletal traction. It is not a bad idea to teach our residents once again how to put a proper upper tibia pin. In my last institute where I was working, in my 2.5 years stay there, I never saw a tibial pin being put. Now we are putting it, and it can be used judiciously till the time patient's COVID test has been done and patient is fit to be operated. Well, there are certain contraindications to conservative management. I think the audience would be aware of that. Just to revise it, any open fracture or a complicated fracture with a neurovascular injury is a contraindication. Displaced fracture neck femur, that of course is a contraindication to conservative management. Adult femur shed fractures, again a contraindication. Femur fractures in children at least before 10 years of age can be adequately managed with conservative management. And of course, displaced articular fracture like a tibial plateau fracture would require ultimately a surgery. There are few factors which we must understand. If any orthopedic surgeon wants to succeed with conservative management, he must keep in mind few factors. I'll show you examples also. The hematoma must be kept intact. The periosteal sleeve, which will be intact, which is not seen on the X-ray, must be made a judicious use of. I'll show you in a management of supranuclear fracture how to make use of this. Then we must use functionally effective adequate support, which should be covering one joint proximal, one joint distal. Wherever possible, principles of Sarmiento must be used. Then till the time you understand the different forces which are acting across the fracture site, you cannot manage, because conservative management requires a sustained effort. It is not like a surgery where the maximum care stress is done on the day of surgery, then you can relax a bit. But if you are managing a fracture in plaster, you have to be very careful in every week's review and see that everything is going well. There's no plaster sore, the fracture is not moved, plaster is not hurting anywhere. And these are the small things you should require for a fracture management if you're giving a cast. The fractures which are amenable to conservative management, in general, most of the upper limb fractures, they can be treated by cast. Except I feel, let us say, a displaced intercondylar fracture or a similar fracture, most of the fracture in the upper limb and quite a large amount of fractures, particularly fracture tibial shaft, that I can prove can be treated with a plaster cast. These are all the other fractures which can be treated with a plaster cast. I will not name them all. Now, it is not possible to show each and every example. I should just show you 3 or 4 examples of different fractures which have been managed with plaster or the cast or by the conservative management. The first is the supracondylar fracture humerus. I think one must read, again I'm stressing, one must read the manuscript written by I've already mentioned about Charles Coe's method in 1950. We must understand there are three distinct displacements in supracondylar fracture humerus: posterior, lateral, and rotatory. Rotatory displacement usually corrects itself during the method of reduction if you are following the proper method. Reduction of the other two things, that is the posterior displacement and the lateral displacement, that would require your care, and that requires 2 particular steps. I'll just spend a minute over them. Giving a simple traction, either in extension or whatever maximum extension possible, less extension, less flexion possible, will mostly correct the side-to-side displacement. If required, you can manipulate depending upon the whether the displacement is posterior or medial. But many times, in a fresh case, giving a simple traction, sustained traction under proper anesthesia. These fractures must be handled under proper anesthesia, which would be mostly GA in a child, and a sustained traction for about 30-40 seconds would adequately reduce the fracture in majority of the cases. Some amount of lateral displacement may be corrected. Then comes a crucial step of correcting the posterior displacement. While giving the traction to the forearm, which is initially vertical but gradually changes the direction. it is initially in the line with the upper humerus, then it becomes towards the roof, when with the help of one thumb, the posterior displacement is corrected, maintaining the traction. As you do so, the triceps and the intact periosteum locks the fracture in position. And it is said that to check it, simply see whether the acromion and the tip of the olecranon, they are in one line or not. If they're in one line, the fracture is adequately reduced. And according to the original description, can be measured in cuff and collar. We in our country mostly give a slab. This is what I mean by making a judicious use of the periosteal sleeve. The periosteal sleeve is ruptured anteriorly, posteriorly it is intact though loose, and once you do the proper reduction, it locks the fracture in position. A very good reduction which was achieved by the method which I have shown you earlier. Now, tibial shaft fracture, you can examine the patient, but a lot of information can come if you examine the patient under anesthesia, which could be GA, spinal, or even the block also. Simple cast fixation will be sufficient for a fracture which has got a moderate displacement, where the periosteum is intact and the interosseous membrane is not grossly ruptured. Now I'll show you an example which would be a very illustrative example for all of us. And before that, we must understand there are a few final points for tibial plaster. Few points are from the books and few points are from the personal experience. Plaster must be applied in parts. Patient could be either supine or sitting. If the patient is supine, then keep a support under the upper end of the tibia while the traction and counter traction is being maintained. If the patient is sitting, many people advocate doing a tibial reduction with the patient sitting because the gravity helps in that situation. The support should be behind the lower thigh. This is a very, very crucial step. The tibial fracture tends to be convex posteriorly. Assistant must keep his palm of his hand continuously under the fracture as shown in the illustration. A palm of the hand, not the fingers, must be maintained behind the fracture till the time the plaster is set. Sustained traction and counter traction initially for about a minute is crucial. Ultimately, we are aiming at 5 to 10 degree of knee flexion and neutral or 5 degree of equinus at the ankle. The anterior surface of patella and the second toe must be in line. Otherwise, your fracture is in there is some rotation, malrotation at the fracture site. Cast must be above knee cast going beyond mid thigh. Extra paddings at tendo Achilles. Support at TA with the hand of a palm, not a finger. And this is a very, very crucial practical point many people forget. Whenever you are applying a plaster in the lower limb, always let the assistant hold the foot or toes with two hands, not with one hand. If the assistant is holding the foot with one hand, there will be invariably varus. The assistant with one hand holds the lateral toes and with one hand holds the great toe. Only then the varus can be avoided. This is a very, very practical point, not given in any book. This fracture came recently to my department, 45 years old male, a segmental fracture of the tibia. And on close scrutiny, there's a fracture of the upper tibia also. Besides the segmental fracture, upper tibia, fracture line going like this, and a tibial spine fracture also. The fracture was discussed in the department meeting. Interlocking should be done, and we should be ready to fix the tibial spine also, and maybe we have to put the once we do a tibial nail, the fragment may lift up, and then we need to put a screw. All these things were discussed. Well, I decided to give a plaster myself, and this is the result. There's a plaster applied about 2 weeks ago. You see the center of the ankle, center of the knee, and the center of the ankle.
Sir, please, we are running short of time. Please.
Okay, dear. I'll try to rush out. Are in perfect line. Now, talking about the proximal humerus fracture, I think this study is known to everybody. I'll not go into detail. This is the largest study in UK, a multi-center study done in 250 patients, which they have concluded that these results do not support the trend of increased surgery for patients with displaced fractures of the proximal humerus. They have proved beyond doubt that the fractures of the proximal and the humerus can be managed, most of them can be managed conservatively. In the last, about the fracture shaft femur, this is one fracture, a fracture shaft of the femur is destined to unite unless an orthopedic surgeon decides to intervene. I put this photograph to show you the amount of muscle coverage the humerus is enjoying. It will unite in whatever position you hold it. Traditionally, we have been holding it in the hanging cast, in which the weight of the cast and the gravity help in reduction. Recently, cast in extension has been in fashion, which takes the use of taut biceps and triceps to maintain the reduction and hold it in position. This is one patient managed by one of my colleagues with the extension cast, the shaft of the humerus changed to a small splint and the good union occurring. I'll summarize that in conservative treatment provides a way out in difficult situations like this pandemic. Traditional methods can guide us to manage orthopedic injuries till the peak of pandemic is over. It is an opportunity to rethink and revisit conservative methods. Let's draw new guidelines and exercise control over the urge to operate every fracture. And finally, cast is not an evil. It can prove to be an angel when executed judiciously. Thank you so much. If there are any questions, please ask right now. I may have to leave a little earlier.
Thank you very much for an excellent presentation, Professor Sudhir Kapoor, sir. And cast is not an evil, and in fact, it has helped us to sail through in this very difficult times. So the question and answers will be taken after the session, because we are running very short of time. There is only half an hour left.
There is some emergency in the
Are there any questions or from the panelists to Professor?
Okay, so I'd just like to make one comment on the supracondylar fractures in children. So if you're going to take the patient into OT and give them a GA and reduce the fracture, putting in a couple of K wires doesn't take any extra time. So I think it makes a big difference to redisplacement of that fracture. So I think if you're going to the extent of actually taking the patient into OR, giving him anesthesia and then reducing it, the maximum aerosols is when you're intubating the patient. So to me, because then you can safely extend the forearm without worrying about displacement, the elbow without worrying about displacement. Otherwise, I think all the other, a lot of these fractures can be managed conservatively. And certainly in COVID times, there's an indication for managing them conservatively.
Thank you so much, Dr. Mukhopadhyay, and thank you, sir, Dr. Sudhir Kapoor, sir. And now I will invite Dr. Gurinder Bedi for the next presentation, that is pre-operative checklist to ensure patient safety. Dr. Gurinder Bedi, please start.
Okay, so good morning, everyone. I think winter used to be a good chance to meet up with your colleagues in Doacon. It was a lovely time. If you've ever been to the Habitat Center, you could stand in the sun, enjoy the coffee. I can't remember any lecture there though, but there was a lot of physical interaction, which I think I'm missing now. But nonetheless, I'm sure we'll make the best of it next time that we meet. But I'm missing those cultural evenings as well. So this is where we are now. We're really confused about the way forward. What should we do? What should we not do? Then these kind of articles keep coming out in the literature again and again, which talk about the high chance of post-op complications, number of ICU admissions. This is a comparison of COVID and non-COVID patients. Then again, this kind of a paper, which actually started it off from China, which talked about if you were not doing any testing on people and you actually ended up operating on them, these were routine elective surgeries. About 50% of them ended up in ICU, huge percentage of mortality, 1/5 died. And what they showed was there are issues why a lot of these people will have a problem if you're not careful. So it's a potentially lethal condition, and that's the problem. I know most people will get better, but it is at the end of the day still a potentially lethal condition, and it's highly contagious. So one person in the house gets it, everybody gets it. One casualty patient walks in, invariably, if you're not taking precautions, at least 5 to 6 carers will get it, and the morbidity can be significant. So we're learning more about the morbidities as we go. So we need to know this. We know that there's a hell of a lot of healthcare workers getting involved. That's what Vivek just told us, and possibly there's something called a high viral load. That might be one of the reasons why we seem to keep getting involved. And there's different changing levels of education about if you're in an air-conditioned room, positive pressure, negative pressure, why the droplets keep on getting spread, how you keep on getting this thing. So hell of a lot of things is what is going to happen to you in the hospital. So it's not at all an easy time. There are different times, the challenging times, which are there. So different times also, because if you're a private practitioner and if you, well, even if you're an orthopedic surgeon in the government setup, there's very little work coming your way. So your normal day-to-day routine is actually quite disturbed. You will end up getting desperate because the itchy fingers are going to creep in one of these days, and you will end up operating on something which you were not really doing very well before anyway. And you remember you're all working on a different regular schedules because the priority is being given to the COVID patients. You're coming at the end, and the whole setup is very, very different. These are unusual times also because the type of the workload is different. It's not the kind of, the same kind of pattern which been used to working for so many years. And it's not the way that you really worked with. You push to one corner. You're so aware of the other person, whether he's going to carry infection, not carry infection. You're adjusting your mask all the time. You're wearing those difficult to wear clothes if you go on to operate or if you go to emergency manage. And remember, you are still in charge, running a service which has to be rationalized, and the priority has got to be given to the COVID patients, which is there. So this is one of the papers which came out. Raju wrote this along with Abid. What they basically talked about, there is it's a different way of working that we are all getting used to it. We're postponing things. We're seeing a lot of different infections. We're seeing a lot of different ailments which are there. So it's a different way to look at it. Your investigations are slightly different. People don't want to go into an CT scanner. People don't want to get an MRI scanner done. You're actually talking to people on the telephones more than anything else. You're sending off the WhatsApp messages. So there's all a different way to remember. And remember, there is a challenge with this. You're not only protecting the patient, you're also protecting the medical staff and your colleagues. And remember, what happens to you in the hospital, you can actually take it back home into your house and actually end up giving bigger problems to the people at home. So it's all good to talk about the theory, but the problem is you don't know when is it going to end. And it could actually go on as we're discussing, maybe for a year or even 2 years. And then you start getting confused about what is my priority, what is not my priority in this. But as the popular radio jingle goes, काम तो चलता ही रहना चाहिए. So these were the initial thoughts which came out. I think Lalit and Raju both were authors on this paper. So essentially, they talked about what Dr. Sudhir Kapoor talked about, that if there is any chance that you don't, or you can avoid operating, go on and avoid operating. This is what we started with. Remember, this is what we were taught. We were just postponing it till we can actually get back to doing it. That postponing thing from a few weeks has become to almost a year. So things are actually different. And too many people are suffering from a lack of treatment, whether it's a cardiac issue, whether it's a stroke, diabetes. We just having to sort of, live with the complications of things we could have sorted out earlier. And we need to think about changing what we call as what is emergency. And more we realize you cannot have a cookie cutter approach. You cannot just keeping the same thing again and again and taking it to other people. So the philosophy, as has been rightly said again and again, everybody is COVID until you can prove it otherwise. But I'm fairly confident when I make the next statement, orthopedic procedures are low risk procedures. I am aware of those WhatsApp messages about the saws and the generation of blood and everything. Nobody's actually shown viremia in the blood. Nobody's shown that an orthopedic surgeon doing a knee replacement has actually got this thing. I know there is a generation of fluid particles. I know they can be vectors for the virus which is floating in the air, but it's not getting transmitted by blood to the best of my knowledge, and you got to take your precautions. And obviously, I'm not asking you to throw caution into the air. Test every patient whenever possible. And if you do not have the facility for backup, keeping them separately, do not operate on them. Now, what about patient selection? We all talk about dividing the patients into these kind of categories. And this is an algorithm. Well, there's so many of those algorithms which keep coming on. There is no denying as a doctor, you do not have a right to refuse a patient. Whether your facility has it or not, you have to actually manage this patient. So these are the emergency patients we're talking about. So we'll talk about that later. Then you come to the other patients, and then the algorithm actually goes. Remember, the big problem is the aerosol generating patients. So anybody who's working in the mouth, the ENT surgeon, a dental surgeon, an anesthetist who's going to keep looking down the throat, the liquid generation and all. He's the one who's at a bigger problem. You are not at the end of it. You can actually walk into the operation theater 20 minutes after he's already done the intubation. So this is a very good algorithm. I hate to admit it, but I didn't really make it. But it makes a lot of sense to me. So you need to divide the institution into COVID positive, COVID negative areas, and you need to have the standard operating procedures which you need to define in your thing, and you need to think about alternative. Now let's have a look at what are the options that you might end up with. So the emergency patient is the one who's got to be operated within 24 hours. Some facilities will give you an RT-PCR test. Some facilities will not give you an RT-PCR test. But if this is the patient that we're dealing with, we're talking about emergency patient and we're talking about urgent patients, so they can all be sort of clumped together into one group of patients. What you need to do is, and again, we've all gone into what is an emergency, not an emergency. Remember, if you have to operate, you have to operate. And you are a surgeon, you need to pick up your scalpel one day and operate. But always, even in the emergency, do a rapid test, but do send your RT-PCR off different reasons so that get your history from the patient as much as you can, in terms of contact tracing, in terms of travel, other family members, prolonged cough, etc. Look in the social contact. More importantly, what is his background? Does he have a lot of problems which are happening? And remember, the inflammatory markers are your best bet in terms of where you're picking up this guy. So if he can be right in the peak of his inflammation, or he's developing into an inflammatory phase, that's the one who's going to give you a problem. And these are the basic investigations you need to get done. So at the very basic, get your CRP, D-dimers, and ferritin. I mean, that will actually give you an idea where you are with your inflammatory cycle. All these patients, needless to say, personal protection equipment, regional anesthesias, straight into the OT, straight out, no pre-anesthetic rooms, less pre-anesthetic conversation. One, the designated person does it. You don't want to send your resident to start fiddling around and then come and rescue him in the middle. You want to be there. You want to clean your hands, get in and finish this and quick off. Very little role now for fixators and all. And much better you take him once, you fix him, plate him, and get him out. So that's again another story. I'm not going to get into it. So remember, few personnel. We don't want to crowd the room with a hell of a lot of people and expose all of them. You don't want a crowded OT. You don't want a pre-anesthetic area. You need to doff in and out in or just close to the OT and have a bath when you finish off. Remember, these are the ones who are almost sort of proven COVID positive or that you can't test. Consent, very important. He needs to be made aware that, look, it's all being done for his best interest, but things can go wrong. If you're in private practice, make sure you tell them that the billing will go up. And if the patient cannot afford that kind of a billing, I think he needs to go somewhere else. Every patient has a potential of ending up with the ICU. This is the next category. Here you have some amount of time. So, I mean, needless to say, you got 24 hours. You actually go in and actually check his RT-PCR and you operate only when the results come. These are the kind of things, they're talking about. People who already, had a fall. These are the kind of semi-urgent scenarios which you have. Patients already had a fall and was already proven positive, carcinoma lung with a periprosthetic fracture, COVID positive. And these are things which are happening every day. So you need to have some sort of a treatment plan in your mind. So these are all things you will have to sort of go with the idea, look, I need to sort of sort this out. You can't just keep sitting around. So here's some of the evidence which looked at what happens in semi-emergency. It's very confusing, I can tell you. So one paper which came out in the semi-emergency was looking at the proximal neck of femur. This man tells you that actually if you stabilize them, you can rehabilitate them better. Then you look at this paper which comes out, which tells you that if you actually end up having these patients who get picked up, high chance of developing a complication. So really doesn't help you too much, but if there is a chance for a few days of delay, you cannot leave a fracture neck of femur waiting for 10 days. It's not going to happen. You are going to kill it irrespective anyway. So there's a third paper which I haven't mentioned, which is about the fact that if you do a CT scan, you will see a lot of things. So what would you do? My suggestion to you is do a repeat RT-PCR again if you think there's a discrepancy in your findings or something, and then you can do a CT scan. Just keep a check on the blood, check the inflammatory markers. Don't catch him at the peak of his cytokine storm. That's a big thing, and you might need to ventilate this post-op. You need to have this SOP which runs with the anesthetist involved with it, who are actually going to sort of have some sort of the protocol in terms of less patient contact, less face-to-face, quick in, quick out policy. Where are you going to operate on them? Where are you going to put them? Even the GDA who's going to transport the patient needs to be provided and looked after, as Vivek just told us about. So now this is the most contentious area. Should you do elective surgery now? Should you not do elective surgery? I remember I said, so if you really want to be sure, do at least 2 RT-PCR tests and you add it to a CT scan. Now you're really reducing the chances that you actually miss something. So what is not an elective surgery?
Dr.
So
Gurinder,
this,
wind up early, please. Running
sure.
short of
So
time.
these are some of the criteria which can be used. And why would you like to postpone? As I just said, you're trying to protect the other patients, you're trying to protect the other people. So this is one strategy which came out about how to do this in terms of where you are and what is your threshold capacity. And then you can decide how to take it forward. So you can think about of offering some alternative surgery, which may not always be available, but you need to keep dividing and triaging these patients to who's a high risk, low risk kind of a thing. These are the kind of patients who maybe you should not try to operate. And remember, the anesthetist has to be taken in consideration for regional anesthesia, avoiding general anesthesia. Your operation theater has to be set up. There are papers available which actually help you. But the best one which came out is what David Parvezi, who collected a group of 77 people and asked them questions about getting a consensus. Remember, this is a consensus-based treatment in terms of when should you think, when should we actually go ahead and start operating? What are the issues we need to look at? And this is a fairly good paper if you want to read. It came out of the American JBJS, but talked about who should not get operated, when should you get operated, what kind of facility should you have, what kind of a test you have. This is all a consensus-based statements on about 77 experts. So there are some help from the literature, not an evidence-based kind of a literature. But once you get this kind of a set up properly, get your pre-anesthetic checkups done, and normally that would help you start off or kickstart your work. But where and how is what you need to pick up. Thank you so much.
That was an excellent presentation. Thank you very much for winding up in time. And I think Dr. Samarjit, please ask the second.
I'll now invite Dr. Uh, Faruqi, Kamran Faruqi for his talk on spine trauma surgery in COVID times. He is professor at AIMS and will give some insight on that. Faruqi, you're not possible, yes.
Yeah. One second. Right. Can you see my screen?
Yeah, can see it and hear you well.
Okay. Thank you, Dr. Samarjit, Dr. Dhananjay, and DOA for inviting me to give this talk. And my talk has been actually made very easy because Vivek and myself work at the same center, and obviously the protocols we follow in the emergency are same. So I would just be sharing my experience regarding specifically to spine trauma during this pandemic. So we all know, I mean, I'll skip through this since we are running short of time, that we started the lockdown on 24th of March and it was ended by the 31st of May. And then gradually the restrictions kept easing off, and so that's how we managed, and different stages that we have gone through of treating trauma and particularly the spine trauma. The only thing I would highlight from this is that we chose to defer elective surgeries, that we are not doing any elective surgeries, and in fact at AIMS all routine OPD admissions have been suspended, and they are extending the suspension of routine surgeries till now, and we don't know how long that will last. So the only thing we are operating now is emergency surgeries, life-saving surgeries, and trauma, and oncology in orthopedics as such, with regards to orthopedics. So these are the only two things we are operating at the moment, and we are not doing any elective work at the moment. So we all know this. I mean, we have almost crossed 6 million worldwide, and even in 62 million worldwide, and India also the figure stands at 93,000. In Delhi itself, I mean, we are almost 5.5 lakhs, and we know about all the stats. So uh, the important thing to note here is that, from asymptomatic carrier, the transmission can be anything between 25 to 50%. And almost, incidentally, when the patient comes to us in the casualty, and suddenly we come to know the patient is COVID positive. So there are almost 80% of patients who don't have any symptoms, and they by and large asymptomatic, or even the patients don't know that they have any symptoms of COVID, and they come to us only with trauma complaints of trauma and fractures. So that's something which is we need to keep in mind, especially in the emergency department, that the patient can be COVID positive. I mean, the dictum is that take them to be positive until proved otherwise. And orthopedic surgeons are somewhat a unique group, because especially when we are dealing with trauma, we are exposing ourselves in the ED itself, and then if we have to operate upon them. And the reason is that we can spread to our colleagues, to other healthcare workers, and to our family, our family itself. I mean, we have to get back home, and we have our family staying with us, so we can be a source of transmission to them and whoever we can come in contact with. This was an interesting study in which 26 orthopedic surgeons from 8 hospitals, they got infected with COVID. This is from Wuhan, and what they found out was that 80% of the ortho surgeons, they got the exposure in the general ward, and 20% in general places, and only 12.5% was in the OTs, operation theaters, while doing surgeries, and or in outpatient, or in the intensive care unit. I mean, most of the exposure was from general wards, and vice versa, they transmit it most commonly to their family members. So that is something we have to keep in mind, that if we have people susceptible to COVID, then we need to take extra care when dealing during these pandemic times. So the challenges we face as ortho surgeons dealing with trauma and spine trauma is that how do we protect the vital medical force at our center, and to ensure the safety of admitted COVID negative patients, right? So that we don't transmit to other patients as well as to our other healthcare workers and our colleagues. The second thing is how do we manage to optimize the patient before they go in for surgery, and especially while respecting the social distancing measures. And the third challenge that we faced is, especially with the COVID times and all the stress on ICU beds and ventilators, how to procure ICU beds, especially with respect to cervical trauma. I mean, that is something, the big challenge that we have faced during this time is the non-availability of ICU beds, because most of the ICU beds in a hospital have been taken up by the COVID patients, and we need to reserve them. And it getting an ICU bed, especially for cervical trauma, is a big challenge. And that's where I think that's something we have learned during this time, that probably cervical trauma is a big issue. Okay. Another thing that we faced was that because I mean, most of the open spine surgeries do require blood and blood product. So especially during the lockdown in the first phases, which lasted till about end of May, before the unlockdown phases began, there was an issue getting the blood and blood product, because the donations were not coming in, the patients were not coming for donation, and getting a blood product could be a challenge, because the blood banks are running short of donations, so they are not able to provide the blood. So we need to plan for the blood products in advance and inform the blood banks that, okay, we are going to need so much blood and this group, so that somehow they can arrange. And you can only do surgery once the blood is arranged. Another thing was, especially initially, when the lockdown was just imposed, in those times there was an issue in getting the company guys to get the implants, because I mean obviously no hospital keeps all the implants, so we have to order the implants, and the implants have to be supplied in time, one day before at least, to the hospital for sterilization, etc. So getting those implants was again a challenge, but somehow we circumvented that by issuing them letters that they are supplying hospital or medical related stuff to the to the hospital. And even with those authority letters, they were allowed by the police personnel and the traffic personnel to come to our hospital, so that we worked out the solution, but that was initially a challenge. So with the beginning of the lockdown and the surge in cases, what happened was that trauma center JP and ATC was closed down, and we shifted to main names, and we were allotted. Thankfully, we were allotted beds, and the whole trauma care facility shifted to the main block, and the whole of trauma center was converted into COVID-19. However, although we did have a slight reduction in number of cases and trauma cases which reported to our ED initially, but then being the tertiary trauma center, and I guess we were one of the few, very, very few centers who were dealing with spine trauma as such. So we did continue to get a lot of spine trauma cases even during the pandemic and lockdown period. And especially once the lockdown has been lifted, then we are getting a big surge, like not exactly a surge, but the number of spine trauma cases which are coming in has definitely increased. So what the protocols like are more or less the same, which we have followed. I mean, initially when RT-PCR and CBNAT were not that universally available, what we did was that all the patients who came, they underwent rigorous temperature checks and screening for risk factors. And then the patients who were suspected of having any symptoms, they were isolated in a designated gray area. And then COVID testing was done only for them. Initially, we were not testing all the patients when the kits were not that universally available. So initially what we're doing is we were doing a symptomatic screening, and only patients who were suspected were being tested. However, and then obviously all the patients and attendants were, we insisted that they should wear a mask, and they were resuscitated. Everything else was according to the ATLS protocols. The only thing was that we were taking care to wear all the PPs, and all the residents who were there in emergency department, they were taking all at least level 2 or level 3 precautions. uh, Later when we started getting, they were the kits were ubiquitously available, then what we did was that the protocol shifted to test based strategy. So whichever patient we were thinking, especially with spine trauma, of operating and admitting, they were done either a RT-PCR or CBNAT test. So that is the protocol we are following now, that all the patients who require admission before spine trauma, we do a RT-PCR or a CBNAT on them. And only once the patient is negative and then we get the report, can the patient be shifted to the ward. So that is the protocol we are following. We get the testing done in the ED, and only then, once the patient is negative, do we shift the patient to the ward. And all the healthcare workers in the emergency department, they wear the PPEs as per our institutional protocols. So the minimum basics is N95 mask, a face shield, a level 2 or level 3, especially those people who are going to deal with the airway. If the patient in the red area, they are wearing a level 3, I mean full precautions, and otherwise our residents are wearing level 2, gloves and boots. So that's a level 3 PPE. So this is for people who are going to deal with the airways, and otherwise our residents are wearing a level 2, that is a cap, a mask, a visor and gloves. So that is the main thing that we stress on in the emergency department. So once the COVID negative status of the patient is established, then only we transfer the patient to the ward and try to put them, take them to the operation theater as soon as possible. However, if the patient does test positive, then what is to be done? Then what we have done, what we have carried out is that we transfer the patient to our dedicated COVID care facility, which is the trauma center now. Once the patient turns, it's sent to the COVID care facility and taken care of there by the dedicated COVID team. And once the patient is COVID negative, then the patient is taken back to a trauma ward and then operated upon. So that is the protocol we follow. I mean, test all the patients of spine trauma. If they are negative, we admit them to the ward. And if they're positive, we send them to the trauma care center and to the COVID center. And once the patient turns COVID negative, then we transfer them back to a trauma ward and operate upon them. And even in the COVID center, there is one orthopedic consultant at least all the time who takes care of and residents who take care of all the orthopedic patients who are COVID positive and who have been transferred to the COVID center. In the wards, we make sure that, because the visitors are not being tested, so make sure that at least we have a minimum visitor policy and only have a visitor if it is essential. So that is one thing, because we are not testing the visitors, so we don't have any control on them. So that's why we have a minimum visitor policy. Another thing that we did initially when we were not that short of beds was to have a social distancing between two patients. That is that we implemented by keeping alternate beds vacant. So we didn't have the patients admitted on consecutive beds, but we kept one bed vacant between two patients. So that is another form of social distancing we try to do. And all the nursing staff, all healthcare workers use PPE. As you know, strict emphasis was used on use of visors and PPEs whenever we are in touch with patients. Extremely frequent use of alcohol. Every time, on every bed we used to use sterilium or any other alcohol based sanitizer. And we did daily rounds with minimum. Another thing we did was reduce the number of residents. So only on-call team and the ward in charges were the residents on rounds, and only one consultant took round at one time. Normally, I mean, we have a big team, but we made sure that only the bare minimum residents who can carry out the work, and only one consultant did the rounds. And among the anesthetic considerations when dealing with these patients, because anesthetists are at the higher risk, because these patients, I mean, mandatorily require intubation. So I mean, they are the anesthetists are the highest risk of catching a COVID infection. So all the pre-anesthetic consultations were done only after a COVID negative report. That is one thing we did. And even on the day of surgery, before the patient is wheeled into the theater, a reassessment was done for any risk factor, because we tested. Another thing which we followed, another protocol which is strictly followed at our hospital, is that all the COVID reports are valid only for 72 hours. So if the previous report is more than 72 hours, we have to get a repeat COVID done, and RT-PCR is done, or CBNAT. But we don't take a report which is it is not valid if it is more than 72 hours old. So that is another thing. So repeat testing.
Dr. Faruqi, wind up, please.
Yep, I'm more or less done. I mean, from anesthetic point of view, so I'll just show you. I mean, we operated about 36 patients over this times, and 4 patients had tested positive, which were sent to the COVID center, and we operated on them once they were COVID negative. So this is just a data I'm sharing. 36 patients were operated during the COVID times, and 22 burst fractures, 8 chance fractures. Unfortunately, we could only operate on one C-spine, because like I said previously, getting an ICU bed and ventilator was a big issue. So that is why, I mean, others are as expected, distributed equally in upper dorsal, dorsal lumbar, and lumbar as expected. The only outlier here is the C-spine, that we could only operate on one C-spine which did not require a ICU bed. So that is the only outlier that I would like to say. Rest of the things are, I mean, more or less routine. I mean, as expected, most of the cases are concentrated about dorsal lumbar, lumbar and mid dorsal region. So I would say the only challenge we faced was getting the ICU bed, and C-spine was very less. Most of the patients were were actually anesthesia ASA grade 1. So that was not big, but however, we did have patients who had chest trauma, and there were patients who were anesthesia grade 2 and 3 as well. So what I would like to say is that they were reduced during this time, but still we did continue to get spine trauma, because we are at tertiary referral centers, and probably spine trauma was not being operated in close by NCR region and nearby area. So most of the referrals were made to our center. All the surgeons use. I'll just show you a photo. We did the precautions we did was. We used the PPEs along with the visor and N95 mask. We did not use much of pulse lavage, and we tried to do minimally invasive surgery wherever it was applicable. So this is the kind of visor we wear along with the N95 mask. We do have respirators. The only issue is that voice transmission becomes a bit difficult to communicate with the residents once you are wearing. So we use N95 and a visor, and obviously the full PPE kit. In the post-op care, we tried to discharge the patients a bit earlier, as soon as possible, so that they're not exposed to COVID infection if it's happening in the hospital. And the other thing is that we have to differentiate between any chest infection that they might have and possible COVID-19 infection. That's something we have to keep in mind. In the post-admission care, I mean, we do repeat the COVID test after 72 hours, and especially if it is suspected. And
Sir, please wind up. Please wind up.
yeah. Okay. So on discharge, teleconsultations were given. We did continue to carry on our academics. And to summarize, now COVID is part of our lives, and we need to continue to do academic research as well as patient care. Thanks very much.
Thank you very much for an excellent presentation. And the question and comments will be taken after the presentation. The next talk is by our president, Dr. Sarad Agarwal. I invite him for the talk, and the topic is multi-specialty versus only ortho-specialty hospitals, which are safer in these COVID times. Dr. Sarad Agarwal, please.
Thank you. Thank you, Dr. Tomar. I'll just share my screen. Is it visible?
Yeah, it is visible.
Right. Thank you. I was a bit intrigued when I was asked by Dr. Dhananjay to speak on the difference between a care in a multi-specialty hospital versus only ortho-specialty hospital, and which one is safer for surgeons. Actually, this is the topic he had given me, which is safer for the surgeons. So I sat and thought, does it make any difference? And when I start analyzing, because I could not get much data in literature on this particular point, but when I sat and thought about it, I think I could see that it does make little difference. My job has been made easier by most of the speakers who have spoken earlier. And so I would be just rushing through some of the slides. A few points I want to emphasize that Dr. Treka said that 87,000 healthcare workers were got involved with COVID till September. And Dr. Kamran has quoted a Chinese study in which they said that 80% patients, doctors got infected in a general ward. So it does make a difference where the orthopedic surgeon is working and how he's conducting himself during this period. This we all know about what causes coronavirus, but one important point in this is that a number of patients are asymptomatic. So they will not be knowing who patients can be infective, who may not be infective. And another important point for us is there is an increased susceptibility and mortality in patients with multiple comorbidities, including old age, obesity, hypertension, pulmonary cardiac problems, and diabetes, if they are operated during this period. Mostly this symptomatic treatment. The dilemma and challenges for the orthopedic surgeons, which Dr. Gurinder has brought out very well, that there is an exponential expansion of the patient population in need of hospitalization, surpassing all available sources. So it's going to impact all fields of medicine, and similarly so orthopedic surgery as well. And I said earlier, there is a number of patients who are asymptomatic and become a carrier. So the dilemma of orthopedic surgeon would be that orthopedic surgeon may have to despecialize, that he may have to leave orthopedics and start taking care of COVID patients. And at times he has to take care of surgical emergency, orthopedic emergency in COVID patients, which leads to high degree of anxiety and depression. What would be the safety measures for orthopedic surgeon? What would be to postpone the elective surgeries so that you reduce burden on the healthcare system, and make more availability of bed to the hospital. But it becomes difficult how to decide which case to do, which case to be avoided at the moment. And in the process, at times, the emergent and urgent patients may get affected. Give you a couple of examples, like this patient having a failed hip. Now he got disabled, he got pain, he's got discomfort. How long can we ask this patient to wait? I mean, in our situation, we had to make this patient wait for at least 2 months before we could operate him. Or there is another lady who has such kind of disability because of degenerative arthritis of the knees. When we can give a result of the kind which is the same patient on the right side with a total knee replacement, how long can you ask this patient to wait? So such cases become a dilemma whether to make the patient wait or we go ahead with the surgery during this period. So how to identify an elective procedure? Ohio Hospital Association have defined elective surgeries as the one which all accept, which are threat to the patient's life or to an extremity or an organ. There is a risk of metastasis and progression of disease, or there is a risk of rapidly worsening to the severe symptom. Such situations, we may need to intervene early. Otherwise, all others we can take as an elective surgery. And similarly, stable and unstable diseases have been defined, where stable cases we can postpone, while unstable cases needs to be operated. What will postponing elective surgery would do? It reduces the pressure on the hospital, save resources, diminishes perioperative complications, and reduces unnecessary patient traffic, decrease the spread of disease among patients and the health care provider. Awad et al. Have come out with 5 categories, A being the most urgent, and E, in which they have taken deformities, arthroplasty, and trigger finger as grouped under E, which can wait for a longer time. Dr. Gurinder has extensively discussed this particular flow chart given by Awad et al., where we divide the patient into emergent, urgent, and elective. In emergent cases, we cannot sort of test the patient, operate like a positive patient, and then decide later. In urgent, we do have a time and then decide, and elective, of course, can be made to wait. So what can orthopedic surgeons do? What precautions we can take at different stages of a patient to protect ourselves? In outpatient cases, as clinic, we need to screen the patient. If they are positive, then we may have to ask them to wait. At preoperative phase, you look for simple different signs by temperature and oxygen saturation, by medical history, history of travel, and as many other speakers have said, testing by RT-PCR. Similarly, we need to reorganize the hospital ward for COVID patients, creating adequate social distancing, having basic precautions like wearing masks, adequate disinfections, and make exclusive wards for the COVID patients. A number of visitors have to be minimized. During the perioperative phase, again, different speakers have spoken. We need to have separate OTs for the COVID patients. We have proper ventilation system, and only necessary material has to be brought into OT. We minimize the number of personnel in the OT, and traffic has to minimize, and all personnel has to wear adequate PPE. It has been emphasized again and again that regional anesthesia is better and than the general if possible. Or if at all patient has to be put into general anesthesia, it should be intubated in a shortest possible time to protect person from any risk from the health workers, to protect from any infection. Surgical procedure should be done by the highest skilled surgeons, so to avoid prolongation. Minimally invasive approaches should be considered so that can shorten the duration of surgery. Electrocautery and power tools like bone saws, reamers and drills used to be minimized to avoid aerosols. Such patients to be transferred if they are COVID positive or suspected COVID patient to isolation wards through dedicated corridors. Surgeons should be aware of common post-operative complications, and if they are positive, then to be managed as per protocol. Standard enhanced recovery protocols to be followed in post-operative phase, which means the hospital stays to be minimized, and most of the work of telemedicines and telecommunications, including for further consultation, physical therapy, and follow-up. Now, what happens in a multi-specialty hospital? What can we expect in a multi-specialty hospital? Either it will be a partially or fully COVID hospital. There we expect heavy influx of COVID-19 patients. The maximum resources and manpower of the hospital will be directed toward COVID care, and less resources would be available for orthopedic patients. Orthopedic surgeons may be asked to do COVID duties, and there would be, as I said, many asymptomatic COVID cases which we surgeon may not know and get the risk of getting infected. Orthopedic surgeons may have to get involved in COVID patients having orthopedic emergency. So there is high chance of healthcare staff, including doctor, to get infected. As compared to that, in an ortho specialty hospital, it may not be most likely it will not be an active COVID facility. So it unlikely to be overwhelmed with the COVID patient. And majority infrastructure and resources should be available to the orthopedic patient, and it becomes easier to set protocols to prevent COVID cross-infection. As we understand, the protocols for orthopedic surgeries during pandemic are different than other specialties. In a orthopedic specialty hospital, become possible to enforce these protocols more rigorously, train the staff effectively, including for orthopedic work and orthopedic specialty hospital. So another aspect of safety is telemedicine, which can be used at many stages. to deliver safe advice to the patients, can be used for patient triaging, post-operative follow-ups, monitoring the patients, and rehabilitation. But at certain stages, it cannot be, in certain situations, cannot be used, like for suture removal, cast change, or some cases where you need a clinical examination. And there can be many obstacles also in this wide implementation, which include infrastructure costs, education of the patient and the provider, data protection, ethical and legal questions, and the payment regulation. So to conclude, friends, the data suggests there is an increased likelihood of orthopedic surgeons to engage with COVID-19 patients in the hospital, more so in a multi-specialty hospital. Occupational hazards to orthopedic surgeons and other healthcare workers, also to the families and neighbor, would be there if the healthcare workers are exposed to the infection. Orthopedic surgeons should prepare to take proper precautions against occupational risk of exposure, especially in asymptomatic and mildly symptomatic surgical patients. In preparation, consider increasing level of protection and infection control and their implementation during different phases of pandemic. It will be easy to implement such measures in an ortho specialty hospital where more infrastructure facility shall be available for orthopedic patients. Easier to set protocols, enforce them rigorously, and train the staff effectively, exclusively for orthopedic work in those hospitals. So orthopedic specialty hospital may be safer not only for orthopedic surgeons, other healthcare workers, but also to orthopedic patients as well. All in all, one has to believe that medical practice, including orthopedic surgery, will differ after the pandemic is over. Implementation of new technologies, restructuring our health system with incorporation of telemedicine has to be considered, as well as organization of our traditional training programs will be crucial for a more effective and optimal delivery. Thank you.
Thank you, Dr. Sharath. Because we've been running late in the session, and since we have a GBM which is taking priority over this, the orders are from organizers to carry on with the GBM first, and remaining two talks will resume after the GBM. So I think we'll disperse for the GBM, which is also again online, and link is already probably shared with everybody.
Thank you.
We'll be going up with the GBM at this stage.
There are three presentations left, and we'll resume this presentation after the GBM is over. Thank you very much for all the speakers and the panelists. Thank you very much for this inconvenience.
ये GBM का link कहाँ है यार?
Yeah, Dr. Dhananjay, is that okay?
Please, I mean, as per the Constitution, GBM takes precedence over any other session. You have to have minimum 50 number of participants in the GBM to make it valid. I mean, this is a constitutional requirement. And since this is a DOA event, we really cannot, interfere in the sanctity of the GBM. I'm really sorry, and I do apologize, but somehow, I mean, I couldn't get away from it. We'll try to wind it up as soon as we can. And what else we can do is we can simply resume the session C on time. That is a priority, because the session which was running late, that remaining talks we can take up later on, subsequently, whenever. And let's see. Let's keep the fingers crossed. Let's hope that the GBM gets over fast.
Okay, just thanks to everybody. I will not be able to join later because I've got another webinar that I'm involved with. So it was interesting and I really enjoyed the talks, but unfortunately I won't be able to join in the later session.
Dr. John, thank you so much for joining us, even for this small time. We really appreciate, and we apologize at the same time.
No, not a problem at all. No, I enjoyed it, so that's okay.
Thank you so much.
Sure. Okay.
Thank you. Thank you so much.
Thank you, Vivek.
Thank you, everyone.
Ravi, does the link change for the GBM or it is the same, this one?
There's a separate link for the GBM for the Delhi Orthopedic Association members only.
Okay.
And it has been shared widely through the Gmail. I mean, all the mails from the DOA as well as on the various groups which are available on WhatsApp. So
we exit this group now to join that?
Yes, please. But it
So
won't.
can I just say something?
I mean, people, they can stay on this group, or they can go to the main hall and go to the poster and see the posters or the proceedings in the hall B. They're still on of whatever we had done. We had conducted sessions in the hall B in the morning over there. You can see them. And moment we finish the GBM, we'll be back here. Anyone who wants the link for the GBM, let me know now. I can WhatsApp the link immediately right away.
Dr. Dhananjay,
Yes.
sir, that GBM link, some people are having problem with that link. So I would
Yes, but I
recommend
did try. I did try with the password, and with this thing, I was able to.
Yes, ID
log.
and password is working. So
Yeah.
link, if it's not working, then we should log in with the ID and password. That's the only thing.
Yes, precisely. Thanks, Manisha. Thanks.
Dr. Dhananjay.
Sir.
Dr. Manocha here. Please send me the link. I have not received
All
the
right,
link.
fine. Coming along, boss. We are waiting for you in the GBM.
Right, thank you.
Yeah. ठीक है, देख लो कराओ, जो भी है फिर उसको बोल दो, डॉक्टर अभिलेख को बोल दो फिर।
Hello, Ravi.
Hello.
Amite, Dr. Amite
Hi.
Pankaj.
Hi,
Hi,
Dhananjay.
welcome.
How are you?
Can you
Hi.
just start getting your panelists on board so that we should be able to resume our session shortly?
I have requested Dr. Shekhar Agarwal and Dr. Yash Gulati. I got a message from Dr. Maheshwari that he'll be joining late.
Okay, no problem.
So let us hope for them to join, Dr. Yash Gulati and Dr. Shekhar.
Yeah.
Hi, good afternoon, Dr. Amite. How are you?
Hi, Manda. I'm good. How are you?
All brilliant.
So I see one of the Bhavuk is there. He's going to our opening batsman for this session. I can see Dr. Ramesh Sen.
Yes. Hi, Dr. Bhavuk.
Good afternoon, Dr. Sen. And
Dr. Chabra is
Dr.
there.
Chabra also. Dr. Chabra also.
Sir, can you confirm that first there will be Dr. Malhotra's talk and then our session will start?
Dr. Dhananjay?
Bhavuk
Dr.
sir. Bhavuk sir.
Yes, please.
Malhotra's talk and the other two talks that were of the last session, we will
Yes.
continue after this session. You continue with this session, sir.
Okay.
So as I see, I think we are almost ready. I'm just waiting for the panelists to come in. So can anyone call these gentlemen, Dr. Shekhar and Dr. Yash Gulati?
Sir, Shekhar sir is in GBM. He is coming in a while, sir.
Okay, so I think we can start. Is that okay? If we
Yes,
go
sir.
ahead and then let this guy. Okay. So good afternoon and welcome to this very interesting session, which is the future of futuristic orthopedics. So as we all know, realize on day-to-day basis that technology in orthopedics is coming in a big way, and some of the technology will be here to stay, and some of the technological advances will not give us any tangible advances over the others. So let's hear the 6 beautiful talks on this topic. So to begin with, I think let me just go through the program. It's Bhavuk who will be speaking on role of AI in orthopedics. So over to Bhavuk.
Thank you, sir. I hope my screen is visible.
Yes.
Yes. So
please go ahead, sir.
So I thank DOA for giving me this opportunity to speak on a topic which is very dear to my heart nowadays. So speaking about the artificial intelligence, we know that the data volume and complexity is growing day by day. And if we look at some of the statistics, we can see that every 73 days, the medical data is doubling every 73 days. And the number of people, the number of financial data is also increasing day by day, and we also are realizing that there is a global shortage of healthcare workers is going to be there by 2035. So this is actually a mismatch between the data and the volume of the work which we have and the workforce which we are going to have in near future. And we have already realized, and there is already data that the 45% of the medicine which is being practiced is not evidence based. And if we have to keep up with the new professional insights in the form of literature, we have to read approximately 29 hours per day, which is not possible. And the US data that the number of retail prescriptions they need to fill every year is going to be in billions recently. So coming to the artificial intelligence, this term was coined by John McCarthy, and it basically denotes that the computers, they could learn to perform the task through the pattern recognition, which we as human do without our involvement as such. So basically machines, they develop some sort of algorithms that provides the machines the ability to solve the problems that traditionally required the human intelligence. Just for an example, like in Netflix, you watch some movie and then the Netflix suggests, the type of movies which is according to your taste and your likings. So you can choose from those pictures. If you go and you browse certain website for some product or some clothing or accessories, you will soon getting those pictures on your social accounts or or in your ads will start coming on your apps regarding this. This is all AI. And this is the same example. If you buy a product on Amazon, you will soon see the products which the other customers they have bought, whosoever have purchased that product also. So this is all sort of AI, and in this presentation which I'm going to give is already have component of the artificial intelligence. This PowerPoint presentation which I have formed with the new Office 365, it has got artificial intelligence inbuilt, which gives you the backgrounds and the format of the slide as per the content of your presentation. So the artificial intelligence, the landscape is quite wide, including from robots to machine learning, which we are going to discuss the different aspects of the artificial intelligence. And this is changing rapidly, from face recognition technology to the self-driving cars. The artificial intelligence is shaping our future in a very rapid way. So if we look at the broad aspects of the artificial intelligence, so if a machine is able to mimic the human intelligence by anything, it is called the artificial intelligence. Whether it is about dictaphone or anything which can mimic the human work, it is artificial intelligence. A sub part of it is the machine learning. When you involve some sort of maths and statistics and you develop some algorithms where the machine can improve itself, then we call it as the machine learning. And then there is a further subset of machine learning is called the deep learning, where you use the complex neural networks like the neurons in the brain. There are complex algorithms, which can process the images, the audio and the videos, and then they can transform into some meaningful data which is useful for your day-to-day practice. So if there is a question, which is frequently asked: what is the difference between the machine learning versus the statistics? So it is all about the prediction versus probability. Statistics tells about the probability. So if I tell you that the 90% of the hippies, they take drugs, it is the statistics. But if I tell you that by looking at the picture of hippie, I can tell whether he has taken drug or not, this is called the machine learning. This is the prediction. So this is just a simple definition. The another terms which we commonly heard in artificial intelligence is about the supervised versus unsupervised machine learning. So suppose if I have got 1,000 X-rays of proximal tibia fracture, and I give it to a artificial intelligence machine, and I tell that machine that this is type 1, this is type 2, this is type 3. And so if I will give this machine 100,001 X-ray, so that it can tell that it is type 1 or type 2 or type 3. Schatzger X-ray. So this machine can learn. This is called supervised learning. The unsupervised learning is that if I just give the 1,000 X-rays to the machine and I don't tell which X-rays, which type is this thing, so the machine can come up with some new classification on which it has itself recognized some unrecognized patterns, and what are the clusters, of the different types which the machine thinks they are same to this. So you can you can look for the patterns which are not recognizable by us as human, but the machine can predict the pattern. So this is important. This is called the black box phenomena, where we are giving the input into the machine, and then it gives us the clusters. So it gives us the differentiation between these factors. Suppose if I have we know the Lenke classification about scoliosis, so there are 6 types. But if I give it to the machine, then machine can give up maybe around 42 types or maybe around 50 types, which are behaving differently as per the machine. So these machine algorithms, they can be run unsupervised, but you can also frequently validate, after 100 X-rays, you can see whether the machine has validated it or not. So there are frequent validation can also be done. So partially supervised machine algorithms are also there. The deep learning basically employs the complex neural networks in which you can feed multiple data, and then you can look at for your particular outcome. So this is called the deep learning, when there are complex algorithms, multiple running into this thing, which are frequently checked by themselves, and then they are amalgamated into another complex network. So it is a form of very complex artificial neural networks, and there are special softwares and there are special machines for this. So these are called the artificial neural networks. So just for an example, like if we look at the human decision making as a basic step, then if we go from above, for different types of machine learning, then if we look at the Google diabetic retinopathy, so the if you just take a picture of the retina, any technician can take, or a machine can take, just by looking into it, the picture of the retina, and then it can tell you about the grading of the diabetic retinopathy without involvement of any doctor or any technician. Then it is the an advanced form of artificial intelligence, this thing. The another type of artificial intelligence is the natural language processing. So natural language processing means when the computer can understand, read or write what human can read or write. This is very especially useful in electronic medical records. So the computers can record whatever is available in the form of electronic medical records, and then it can itself formulate, or it can process the future medical records. Suppose if I tell that I want to book this patient for carpal tunnel syndrome, I have to just give this instruction, and then the computer will itself see his blood reports and his other parameters, whether he has got hypothyroid or not, if he needs an endocrinologist opinion first, or what are the precautions you need to take, what are the preoperative treatment, how much prediction is there that he will improve after surgery or not, what instructions to the patient need to be given. Everything can be just done by the computer in the form of a machine learning, and it can be processed like that only. The another thing is the Internet of Things. So when we all have smart devices now in the form of the wearables. We have the smart watch, we have the smart pad, we have the smartphones. So if we can incorporate these smart things into with the artificial intelligence, it is called the Internet of Things, and it is also known as the mobile health. So this is very important in today's world. So we have the wearable sensors also. So suppose if I am prescribing a patient a brace for a scoliosis, and I just incorporate a sensor into that brace, I can monitor how much time the patient is wearing the brace, and what are the times when he or she removes that brace, and what are the factors related to that why he or she is removing the brace. Similarly, if a patient of total knee arthroplasty, if I am going for rehabilitation, I can incorporate a small sensor into the implant itself, and then we can see that the how the patient is rehabilitating, whether it is properly being done or not. So these are called the remote patient monitoring, and we are moving ahead with this. And the major applications in orthopedics is coming up, especially in the image recognition, preoperative risk assessment, clinical decision making, analysis of massive data, and the predictive analytics and risk prediction. So there are several papers are coming up which are using these artificial learning technologies. This is an example of a 3D spine model vector formulation and automatic detection of the AIS. It is being replacing the school screening programs nowadays. We have this EOS machine, and we can do a 3D reconstruction with this, and then we can draw these sort of special diagrams which we call as the Da Vinci view, which we can see the rotation of the vertebra. And then people have also started looking at the different unsupervised learning clusterization of this thing, because the outcome is being seen that it is depending upon these factors. We have collaborated with the Lieutenant Dunstable University of UK at AIMS, and we are identifying the manufacturer and models of an orthopedic implant, which is the IMPRO project. So we just feed the X-ray, and this machine can tell us which company, manufacturer, and model of this implant is for any revision surgery. The another aspect is the FHIR, which is spelled as the FHIR, which is the Fast Healthcare Interoperability Resource. So we have the different electronic medical records, and we can combine it with the artificial intelligence. And similar on this pattern, we have developed this SRS-22 Hindi validation, and we have the Hindi version. So we have developed this app at AIMS, which is the ASICS apps, the AIMS Spine Initiative, Crooked to Straight. And in this, we gave the option of patient filling up the choosing the Hindi and the English versions, and then he or she can take up at different follow-up schedules. They can take this score, which has got various components, and then we can use this scoring systems into predicting whether the patient is what should be the outcome of a particular patient or a particular type of scoliosis in this thing. Another area in which we are working is the integration and application of AI in care of patients with scoliosis. So how to classify X-rays and what should be the fusion levels. So we have funding approved from the ICMR, and this is being done under the AIMS IIT Delhi collaboration. The another project which we have submitted to DHR is predicting surgical complications in patients with pediatric spinal deformity under AIIMS IIT Delhi collaboration. So basically, again, we are going to use the artificial neural networks in this program. We have certain clinical data and the radiological data, which we have for approximately 500 patients, which we have operated in last 9 years of these pediatric deformities. And then we are going to feed relevant clinical laboratory and radiological predictive risk factors. And then we will have a training set of 80% patients. Then we are going to test the findings into 20% of the patients. And then we will have certain outcome measures, the various prediction models, and we will use the artificial learning. So this is the way which we are progressing, but there are certain more applications. There are endless applications which one can think of. The challenges are that these are somewhat complex. You need somewhat specialist to have to help you in developing these protocols. There are some ethical issues because patient sensitive data is being tackled. The another problem is the adversarial attacks, when someone can manipulate the data, whatever is being fed, and then there is a de-skilling, because some people think that it can de-skill our clinical skills of a physician. But one thing is certain, that we must merge the health and the health data to give the best outcome. And the important thing is that we at human, we excel at the common sense, compassion, and the morals, and the AI system excel at the pattern recognition. So if we can merge these two, then we can have the best AI, that is called the augmented intelligence. So everyone here, we can see that our future is being influenced in a great way, and the best way to predict our future is to create it. Thank you.
Thanks, Bhav. That was really interesting concept, and I think in the future years to come, AI is going to, whether we like it or not, AI is there to stay, and it will influence clinical care also. That's we all. Any questions on this talk? We may have one question. No. Okay, then thank you, Bhavuk. Now we have the next speaker, Mr. Ketan Jalal. He's an engineer by profession. He's going to speak on the scope of 3D printing in post-COVID era. Mr. Ketan, please.
Thank you, Dr. Pankaj. Thank you, Delhi Orthopedic Association, for giving the opportunity. As you mentioned, I am an engineer. I am a biomedical engineer. I'm not a surgeon, but I've had an opportunity to work in this field for almost 18 years. So hopefully I'll be able to give some insights. Let me just share my slides. Okay. My talk is on scope of 3D printing post-COVID era. What we decided to do is we want to share our experience. We are a 3D printing supporting orthopedics, and last 6 months we have had an opportunity to actually support orthopedic surgeons across India, especially during the COVID times, and how we were able to do that. So what we have done is we picked the 3 examples that will kind of share, we want to share and talk about. So these are 3 different areas that we want to talk about. One is a 3D model and how a 3D model was created for an acetabular fracture. Another is that one was in Chennai. The other one was on the surgical guides and how, for reverse shoulder arthroplasty, you can use these guides to accurately position your glenoid component. And the third one is on the customized implant, 3D printed implant. So hopefully this will give you an opportunity to kind of see how you can leverage some of these technologies and actually help you in your day-to-day, especially post-COVID era. So in the acetabular fracture example, the patient had during the COVID time, 84-year-old female. Surgeon was quarantined, so there was not much we could do. We were able to get a CT scan of the patient. We were able to create a 3D model of that patient. So once we had, this 3D model, like Dr. Bhauk said, image processing is still not there yet. So we had to, we use these FDA-approved software for segmentation and creating a 3D model. Once that 3D model was created, we shared that 3D model with the surgeon so that they can understand how exactly the fractures are, in what directions. The model was not enough. The virtual model was not enough. So we actually went ahead and printed a physical model, wherein we were able to send the surgeon that physical model so that he can plan the surgery, he can, place it, he can, use this model to create a pre-bend plate and things like that. Once that was done, and this was done all while he was sitting at home. One of the things we we were able to leverage was to use local 3D printing services, so that we are not spending too much time on shipping and all. Especially, this is another thing we learned, that the whole local concept is going to work in the long run, because in fact, one of our partners in Mumbai were in quarantine region, so they could not even manufacture the part that we wanted to. So this kind of helped us change our plan, and we started now manufacturing these parts very near to the surgeon so that it can be delivered right away. Another example is on the glenoid axis guide, reverse shoulder arthroplasty, fractured scapula, 62-year female. Again, CT scan was done. We created a virtual model. So here's an example of a virtual model. You can see how the the glenoid surface is fairly shattered. We were able to plan the surgery virtually, look at everything, work with the surgeon to identify the exact axis in which we want to do the plan and execute it. For the execution, we were again, able to print it locally. This is a case in Delhi, so we printed locally in Delhi, provided this in one business day, and then using these autoclavable parts, the surgeon was able to place this, use this in the surgery to identify the location and kind of pinpoint the axis where exactly that axis could be. So here's a small video that kind of shows the positioning of the guide, and then drilling it right there. Okay, and then the third one, which is more on the customized implant side, especially with advent of 3D printing and metal 3D printing. Now we are able to actually print an implant that is customized for that patient. So here's another example. This was a case in Baroda in Gujarat, a failed fracture of a talus, male, 35 years old. Again, we started with a virtual model. What we did was, once we had the virtual model, we mirrored the other side, which was a good side. And then once that mirrored model was again 3D printed, in this case also the surgeon was quarantined at home, so we were able to deliver these models and the different sizes of the implant, talus implant component that he wanted to look at. So we created about 6 different sizes, small, medium, large, extra large and extra small. And then he was able to plan even the ligament attachment and how we wanted to do. We continued to send him models, and then we would have a video call to kind of plan the surgery while he was at home. Once that was done, once he approved the design, we were able to manufacture this in a medical certified facility, a 3D printed titanium implant for talus. So here's an example of how that titanium implant was being manufactured here. So these are the these are the models. We ended up having 3 different sizes, so that intraoperatively the surgeon has an option of choosing which size he wants to use. And then yeah, those were post process made ready for the surgery. And these are some pictures kind of in the surgery to show you. We had a trial component, we had the final implant. These are some ligament attachments that he used, and yeah, so this is the post-op video that kind of shows how this is. What is fascinating for us is our ability to mirror the good side of the ankle, and you can see the contours here, and it's fascinating that the contours really match well with the patient. And this is hopefully what helps with in terms of having a patient specific implants and allowing to have a better outcomes in the long run. How does this work as a process? So just a quick overview of the way it works is typically a CT scans are taken. It needs to be 1 millimeter slice. I think that's the most important piece. Is as long as you have a 1 millimeter slice thickness CT scans, we are able to take that in and provide the 3D models. Those get uploaded to platforms like mysegmenter.com, wherein this data gets received, post-processed, visualized, and then you can see the entire traceability of printing as well as delivered autoclavable parts in the surgery. These are some examples of now the advanced these platforms allow surgeon communication as well. Before you used to have these physical models and kind of mark that and talk to the engineers. With these kind of digital platforms, it allows us to also kind of communicate with surgeons on what exactly they are looking for, so that while they are at home, we are able to have these communication details that help us kind of move forward and get their feedback whenever they are free. Not, especially especially in these COVID times, it becomes very difficult to get their physical time and actually meeting them physically. So we've moved more towards a digital platform wherein we can communicate through these platforms. This is kind of the network or how things work. The surgeon and the hospital staff uploads the CT scans. The surgeon is able to look at the 3D model on their phone or on their computer. Of course, they are also able to use the guides and the models or even an implant in the surgery. The patients, the link is open, so the patients, we were able to incorporate like a payment portal so that the patient is actually making the payment through the same portal. And then the 3D printing service bureaus who are locally there near the surgeon is able to print it quickly and then deliver it as soon as they can. So in conclusion, the 3D printing technologies are here to stay, especially with COVID era, especially when you have complex surgeries, and it actually does help surgeons plan and execute with confidence, especially whether it's anatomical models, surgical guides, or customized implants. With that, I want to thank you, and over to you, Dr. Pankaj.
Thank you, Ketan. That was really very useful talk and insight into 3D printing. 3D printing, as we already know, it has found a place in clinical delivery of healthcare and orthopedic care. So, I mean, and I can see Dr. Shekhar has joined us. So, Dr. Shekhar, do you have any comment to make or question for Ketan?
Hi, Amit.
Hi.
I joined just now, so I won't be able to make any comments.
So I can see Dr. Shekhar Agarwal also there. Is he there or not? Okay. I have a question for Ketan.
Yes.
3D printing has a lot of applications in tumors, trauma, and the specialty that I practice is arthroplasty, joint replacement. So in a revision case scenario, we do find that in case we have a lot of input from technology like 3D printing. So can you tell us, can you take the implant which is already there out of the planning and you just can give an accurate 3D model of the bone? Is that possible with the current technology that we have?
Yes, sir. Yes, sir. So it is, even though it is a cumbersome work, we can do it. In fact, we have had one case in Ahmedabad and Chennai wherein it was a revision hip case where, the patient's screws were all over the place. So we were able to identify those implant components that were floating inside the patient in 3D model, as well as provide the, whatever the bone loss that was there, what is finally available to the surgeon. And then a lot of times, we don't promote customized implants. A lot of times, you already have standard implants that are available for revision surgery that you could use. So we support those things, what we believe is preoperative planning, better visualization. Once you have better visualization, once you have better planning, then you are able to execute it a little better. But yeah, absolutely, it is possible. It does take time because of the metal, the scatter marks, and hopefully, like Dr.
Exactly.
Bhavuk said, because of the scatter marks, it's a very manual process where we have basically biomedical engineers who are specialists in imaging who are able to identify the difference between what is a scatter and what is actually a bone. So once that is done, then the 3D part becomes pretty straightforward. But yeah, it is very much possible today.
Okay, yeah. And another important aspect of 3D printing would be the cost, because that is the commonest question that is being asked. So can you give us an idea, what is the tentative, what range one could expect the cost to be in, like for a pelvic model or for a shoulder model?
Yes, sir. So what we have done is we have done like an entire tiered approach. So we have guys like Dr. Lalit Maini, who are kind of the godfathers of the 3D printing. So what we have done is we have created, if you are interested in printing yourself, then you can buy a 3D printer for 20,000 rupees on Amazon. So you can have your own 3D printer for 20,000 rupees, and then the service we provide is basically a file or a patient's 3D model, STL file, what they call it, as a digital file. So what we have done is one of the first tier is, okay, if you have your own printer, we can give you a digital file which can cost, say, anywhere from 5,000 rupees to 20,000 rupees, depending on the complexity. So that is just the file part.
Okay.
Then if you want to get it printed, it's more like 30, 40,000. If it's an implant, it goes to 1 or 2 lakh rupees, depending on the size.
I think that answers the question. Okay, I think we can move forward now. Thank you, Ketan. May I invite Dr. Chabra to speak on the role of robots on in spine surgery. Dr. Chabra, please.
Yeah, hope you can see my screen.
Yes, yes, we can.
Yeah, thanks. Bhavuk has made my task easy by talking about artificial intelligence and machine learning. At one point of time, it was thought that humans have intelligence and that's why they're superior to machines. But then came artificial intelligence, machine learning, and deep learning. Bhavuk has talked about them, and this has enabled the computers to evolve a new path towards human intelligence. And what was revolutionary was when the computer defeated the world chess champion, right? And in 1997. The history of use of robots in surgery dates back from 1985, when the first robotic surgery was performed to obtain brain biopsy. Since then, it has gradually evolved, and till 2016, over half of prostatectomies and a third of hysterectomies were performed robotically in the USA. And in 2019, over 5,000 Da Vinci surgical systems were installed worldwide, and 6 million surgeries were done globally. With regard to spine, there has been an increase in incidence of spine surgeries and also increase in incidence of instrumentation surgeries and revision surgeries. And we know that minimally invasive spine surgeries are the state of the art now. And with more and more complex spine surgeries being done, there has been an increase in complication rate, and there has also been an increase in radiation. So people tried to find out ways and means to reduce the complication rate and the radiation rate. And here is where the robotics came in particularly handy. So it was adopted more slowly in spine surgery than in other surgical disciplines, primarily due to the difficulty of accessing and visualizing critical structures through small closed working channels. But ever since it was introduced in the 1990, with better understanding of spine biomechanics, more sophisticated instrumentation and refined technique, it has gradually evolved. So as we mentioned, the first reported three-dimensional surgical navigation for spine surgery was by Nolte in 1995. But now they have evolved to quite an advanced stage of robotic spine surgery. Let's see how it works. You can do a pre-operative planning at your leisure, and over a sip of coffee the day before, or in your office, you can mark the region of interest, position the screws and or trajectories, plan the route, and then the surgical plan is reported and exported. And during the surgery in the theater, the intraoperative workflow enables the surgeon to execute what has been planned at convenience before. So this is the beauty of robotic surgery. In a step one, you affix the surgical system to the bony anatomy. In the step two, you define a safe work volume in which the surgical arm should move. Then you draw spine, in which the surgeon marks the segment currently being operated upon. Then two clear fluoroscopic images of the spine, AP and oblique, are required. The system software matches the two fluoroscopic images with the preoperative CT study of the current patient and registers each vertebral body position in relation to the surgical arm position. And then for each pre-planned drilling site, the robo accurately sends the surgical arm to the position in the surgical field according to the surgical plan, and drilling of the spine is commenced through the arm guide position. And then you have additional feature where you can use navigation to see real time where your implants and instruments are going, and that gives an enhanced confidence to the surgeon that you are in the safe zone. There have been enough published evidence about the accuracy that comes in with robos and it has improved accuracy by 70%. So you can achieve almost a 99% accuracy. It has reduced X-ray radiation by 50 to 70%. It has reduced complication rates by 48% and reduced reoperation rates by 46%. Our review of literature also confirmed these findings. Let's see how we have used the robo to our benefit in complicated cases. You can see this cervico thoracic kyphotic deformity, almost 90 degrees kyphotic deformity. The patient had tubercular spine, was treated elsewhere, operated upon, the implants had to be removed because there was infection, and you can see the severe kyphotic deformity, the destruction of the vertebra, and you can see how the cord is getting impinged upon. The patient had progressive neurological deficit when she came to us. So we did a stage surgery, applied a halogravity traction. In the next step, did a corpectomy, and then applied a halopelvic device and distracted her while she was awake to gradually correct the deformity, and then did a robotic assisted definitive surgery, and the results were good and the patient recovered very well. In deformities, which are again very complicated surgeries, you can achieve good results using robotic surgery. As you can see in this case, the results were quite good. Another case of deformity with good results. And minimally invasive spine surgery, you can have it like a conveyor belt phenomenon where you can reduce the surgical time substantially by robotic guidance. So you can plan, simulate surgical outcome, achieve rate trajectory, assist in putting screw, and you can do both MIS and open procedures. But what you can't do now, and what is a possibility and a potential, is to assess the decompression, rod alignment, fusion, rod placement, and difficult approaches. So what we expect in future is that it should be able to, software should be able to plan the instrumentation by itself. And rather than the CT, you could use MRI for the planning, minimizing the radiation exposure. Provide a rod which is automatically bent as per the planned contour, and integrate the existing OR devices such as power drills, etc., with the robotic system. And when you have to do front and back surgery with robos, you can do a single position surgery, which is gradually evolving in this time. The surgical robos in use today are remote control devices operated by surgeons. The robos don't control the scalpel, the surgeon does. Technology is still a long way from delivering autonomous surgical robos. But then there have been the question, will robos take over surgeons? Many experts believe it will. Like this 2017 study from MIT showed that an artificial intelligence system was at least equal, if not better, than radiologists at reading mammograms for high-risk cancer lesions needing surgery. Exactly a year later, JAMA reported Google study which showed that computers are similar to ophthalmologists at examining retinal images of diabetics. And then subsequently, computer-controlled robos have performed intestinal surgery successfully on a pig. While the robot took longer than a human, its sutures were much better, more precise and uniform, with fewer chances for breakage, leakage, and infection. So there are experts who believe that robo-doctors will definitely replace surgeons. However, others feel that there are challenges regard to perception and manipulation. Jobs that involve understanding subtle visual cues and fine manipulation of objects, both key skills for surgeons and which are extremely difficult for AI to master. And they feel that it will take time before these are mastered. Machine learning deals best with the predictable world. As soon as you try to cross the divide between the digital world and the messy analog world, machine learning does less well. Surgery, is an extreme example of this messy world, and interpreting from a camera image what is going on in soft tissue is hard enough for people and harder still for the machine. Again, AI is only as good as the humans programming it and the system in which it operates, and it is dependent on data. And like for other computing, garbage in results in garbage out. And there is a major concern about the data which is available right now. And will this improve with robotics? It may compromise results. That is the fear. The machines do not and cannot verify the accuracy of the underlying data they are given. Rather, they assume the data are perfectly accurate, reflect high quality, and are representative of optimal care and outcomes. Thus, many experts believe that it may not, the robots may not ultimately surgeons. So the world is divided in this regard. Even if people who believe that it is possible, how long will it take for robots to replace surgeons? The general view amongst the AI experts is that it will take at least half a century, if not a whole century, if it is possible. So we don't need to lose too much sleep in this regard right now. At least a couple of generations are safe. But does that mean safety? The experts may be divided on whether robots will replace surgeons, but ultimately it is the patient's benefit that we have in mind. And it is definite, and there is a consensus that both are very useful partners. So robotic assisted surgery is here to stay, and we should make use of this wonderful technology so that we can keep pace with technology, and gradually as the potential evolves, we'll be in touch with it. Thank you. Thank you for your patience.
Thank you, Dr. Chabra. Rightly said that robots can replace surgeons. But on a lighter note, there is certainly one thing that they can't do, and that is get sued in the courts. Is that correct?
That's true.
For that you will need surgeons.
So again, robotic surgery will be in the name of a surgeon. So it will be the surgeon who will be sued because he decided that the patient be put to the surgery through the robot.
Absolutely. Wonderful talk, sir. Dr. Shekhar Agrawal, welcome to the.
Thank you.
Please, any comment to make on the talks that?
No, I think robotic surgery is taking a little time, at least in the joint replacement field. Though there are some centers doing it, but I think they are implant specific, and whatever data is coming out is not showing any superior results to conventional surgery. So there we go on the. But I'm sure it's going to improve upon time, and we will have better robotics to give more precise surgery. See, on the other side, there is a constant debate between mechanical alignment and kinematic alignment. And kinematic alignment can vary from patient to patient. And is a robot going to depend on mechanical alignment or kinematic alignment is hard to say.
Right. Okay, I think it's time to move on to the next speaker. Welcome, Dr. Ramesh Sen to DOA and Doacon. So he's going to speak on another interesting topic, role of bioabsorbable implants. Over to you, sir.
Okay, thank you. So very good afternoon. And when we are talking about these new technologies, we're talking about emerging bioabsorbable as such. We understand that these are kind of the ghosts which we are likely to put them and they're likely to melt away. And technically speaking, these were practiced long back as sutures. We all know about it. Then they came staples, clips, many things came as bioabsorbable. And what is the basic importance is that they are likely to give a reasonable amount of stability. They cannot be very, very secure, but a reasonable amount. And their degradation or their solution has to go along with the fracture healing. And by the time we have to have that level in which the fracture has healed and they should subsequently dissolve out. And we have many varieties from plates to screws to anchors. Many of these things are available and are getting available. They can be natural based, out of which we know about collagen, fibrin gel, or chitosan, or they may be synthetic, for which we have got a big variety available, and many of these you can see are useful in orthopedic surgery with all those scientific names. Now, what has been observed that osteocytes can be cultivated on these polymers. So they do show kind of a safety also. If you look in the pictures around, whenever they are there, their growth is reasonably good as compared to the other surfaces. The second question comes their stability or their ability to hold. As far as bone-to-bone fixation is, they definitely, metal screws are better off. But what is the strength required? In a bony, they say the biodegradable screw can also provide that level of mechanical stability. Second is interference fit, meaning by getting into a kind of a bone or a ligament. Again, it has been observed in this study that there's not much of the significant difference between a metallic screw interface or a polymer screw interface as such. Second group is ceramics, which has been used as absorbable. These could be hydroxyapatite, could be tricalcium phosphate, we all know. Problem with them is that mechanically they are very weak. So they are more likely to be filling the cavities and cysts rather than to be a screw. But if you combine ceramics with polymers, it has been found that they have got highest densification and their compressive strength is quite good. And that is one of the areas where things are moving on. Another thing which has been seen, that again coming over to the natural polymer chitosan, and if you combined with the ceramic, again we have got a very high quality absorbable material available with very high mechanical strength. Now moving further from ceramics right now is the metals. People tried using iron, but it was not suitable. They tried using zinc. It has also low rigidity and deformabilities. It was more as an alloying element rather than the primary. But in comparison, magnesium showed good biocompatibility, favorite biomechanical properties, and ability to support the bone fracture. And there has been a lot of work. If you look at these reviews, a lot of animal work, a lot of experimental work has gone to prove these things. And these magnesium-based absorbable screws, their degradation did not interfere with the fracture healing. They had an excellent results. Here you can see them on the capitulum, on the side of it, the fixation screw. Then their kind of a further augmentation as a component, they have shown a reasonable amount of the degradation also. If you see on the slide, the kind of a screw which are there, the side of screw, they are there, and subsequently they tend to melt away. They tend to disappear in the fibula here on the right side of the X-rays. Another paper in the last 2 years reported that if you take these screws with bioabsorbable magnesium compression screws, there was no failure, fracture healing was very well, and there was no interference with the union as such. So they are seen to be an appropriate candidate, these magnesium screws. And their components, then further zinc tungsten carbide nanocomposite, which was found to be still better in a kind of a situation as a kind of a graft. So now they have been seen that these are good, they can dilute away, they are eventually excreted by urine or by feces, and they are helpful in the subsequent, some of their element is helpful in the formation of the hydroxyapatite in the bone tissue also. Regarding the use of these injectants, they have rapid corrosion rate. About that was one thing which was able to found. So now it has been observed that for the corrosion, you can have the hybrid coating on them and their quality can still become better in this kind of a situation. Another metal tried is strontium. Strontium impregnated bioabsorbables, and they find they also have a good osteointegration, especially in an osteoporotic bone. So they could be good in that kind of a condition. Another new thing which came up is the black phosphorus. It is just this year, the publication says it also has got a very good optical and mechanical property, and work is going on more for these black phosphorus implants. Now, what are the uses we are looking for? Definitely, they have been there as films, which you tend to put in a heterotopic ossification, which you put as kind of a wound dressing, which you put in the area as a kind of a prevention of adhesions between the bones. They have been used as threads also to get the fixation of the bones using a thread. This is another area which has developed. Then they, as a glue also, we know there has been a lot of use of glues at many places other in vitro, but here gluing of the nerve as well as a kind of a delivering of the neurotrophin inside is one area which is being worked upon this area. Then as a scaffold, meaning by to take away a kind of a cover up for the cells to hold, for the biological things to hold, or to tendon repair surgeries they have been used. As an adhesive for the bone fragments, another very interesting we have been looking for, or maybe we had sometime, I remember about 15 years ago, some company from America had come up that they are likely to provide us material for research was these biodegradable adhesives also. The work is still going on, and this is 2019 paper. They say now we are nearing that research to get these kind of situations. We all know, we have all probably used these polypins or from one of the companies over here, which we used to use, and they have got a very good purchase of the fragment, the small osteochondral fragment in children where you do not want to have more metals inside it. There are screws also which has been used as a kind of fixation along with the braided polyester suture is another area. There are plates also. If you remember, we had these plates available with us even 15 years back also. There were issues, I'll talk later, but these plates were also available, and they are now being looked at another area where there is not much of the stress. And these non-stress areas, again, these screws, especially for these osteochondral fragments, have been there. For the chondral trauma, these biodegradable things have been used. And for the anchoring into these tendons, these PGLA, TCP, all those ceramic to polymer combined screws or these degradable stunts have been used for these reconstructions. So there are many areas where the degradable or bioabsorbables are being used for those osteochondral injuries where you do not want to put metal into this area. Or on the calcaneum fracture, so this is the paper where you have used a plate also by kind of a stripping of that polymer and dividing it over and giving a kind of a purchase to that area. Or for the another fractures also, which are degradable screws which has been used. Then implant spine also. I was interested to see these spine cases also where the bioabsorbable magnesium PCL cage has been used. And this is the study which said it could be useful as a cage. Then biotics, another area is taking up antibiotics or growth factors along with and putting them into that kind of an area is the another area. They do not have their own antimicrobial property, but they can be used to carry over those antibiotics. And as an antibiotic delivery vehicle also, if you coat and screw, and if you contain that screw and the screw has got that antibiotic, they have been found to be effective. And this is quite an old study. But as a drug delivery also, this has been found to be suitable for long lasting. Now you see here, the dilution and subsequent delivery can go to 350 days to a year even. So in those situations where you want to give, for just like in osteomyelitis case, for a very, very long period of antibiotics, this is one area which is there. They're all recent papers. And this is another paper, which is an Indian paper in release of profile display drug levels, continuing up to 2 months. This is the older thing, and these things are already available with us. But this is all not rosy with them. If you look at it, the kind of issues, osteolysis as an issue has been reported. And there is a big story about it. It was in 2000, the things came up. Even in the spine also, there were papers which said, no, it causes a lot of osteolysis. 44%, they did have that problem seen with these cases. And another area, implant failure, screw breakage, these were all reported in some of the areas where they were used. And in the clavicle, they said they could fix the clavicle, but they could not manage to hold that alignment which was there at the surgery time. And post-surgery, during the healing, the fixation had failed and they had given way. And this is our own experience also way back about 15 years ago when these came from one of the companies. The left side you see, these are the conventional implant, and the right side you see the biodegradables which we used at that stage. Some cases did very well. We had a very excellent radiological picture because we were not seeing any metal, and the fracture was appropriately stabilized also. But the problem which was coming, they showed excessive discharge post-operatively. And this discharge was bad for this patient where we did the fixation. It was a Pipin 3 kind of an injury, though the surgery was, but we understood the area of mechanical stress. There we put simple metallic screw. But in the head reconstruction, we put these degradable screws, but they gave a lot of irritation, lot of fluid. And we did complain to the company also about these things which we were observing in these screws, but definitely they had a problem and we had to take it out. The implant failures, because they demonstrated some efficacies, but they did not really fulfill the total. This is the last year perception. So what is happening? we may have a use where the metallic devices are problematic, maybe in the pediatric situations, maybe specific situations. But if you know the history, because in 95, 96, they were much more proposed by a specific Helsinki group of people. There was a lot of literature which came in support of these devices. And later it was found it was more a market-driven work in the publication that stage. Subsequently, those things, we also suffered all those problems with our patients. Subsequently, these things were taken back. And now, but that does not mean the research is coming up. It is coming up again in a proper scientific way. Now we have got Make in India campaign also, where in India we have got these biodegradables available now. These are available, and we feel that within proper area where it is not much loaded, till the time we do not have very new things coming up which are proved by just like magnesium screws, or which might have a better strength also, there will still be a use where we can avoid a second surgery. We can see a good post-operative picture where we don't see any implants. We don't have to take these implants. They should remain biocompatible. And in those areas, especially these days, going across for the flights also, the metal sensors are not likely to make an issue. And the patients can be comfortable while undergoing shortwave diathermy, microwave diathermy. So these are still the benefits which we can look for, and maybe in the future we get much better quality of these biodegradables or bioabsorbable, and we can have a better future. Thank you.
Thank you, sir. Any questions or comments from the panelists? Rishika, you want to ask anything?
No, these biodegradable implants are not good for any weight-bearing bones. They may be all right for smaller bones, but mostly they are used for antibiotic delivery or as osteotomies and things like that. But I think as fracture fixation, they've still got a long way to go.
That's
one area where they, yes, please, Dr. Sen.
Yeah, this is what I'm saying. Dr. Shekhar has rightly said it out, that we are still evolving in these areas, and maybe in the years to come, we might have better documented and better kind of a stable and more stronger implants available. But right now we are in that transition stage for that.
Yes. So
one area where these bio implants, they have found a definitive place is the sports injury reconstruction. So in all the ligament reconstruction, it is now a standard of care to use bio implants. The same cannot be said about the anchors, but yes, bio screws for ACL, PCL, and other ligament reconstruction, they are supposed to be, and they have been given very good results without any significant complication like osteolysis, etc. And another advantage, as you have rightly said, they don't show on an X-ray. So I am very happy using that because the patients are very happy not to see any metal in their bones. Yeah, with that, thank you very much, Dr. Sen. May I invite the next speaker, Rehan, to speak on implants which are infection resistant. I think that is an interesting talk I'm looking forward to. How are you, Rehan?
I'm fine, Dr. Amete. How are you?
I'm doing great. Yeah, please.
Am I audible to everyone?
Over to you. Yes. Over
First
to you.
and foremost, thank you very much, Dewey, for inviting me for this lecture on infection-resistant implants. Although I am joining you all from Bhopal, but I think I'm a part and parcel of Delhi, and I am there as a in-house faculty. So basically, the things that I'm going to talk of today are, this is a disclaimer I want to put. The science and the clinical use of infection-resistant implants is actually in its nascent phase. Like all of you, I have limited experience of their use and efficacy. Like most of us, we have used antibiotic-loaded cement spacers. We have used antibiotic-coated nails. Most of you must be familiar with the gentamicin-coated nails which have come in the market. But a lot of research has gone into the newer sort of technology which is coming up in this field. And I will be talking based on an extensive review of literature on this subject. So basically, 4 important points I'm going to cover. One is the basic science behind implant-related infections, strategies to make implant infection resistant. Most importantly, what is available. As a surgeon, research is all right, but my primary concern is what is available on the shelf, which I can use. And last but not least, the advantages and limitations of what is available. So if we go to the basic science, I think from the day we join our post-graduation, we are always talking of the biofilm, And very briefly, from a clinical point of view, the biofilm is nothing but the moment you put an implant inside the body, there is a race between the host cells and the bacteria. And this race has been called the race to the surface. If the host cells win and they form a layer onto the implant surface, the implant is safe. However, if the bacteria will form a layer, a biofilm is formed, and that is the key problem in all implant infections. Because the moment you have a biofilm sort of a thing formed here, neither your antibiotics, which are represented here, neither your macrophages or the antibodies which are being produced by the human being against these bacteria will penetrate the biofilm, and therefore if the biofilm is there, the chances are that implant infection would be very high. So although 5 stages of biofilm formation have been described: the reversible binding, the irreversible binding, colonization, maturation, and finally dispersion. As practicing orthopedic surgeons, we need to understand that this whole process is a very fast process. It completes itself within 18 to 36 hours. And the only reversible phase of this is the stage 1. Therefore, if you want to have an implant which is resistant to antibiotics, you have to create a surface, an implant surface, which has the properties of not going in for this phase 1. That means you have to somehow reverse the stage 1. If you can take control of stage 1, all things are mostly sorted out for you. So basically, there are 3 strategies which have come up. The first strategy is the passive surface finishing. That means this is a non-pharmacological method. What you are trying to do is you are trying to create a surface which will automatically repel the bacteria. Therefore, once the stage 1 is not happening, you are in safe hands. The second, which is more promising, for which more clinical results are there, is that you create an implant surface which is either impregnated with antibiotics, antiseptics, metal ions, of which silver is most promising, or any other ion, and very recently iodine. So once you coat it, not only does it prevent the bacteria from lodging onto the surface, what it also does is a sort of a contact killing. So the moment the bacteria comes in contact, it is actually killed, and therefore a biofilm is prevented. And last but not the least, this is our gold standard sort of thing which we all use, the antibiotic beads and the antibiotic cement. So this is something like a perioperative antibacterial local coating. You have done a coating, and this coating is not only bactericidal, but it also prevents bacteria from forming a biofilm. So these are the strategies. The question is, what is available for us in the market? Like I told you, the non-pharmacological methods, a lot of research has gone into it, but they are still in the preclinical phase. What is available to us is mainly from the pharmacological materials which have been put up on an implant. The most promising of which is the gentamicin loaded nails, which have recently come up in the market. They are available for the tibia. They are also available for the femur, but they have their own advantages. For example, 80% of the antibiotic is released within the first 48 hours. And like I was saying in the basic science, the biofilm forms within this period of time. So if you can take care of not the biofilm forming, you are in safe hands. The limitation is if you have a bacteria which is already resistant to gentamicin, there is no other choice, because as of today in the market, we only have gentamicin. Again, from the pharmaceutical point of view, silver ion coating is something which has come up. The advantage is these cations not only are bactericidal, but they also prevent bacterial adhesion onto the surface, especially useful for tumor surgeries, because in a tumor patient, the patient is already immunocompromised. And because the patient is immunocompromised, he has high chances of infection, a biofilm forming, and the whole surgery failing. So if you have something like a silver ion coating, it probably helps in some ways and prevents the implant from getting infected. Again, silver coatings come with their own limitations. There is a toxicity of the silver ions. There is harm at the distant site, not only at the local site, but at the distant site, the ions can be of failure and dry. lastly, you cannot completely coat the implant. So because the implant is only partially coated with the silver ions, the biofilm can actually form at some sites. I was talking about iodine. So this is a concept which has recently come up. We all know iodine. It has been with surgeons for so many years. We use it for painting and draping. And for all our, previously we used to do it for wound lavages also. So iodine impregnated implants have come up in the market. And the good thing about these is that there is extensive preclinical as well as excellent clinical efficacy of the iodine coated implants, especially for the titanium alloys. So I personally feel that this is one of the very promising implants, which is the way forward and probably are going to come in the market in a much bigger way in the very short near future. However, again, the problem is that the long-term effects of the local application of iodine is still not known. And except for titanium dioxide, the use of iodine with say stainless steel and other sort of implants is not known. And this is the last one which I would like to talk is the perioperative antibacterial local coating. We already know about it. We talked of the non-biodegradable, which is the bone cement, but a lot of companies have come up with some sort of a hydrogel. So this gel can be mixed with an antibiotic and then it can be put onto the implant. The proprietary one has come up from Italy, which is called the DAC system, the defensive antibacterial coating. The advantage is you can put in, unlike the gentamicin nails, here you can put in any antibiotic that you want. The amount of drug that is released is almost 100 to 1000 times more than the MIC, which is needed to be bactericidal. So actually there is very good chances that no biofilm will be formed and the implant will be resistant to any infection. However, clinical trials to this is only in case of primary and revision joint arthroplasty. I think some of the panelists would be better aware of this, and only for closed fractures. So there is limited literature about use of the DAC technique in the open fractures technique. And again, like anything which is new, there is limited data for long-term follow-ups. So I think my only take-home message from this talk is that prevention and development of the biofilm is the key to developing infection-resistant implants. There are three promising techniques. One are non-pharmacological methods, that is passive surface finishing. Then there are pharmacological methods, which are most promising, which I have 3 or 4 things which I have discussed. And last, the perioperative antibacterial local coating, which we all have been doing. So gentamicin, silver iron, iodine, and hydrogel coating are those available in the market. But I think in the future, we'll have more options. Thank you.
Thank you, Rehan. That was really interesting. Any questions or comments?
You can carry on.
Okay. Okay, thank you, Rehan. Now, the next and the last talk would be by Dr. Maninder on gate analysis of gate. And let me just, okay, over to Maninder. You can tell about your topic.
Yes, thank you, sir. First of all, I'd like to thank DOA and Dr. Dhananjay for the kind invitation for talking today and for giving me this topic. The topic that I've been given to talk on is gait analysis, the future assessment of implants, surgeries, and patient outcomes. So I'll try to do justice to this. And we had a really great series of futuristic orthopedic talks, and has made a lot of overlap with what I'm going to say, especially Dr. Bhavuk's talk on AI. So, what's the normal orthopedic surgeon's perception of a gait analysis? That it is boring, isn't it? We're not really interested in doing any gait analysis, majority of time. So it's cumbersome, time-consuming. It requires trained personnel. It is difficult to interpret for the normal orthopedic surgeon. And the data is more useful for research and not for clinical purposes. So we try to debunk those perceptions, and that does not really need to be the case. So first of all, I'm just going to talk about the basics of what the types of gait analysis are and how we can use them in our daily orthopedic practice to improve our outcomes and to assess our patients, the progress and the analysis of their gait patterns and their recovery from surgery. So in Injury 220 this year, this excellent paper has been published, which tells us about the different types of gait analysis that are there. The first is pedobarography, which is pressure measurement. The second is marker-based, which is the most common gait analysis. The third one is very exciting, which is the marker-less gait analysis. And the fourth one, which is the variable system, so different sensors all over across the body to assess our gait patterns. So the first one is the pedobarography. So that's basically essentially a plantar pressure measurement, and that can be in the form of a platform system where the patient stands on a specific platform, a pressure sensing platform, or and that platform can be as small as like half a square feet, or it can be a long platform with pressure force plates. Or the other one, which is a very exciting one, upcoming in a big way, is the insole system, which is measuring the whole of the pressures on a real-time basis while the patient is walking on it. So the sensors are all inbuilt into the insoles, and it is battery operated with the battery incorporated into the insole. So it is a portable system which a patient can wear so it's a more dynamic system, and it can allow us to measure the pressure while the patient is walking on different terrains. So there's two types of pedobarography. One is the maximum pressure picture, which assesses the total maximum pressure on any point or pixel. And the other one is the pressure time integrated system, which is basically tells us the time of how much pressure is put on a certain point, which is more relevant more for diabetic feet. So what are the applications of pedobarography? So first one is sports, is prevention of overuse injuries, to assess the foot pattern of a specific athlete or a professional athlete and look at where you could do more padding in his footwear or modify his footwear to prevent overuse injuries, especially stress fractures, deformity correction, pre and post surgical. So this is basically any analysis of different foot deformities like hals valgus or heel valgus deformities, flat foot, to look at whether we've actually improved the pressures post-op. And then diabetic foot is to prevention and treatment pressure ulcers. So this study in International Orthopedics 2018 assessed 27 patients with a variable insole pressure monitor, and they found that they found that the sensors would evaluate specific patterns which were associated with a poor prognosis, and those patients with early intervention did better than ones which did not. So it is an important thing to identify these patterns early, and we can do that now. The next one is the marker-based gait analysis, which is the most common gait analysis that we have. It is basically has skin markers attached to different anatomical landmarks. Basically, it's the bony landmarks. And then we have motion tracking systems, optical systems, or other systems to track those sensors and tell us the joint movements in different planes. And we can measure walking speed, cadence, step length, or external joint movements. Even joint power, muscle power can be assessed with these patterns. So this is something which we have in our in-house in ISIC. Basically, so this is skin marker based, and you can assess different joint patterns and even the movements of the specific joints with this pattern. So if you sort of make the patient do certain jumps, so you can assess the different patterns that are there, and you can apply it to different orthoses that are there. So what are the applications of marker-based gait analysis? The most common indication in orthopedics at present is in surgical decision-making in cerebral palsy children. So that is an area where this has really made a big mark, and has several studies have shown that incorporation of gait analysis in the study allows us to change and modify our treatment plans according to. So these two studies have actually shown that the treatment plan was changed in the majority of times when a gait analysis was done versus when it was not done. So again, a very important mark. But then in more other applications along with cerebral palsy is for post lower limb trauma, pre and post arthroplasty, and deformity correction, along with spinal indications like spinal deformity. So these studies basically show that in a knee arthroplasty, a normalized gait parameters analysis, it basically is closely related to the outcome measures that we do. So if we, instead of outcome measures, we can just have sensors which the patient can take home with them, and we can get data from them afterwards according to what the rehab is going. So that's basically one of the options of gait analysis, which is portable, and that is coming in the near future. And the gait analysis along with spinal disorders, again, basically sensors and gait analysis sensors which the patient can go home with. So the next one is a markerless motion capture. So this requires a camera or a 3D camera sort of system. It does not have any markers, and there's no trackers as such which you have to apply to the patient. It just senses the body position as it is, and then allows the computer to analyze where the joint is, and then make decisions depending on the AI, artificial intelligence, and make sort of different drafts which come out in real time as the patient is walking. So it's not cumbersome. It's very easy to use. This is one of the systems which we have in our in-house, which is the walker view, which allows, it's basically a camera, a 3D camera-based system, which the patient can have a big screen in front, and he can actually get visual feedback as well, sort of, so along with the physio who can monitor his progress. So this basically allows us to do gait analysis, even outcome measurement, and training as well for the patient. So if we just to look at an example of a gait analysis, so this is a patient who's had a knee arthroplasty surgery, and this is like 2 days after the knee arthroplasty, and she's walking slowly, and you can see the different parameters that are there, which are coming real time to assess is basically the range of motion of the hip, the range of motion of the knee, and you can see how the graph is very variable. So there's asymmetry in hip extension and inadequate knee flexion. So that is what we want to improve on. So the patient can be trained on this system, and then it allows us to assess the actual movement real time. And so slight symmetry, so she basically tells the velocity is slow. She has different variable left and right step variability and a short step length. All of this can be assessed just by the means of camera, doesn't require any sensors. And if you see the pre and post, before and after videos, you can see that, sort of she's walking faster. And there is knee flexion. So you can see this is a graph of knee flexion, which comes out in real time for you, and basically tells us the knee flexion has improved from where it was here, quite low and very variable. Now it is coming to quite significant, simple knee flexion pattern on both sides. So it tells us both the right and left sides, and then we can assess that. So and that gives us basically a very objective view, and even the patient can see how he's doing real time. So this is one of the new sort of gait analysis along with training, which is very useful for orthopedic sort of assessment as well as rehab. So so we can measure all these parameters in-house. This is just a gentleman who's had a total hip arthroplasty, and then he's basically, we can measure the same things along for him. So initially he may have inadequate hip extension, inadequate knee flexion, and then with training, as he goes, we can also measure actually the weight that he puts on each joint, and the AI system can detect that, and along with the instability of the hip. So after training, he starts to walk better. He starts to walk fast, and then we can show the same picture pre and post to the patient at the same time, and he can actually assess how he's doing. And that really gives us a gait analysis as well. So we can analyze all these parameters that we are actually improving rehab. And this takes very little effort actually, or very specific training with these systems. So all these systems are now, very widely available now. And we can use these to assess our patients' rehab in our normal day-to-day practice without much of difficulty. And the training includes virtual reality, which has been shown to have the increased biofeedback to the patient and reduce the amount of rehab that they require. So quicker recovery for the patients as well. And you can make the patient walk in different environments, like on a street or on an uneven surface, and you can make the different variabilities inside the treadmill system. And the visual feedback again tells us, so if you see the patient without visual feedback, with the camera, with the monitor switched off and with the monitor switched on, you see the side-to-side swaying of the patient less with the biofeedback, with the visual feedback which is available. So that gives us an idea that sort of the lateral flexion which reduces, and again that's an important component of the overall rehab. So it's an easy to understand output both for the patient and to the surgeons, and does not require any complex calculations or a specific technician to do it. It's this minimal training required for the physios to operate this system, and can be used for assessment and training both at the same time, and incorporates virtual reality and AI machine learning. Now, coming to machine learning in gait analysis, it's been shown in various studies that machine learning or AI can assess the various gait patterns much more accurately than if we were to present it with a series of graphs a human would do much, a machine would do much better at assessing those gate patterns and telling us what is wrong than what a human could do. And again, it's accurate, more reliable, and exactly simpler, much faster results, and we can get real-time results. So all this enhances our ability to actually provide better care for our patients. So let's look at the first slide that we put up. An orthopedic surgeon's perception of a gait analysis is cumbersome, time-consuming. It's not. It requires trained personnel. It does not. It is difficult to interpret. It's not no longer the case. And the data is more useful for research and not for clinical purposes. No, again, that's not. We can use it daily with these helps from the systems that are now coming up. So what does the future hold for gait analysis? So the future would incorporate a continuous assessment of gait by always-on sensors, including EMG sensors on the body, which will tell us what exactly the body is doing. And we can have these sensors, patient wearing these sensors post-operatively to allow us to assess from remote locations how his rehab is going. A real-time correction of gait and posture is also possible with continuously adapting orthotics and insoles. So they can modify according to the way the patient's foot is landing incorrectly. They can modify the insole pressure or the position in real time. And this is not far away. This is all coming up real soon. So thank you very much. I think that's it from my side. Any questions, please? Thank you.
Thank you. Thank you, Maninder. Any questions from the panel? Okay, I think definitely gait analysis will have more role to play in the way we rehabilitate our patient or even plan the surgical correction of some of the difficult gait patterns. So I think it has a definite role. The only issue would be the availability of these devices so that we can, if we can have a portable device in near future, I think more and more orthopedic surgeons would be happy to incorporate that analysis into their day-to-day practice.
And these will be much more economical to use as well.
Yes, exactly.
Portable ones.
So I think with that, I'd like to thank the eminent speakers and the DOA and my co-panelist, Dr. Shekhar Agarwal, who had to leave. And I don't see Dr. Yash Gulati, he couldn't join due to, and Dr. Maheshwar, he couldn't join the session, but thank you very much. So we sign off from here. Thank you and all the best.
Thank you. Thank you, Amite. Can we go to the next session?
Dr. Shekhar, there are 2 talks before this session.
Okay, okay.
Dr. Ravi? Dr. Ravi, are you here?
Yes, sir.
So just guide Dr. Shekhar. There are 2 talks remaining now?
Yeah, there are 3 talks. Shekhar sir, there are 3 talks are remaining of the last session.
Okay.
First talk is of Dr. Rajesh Malhotra. Dr. Bhavuk Garg will play the video of sir.
Okay.
And thereafter followed by Dr. Manish Dhawan talk, and thereafter Dr. Dhananjay Gupta talk.
Okay, so we'll start our session after that.
No, before your session, sir.
Okay. No, that's what I'm telling you.
You can start with these 3 talks, sir.
Okay. Okay.
Yeah.
Dr. Malhotra, we can't hear you.
So I think, can we go ahead with the second talk first? I will just see what is the problem with this. It's a recorded talk, so I'm just checking the audio part.
Okay.
Can I go ahead, Dr. Ravi?
Dr. Manish,
Yeah,
please.
please, sir.
Yeah, I'll share my screen. My screen is visible.
Yes,
Yeah,
we
sir,
can see.
it's visible, sir.
So good afternoon, everyone. And my talk is slightly unusual of all this academic stuff, but it is one of the most important talks because nothing moves about money. You have money, you can do this webinar, you can, the DOA has money, everything can be done. But if money is not there, you can't do anything. So we have to see that how COVID has affected our community, the medical community, and overall the other population. So this coronavirus has totally engulfed whole world. Now the whole world, I think there is no place in the world at present which is not affected by coronavirus. So this is COVID-19 pandemic, now labeled as a black swan event and linked to economic scene for World War II. The outbreak of COVID-19, the disease caused by it causes severe acute respiratory syndrome, coronavirus 2, that is SARS-CoV-2 virus, and has the detrimental effect on the global healthcare system with ripple effect on every aspect of human life as we know it. Same situation we had in the Spanish flu before the World War II, and the World War II created a havoc in the economy, and probably the COVID crisis will surpass the economic crisis of World War II. Now, World Health Organization declared COVID-19 outbreak on January 30 as a global pandemic. In response to flatten the curve, government enforced border shutdowns, travel restrictions, quarantine in countries which constitute world largest economies, sparking fears of impending economic crisis and recession. Particularly in India, which is one of the fifth largest economies in the world, and the lockdown was, I think, the largest, and it was the longest lockdown ever we have experienced, and it was the longest in the world. Now, in order to understand the turmoil effect on economy, we need to summarize the effect of COVID-19 on individual aspects of world economy, focusing on there are primary sectors like the industry, which involves like extraction of raw materials like agriculture, petroleum, and oil. There are secondary sectors which involve the finished products like manufacturing industry, tertiary sectors including all service provisions like education, health. We come in the tertiary sectors, pharmaceutical, finance, hospitality, tourism, aviation, real estate, housing sector, sports industry, information technology, media research, development, food sector, and social impact is like family dynamics. Now, since there was a lockdown, lot of video gaming, webinars. Also, we have seen that domestic violence increased because husband and wife were staying together. So it triggered lot of domestic violence also. Now, financial toll of COVID-19 pandemic on our healthcare system has been enormous. Or as the hospital cancelled non-urgent admissions and surgeries like elective surgeries were cancelled, outpatient clinics were cancelled, practices deferred, elective and preventive visits were deferred, and basically what revenue was coming, it just evaporated. Hospital and health system face catastrophic financial challenges in the light of COVID-19 pandemic. Now, the COVID-19 had a very big catastrophic effect on the health workers. Like they were the corona warriors, the frontline warriors. They suffered with finances. They suffered with their health. Lot of became ill. A lot many medical fraternity, died because of coronavirus. Most of the OPDs were closed during the lockdown, so no money. And there was reduction in income of all the two types of doctors. There are two types of people in our community. One is the people who draw the salaries, like people who are working in government job or in a private sector job, and other are which are self-employed. So both suffered paycheck cuts. Now era of video consultation started,
And it went against all the principles which we have learned in the Hutchinson's manual, that you have to see the patient if there and you have to talk to the patient. History taking can be done, but you can't feel or move, or you can examine the part. So it is just a virtual video consultation, which is not what we have been taught in the medical colleges. Now, financial management is a cyclical process. So the elements of management are flow of input, like money will come, then you have to, the money retains, and the outflow means your expenses and bills will go away. Now, the retention thing is very important, because whatever input is coming, at least 20% you have to save for your future, and then you allow the outflow. So you have to maintain this cycle. Now, there is a cyclical period of input and outflow, and it is always important to manage the frequency of outflow to maintain the resources of uninterrupted supply of finances. Even if the inflows of finances are more than sufficient one, you should increase the retention in terms of savings. Savings are very important instead of mismanagement or excessive outflow, like mismanaged expenditure should be avoided. For past 100 years, nobody faced such a kind of long-term crisis which COVID has given us. A long-term lockdown crisis in business earning has forced people to think and learn most important question: how the finances can be managed in long-term crisis without affecting the normal style of living. So now in the slides which are coming, we'll know that how to cope up if this situation arises again. So there are, four categories of people: the poor, and the underprivileged section of the society, the medium class of people, the upper class of people, and the class who are well established in the society and committed to serve the community. The same rule cannot be applied for finance management of all these. Means all the four categories, there are different rules of management. Now, the most affected category is the poor section or the underprivileged. And in this, every science fails. Science of economics fail in this thing. Now, the only option for this poor section or underprivileged is to, get them, get the help from the government, programs which government has launched. And second thing they can do, that they can have a harmonious, relationship with their business houses, so that, you can cope up in this situation. So they have to depend on the government program. Now, what are the hidden underprivileged, the migrant workers, like India witnessed, which actually it was a surprise to the government also. There are estimated 139 million migrant workers, and rest 400 million will be poverty stricken. So this huge number nobody realized, and in the lockdown, suddenly all these migrant workers, they came on the surface, and it was a huge number, and government also didn't know what to do. So our government has a adequate food grains stores, but the distribution system failed. One nation, one ration card, many government schemes, but benefits people were not aware, because in a survey done by Hindu newspaper showed that only 96% only showed 96% did not get their ration cards, and 90% did not receive wages. So these are poor people, uneducated, they do not know how to avail the government schemes. So we have seen all these harrowing pictures of this migration, and they are also known as the ghost among the citizens, because they suddenly erupted, so they are the ghost. Now the medium class people were affected the most, and neither may be interested. They basically are the bulk of, you can say, after the migrant worker, their population is, India has the largest middle class. But these community, they have a habit of saving, so they somehow coped up. And in this category, we have entrepreneurs also who have either just started their career or have not reached the milestone which they have been dreaming about. Particularly the young doctors who have started opening their clinics, they come into this category. So these people, the doctors who had opened the clinic, and they were very badly affected with the COVID situation. Now, how to do your finance management? So regular saving plans with intention of improving the infrastructure facilities at the clinic. So regular, which I have told that 20% of income you have to save, and you have to have provision to improve the infrastructure. Your clinic should be top class in that area. You should have an insurance policy, your life insurance policy, some life insurance policy. You should have medical insurance policies because you are very prone to disease. But people working in hospital are sometimes covered. But it is very important to have a insurance policy. Also, you can have one more policy for the in case of natural disaster or accident disaster. So if you are not working, the insurance companies pays you for the days which you are not working. So these few policies can help you. Now medical field is vast changing, so technically and scientifically, so you have to upgrade your clinic, keep on upgrading your clinic with technology, equipment, and you have to create a clinic which is better than the other people's, so that attracts patients. In my opinion, all the doctors should have a syndication with or at least one good nursing home. See, it is very important for doctors who are running their own clinic. They should also have an attachment with an hospital. So there should be two ways. Suppose one way is affected, so at least your second way is happening. Similarly, people who are working in big hospital, they should have their own private clinic, so that one avenue closes or other avenue is working. Now, also it is also important that a doctor should also help the needy, and they should basically, if the country or the government says that you have to help the poor and underprivileged, so you should be open hearted to help the poor people. Now other important thing is that you should, if you have to take a loan, you should make your CIBIL strong. What is CIBIL? CIBIL is just a credit worthiness of the person. Like suppose you have taken a credit card and you have defaulted on the payment. This reflects in your CIBIL. Or if you are taken a home loan and if you default on the payment, then it reflects on your CIBIL. So when you take another loan, then this causes problem unless you have cleared that thing. So strong CIBIL helps you become more dependent on the loans, and you can take more loans. So it is very important for CIBIL to be good. So finance management is not like only you think that about yourself, but you have to think about other people. So category C and D are well managed people, and mostly the doctors, they come in the C and D, mostly in the D category. So these are the people who have contributed to the PM fund, other government agencies, and establishing various rescue camps. But these are the people who have come and helped the society. A lot of many people have donated in the PM fund also. So category D is our category, and we are also known as the Corona Warriors. So what effect, people, the salary, this is a picture which was very, it's on the headlines of Hindu newspaper. In a big hospital in a Delhi, like Hindu Rao Hospital, there was no salary, or there was a 30 to 40% salary cut. So this was the situation, or people who are also in the government job which got affected by the corona crisis. So it is also our duty to differentiate between the needy and the poor patient, and you have to help them. And also with hospitals, there should be provision to, or you have to have some tie-up with the NGO, so that you have a corpus and you help the poor and needy. So finance management seeks an opportunity, and it is best time of the finance management to use the resources of the institutions to use the corpus to achieve the very objective in the field of medicine. Soft words can heal the patient, but but providing medical and other facilities on well subsidized value through our finances is like cherry on the cake. So this is the category, and C and D can do lot of social, upliftment of the poor people. Finally, I can say that it is always the planning of everybody to manage one's finances for a defined contingent period. This is the time, it has been much longer time, but all this is management for your own. We belong to the society with a good well-being, but society who can think of others, we should manage our finances to help the others and find a better place for all. So category C and D should help the poor and the underprivileged. So thank you very much. And any questions, I can take it now.
Can we just move on to the next lecture, please? We can
Yeah,
have
sure.
Sure. Bhavok, are you ready with Dr. Rajesh Malhotra talk? Yep.
To the new normal. These are the things which we used to get for this opportunity, and we are going to talk about restarting elective surgeries following COVID, how to clear backlog and ensure optimum outcome. The world has changed a lot, and we are now passing through the new normal. These are the things which we used to get scared of. However, our nightmares have now changed, and this is our latest nightmare. We need the hammer and the dance. We know that doing nothing or mitigation doesn't work. Actually, you have to go with a hammer, where you for 3 to 7 weeks strike the infection hard, and then the dance over the next few months after the initial hammer is to keep the COVID infection under control. And this is the approximation of countries along the hammer and the dance phases. And you can see we are somewhere here now, and we are hopefully past our peak for this time. And this is how the COVID has really challenged us for orthopedics. So we have the high risk for the orthopedic patients. They sometimes tend to stay longer in the hospital. We need rescheduling of the orthopedic surgeries. We have to avoid face-to-face meetings. There is a constraint about the supply of the orthopedic instruments and implants. Then orthopedics ranks low in the priority for the hospital administration to make available the customized and constrained resources. And of course, there is post-ponemia teaching activities. The proper control of infection is very important. And of course, there is challenge of diagnosing corona, as well as the challenges with delays in the treatment. So this has required some unprecedented measures, and all of us are guarding many unknown gates, shifting from the robotic OT to the COVID facility. And then we know that it's like being airborne during the pandemic. We have to do it only when it's an emergency or an urgency, and the elective things have to wait. And this is the statistics which show that 28.4 million surgeries have been postponed during the 12 weeks of disruption. And now the disruption has gone much beyond the 12-week period. Over 2.3 million cancer surgeries have been postponed, and almost 3 out of 4 elective surgeries have been postponed. This is the 12-week cancellation rate, which is almost 82% for the orthopedic surgeries, with an average of 2 million operations cancelled every week. And much has been written about the impact on the elective orthopedic surgeries, and it was said that if we had restarted the surgery in June 2020, it would have taken anything up to 16 months to overcome the backlog. And now you know that we have gone much beyond the 16 months. So the future is quite uncertain, as is the availability of vaccine, and the resumption of the elective surgeries is actually something where we have to move forward with cautious optimism. So Actually, the elective surgeries is a misnomer because there are emergent surgeries and non-emergent surgeries. And the backlog of elective surgery is decided by the demand as well as the decreased healthcare capacity. You have to strike a balance between the two. And when you resume, you cannot try to accelerate the simple system. You have to actually balance the speed with strategy, and you have to ramp up these strategies. So one thing is that you have to have the consistent, transparent, and bias aware algorithms for surgical prioritization. Avoid the gold rush mentality. Do not leave it to individual surgeons. Avoid first come first serve or the nuisance or the loud voice makers to don't prioritize them. And then the work has to be algorithm based, depending on the surgical risk factors, the capacity requirement factors like the availability of OT time, the PPE consumption, the ICU bed requirement, as well as the COVID-19 risk factors have to be taken into consideration. The risks have to be made visible. You can expand the surgical capacity by transitioning to the outpatient care or minimizing the hospital stay of the patient. You have to form dedicated teams to improve operating room efficiency. It has been shown that 30% of the list start late and 38% finish early. So you have to optimize your resources and make strategies for that, standardize them, and then improve them. You have to think beyond the traditional working hours. So you could actually make 3 shifts and keep on changing the teams. It's not doesn't mean that the OTs have to be available to one individual 24/7, and then you have to improve the access of OTs during the weekends. You have to focus on simplifying the patient surgical care experience. So you have to alleviate the corona pandemic fear among the patients, consider the economic consequences and affordability of the patients. Try to streamline everything so that the patient doesn't have to run from one department to other within the hospital. Avoid price opacity and use telemedicine. You have to honor existing procedures and protocols and adopt the new ones as required. And much has been written about the recommendations to optimize the safety, and the primary objective remains do no further harm. There has to be protocol for testing for indoor patients, those who are undergoing surgeries or not undergoing surgeries, outdoor patients and healthcare staff. If a patient tests positive, the recovery, the surgery has to be delayed till recovery. And we use in our institution 10 and 3, which means 10 days since the start of symptoms and 3 days without fever before we call a patient negative. Healthcare professionals may need testing when they have signs or symptoms suggestive of COVID-19, or when they have had exposure, or when they are in special settings like nursing homes, or when they are recovering to test them negative. A high-risk contact is more than 15 minutes or any duration of the aerosol generating medical procedure, or a close contact less than 6 feet. You can test asymptomatic healthcare workers, but there are ethical issues about losing manpower if they are positive. A lot of centers are actually letting them work unless they develop symptoms. The theater preparations have to be for COVID and non-COVID, and this is what we published in Indian Journal of Orthopedics. It shows the donning and the entry room, and then going on to the operation theater, exit room, and the doffing area. All this has been defined. Air conditioning has to be central, dedicated with negative pressure and HEPA filters. And if you don't have these advanced settings, you can actually use a non-recirculatory type of system, turn off central air conditioning, block off all return air vents to the OT, and then use the 100% fresh air. Now, to deal with the air going out, you can use actually either the HEPA filters or 1% hypochlorite or UV radiation. And the pressure, negative pressure should be 2.5 pascals. The supply air should have 12 air exchanges per hour, and then split alone ACs may be useful. Other OT protocols are to minimize requirement, and the personnel do not carry any personal belonging inside OT, use disposables, use special equipment in the breathing circuit, and the patient should be observed post-operatively in the theater. If the patient turns out positive after surgery, you shift him to a COVID facility. That is the best way to deal with it. The regional anesthesia is preferable to general anesthesia wherever possible, but when intubation is required, should be done by the most experienced anesthesiologist. The use of PCP PP is important. N95 and N99 and N100 are equally effective. Surgical helmet systems are useless, and the PPs have been defined as level 1, 2, and 3. And I would just like to say that the OT needs the level 3, and the wards need general ward need level 1. All other area where you interact with the patient needs level 2 PP. And all areas have been divided into 3 zones. The green zone is the zone of social distancing and masks. Yellow zone is COVID-19 status when it is not clear when you use FFP2 mask and isolation. And red zone is the COVID-19 patients and you need special PP. Avoid the use of cautery drills, ultrasonic scalpels, pulsatile lavage. Avoid contact with the splashing of the body fluids of the patient. The smoke must be removed by the aspirator. And of course, the post-op follow-up should concentrate at minimizing the patient visit. You can use some of these glues instead of sutures so that the patient doesn't have to come back for suture removal. There are some unintended casualties like osteoporosis, chronic pain, or sedentary lifestyle. Telemedicine has been extremely useful in the pandemic for managing the patients. And then, of course, we have carried on with the training of residents and fellows with simulation-based examination and interviews. And then, of course, this is also an opportunity for research. The consent is important. You must tell the patient about the risk of contracting COVID in the hospital or may already be infected without knowing. And it's basically tell them that the threat is the virus, and that's all we are taking all precautions. So to summarize, the resumption of elective surgeries even has to be moving forward with cautious optimism. We are in this together, and I'm sure all of us will get through with this together. I thank you very much for your attention.
Fine. Since Dr. Shekhar is not aware of the leftover lectures from the earlier sessions, so that's why I'm barging in without his permission. But let me assure you, this is the last one, and I'll try to keep it very short. This is one survey with the permission of Delhi Orthopedic Association we had conducted, and it was something which was a great eye opener for all of us. See, as we all know, and as Dr. Manish has discussed in detail, that there is serious repercussions for the health industry. And if you see all the hospitals, they have almost their expenses, the cost 80% fixed. So that means in such time, there's going to be a severe impact on the cash flow, and the losses are going to be tremendous. There's already been a survey which has been conducted from Lucknow, PGIMS, and it was published in the Indian Orthopedic Journal also. And as you can see, they had sent a survey, a questionnaire online to about 533 people, out of which 407 had replied. And their result was given in a concise form here, which says that almost 90% of the people, they saw almost half of the practice went down, and 64% had stopped their elective surgeries, and even emergency ones had, by 21%, they had to reduce. More than 50% of the doctors had their earnings reduced by over 75%. That's a significant numbers. Yes, and there was a direct relationship. Rather, between the people who were working alone, they had their own clinic or the setup, and the people who had their own small nursing homes, etc. They were the ones who were most severely affected. People working in the government hospitals, by and large, they were spared, and the corporate hospitals, they were left off with a reduction of almost 30 to 40% from their salary. So this survey, apart from the financial aspect, we were also trying to cover the various other aspects also. So we had almost 257 responses in this particular survey. Not a big deal, but nonetheless, it was an eye-opener for all of us. 70% of the people who responded were in private practice, 16.3% in corporate, and 14% were in the government hospital. Most of them, majority of them, were in the general orthopedics, And arthroplasty was the second commonest one, followed by your arthroscopy, sports medicine, and other such specialties. The monthly surgeries, I'm really surprised to see that most of them, they come under the category of almost 15 to 30, which is quite a healthy number if you look at it from their perspective, almost one daily. And the second category was between 5 to 50. We had a good sizable number of people who were doing more than 30 surgeries in a month, going up to the 50. And so this is the pre-COVID era, where we are trying to give you a breakdown of the number of surgeries, the percentage-wise. But this is the post-COVID surgeries. The majority of the people, they were down to less than 5 surgeries in a month, which is a severe cut short, a shortcoming. But there was still certain number of people who were doing more than 50. So perhaps on the hint side, either they were the government hospitals where they were still open, they were not fully COVID hospitals, and they were still taking the patients who had no other way to go rather than coming to these government hospitals, because all the private hospitals had closed down. And the other side also, like in South Delhi, all the major hospitals like AIIMS and stuff, I think they had closed down for the COVID patients. So our hospital, they did see a good jump in the emergency surgeries. So this is the percentage of the surgeries post-COVID, and this is the comparative study between the two. As you can see that yes, it's a substantial decrease, only less than 5 surgeries in a month which is being conducted here. Now earnings, yes, due to COVID, more than 50% reduction in the earnings, they were seen by almost 30% of the people. No reduction only in 8% of the people. If you see it from that perspective, we had almost 50% reduction in 25% of the patients, which is quite substantial. Sorry, we had almost 30% orthopedic surgeons saw a 50%, more than 50% reduction in their earning, and almost 25% saw up to 50% of the reduction, which is again quite substantial. I mean, this came as an eye-opener to us. So the question came, how were they able to survive? Did they have any alternate source of income? And again, as all the doctors are very bad financial planners, we had almost 60% of the doctors which didn't have any alternate source of income. I mean, at this time and age, can you really believe that? But that was a fact. And few people, almost 20%, they had investments, some trade stock market, almost 12.5% had property and other such investments, which are supposed to be quite healthy. Only 8.2% had medical businesses going on, such as hospital or nursing home. So then the next question was that how much of their earnings was from the alternate sources of income? So you have almost 51.4% doctors responded that it was 0%. So this is the magnitude of our financial planning, absolutely catastrophic. And up to 10% was suggested by 22.6% of the population, and more than 50% was hardly, I would say, about 5% of the people, so-called the smart people who were doing the medical practice only for the sake of it and not for the financial benefits. So the next question came, now that you have faced this particular situation, do you think it's high time you should start seeking an alternate source of income, or might change to alternate profession due to financial ease? So 0 was they are absolutely comfortable, happy in this present scenario. They won't look for alternate source of income. And the 10 was where the people, they are desperate. They want to give up this particular profession and move on to something which has more financial benefits. So only 7%, they were quite happy with the present situation. And the percentage slowly, gradually kept on decreasing. So almost 50%, I mean, the 5th percentile rather, they were sure that they were sitting on the fence and they could jump over any time. Now we are gradually going towards the people who
are looking for alternate source of income, and that's a quite healthy trend because the way that things are, the medical practice is not going to be the same anymore. We have to diverge. We have to get independent of the separate sources of income also. So the next question we asked them was, what should be the source of alternate income for you? And the maximum number of people feel that investment are still safer. The second one thought whether it is the investment into the property which is going to work here, and 31% were confident that if they continue with their medical business, or rather if they expand more of their medical business and if they get revenue out of it, they will be better off. 30% of the opinion that they should go into non-medical business. So now the next question was, fine, we all know that we are facing financial constraint, and what should we do? How should we handle it? So only 9% of the people were confident they still wanted to continue with the same lifestyle, same way. 78% are delaying, like me also, their luxury expenses. The travel plans have been postponed. And the worst part, almost 5% of the opinion that they had to cut down on the expenses of the children child education, which is going to be 7%. Then we tried to ask them, do you feel that your lifestyle, the social status has been impacted? And yes, only 10% felt that there has been no change in their lifestyle or the social status, while almost 50-60% people were of the opinion that yes, it has affected our lifestyle. So, gentlemen, this is the overall talk, and I think this is a high time we should start thinking in terms of alternate source of income so that we are never caught again in the same predicament. Thank you very much for your patient hearing. Now, Dr. Shikhar, it's totally up to you. You can start with the next session.
Thank you, Dr. Dhananjay. It was a very interesting survey. I think 2020 will always remain as a watershed year between pre-COVID and post-COVID era. And that will lead to change in the attitude as well as how you conduct your practice. Now we start the next session, that is regenerative orthopedics. And I think it's a extension of the last session, that is futuristic orthopedics, because I think the future of orthopedics is in gene therapy and biologicals. So I welcome Dr. Raju Ishwaran as co-moderator and Dr. Prateek Gupta and Dr. R.K. Manucha as the panelists for this session. We start the first talk with platelet-rich plasma. Platelet-rich plasma, good, bad, or ugly. Now, PRP came in a big way as a panacea for many unsolved problems of orthopedics like tendinitis and chondral defects. Has it really lived up to its hype? So let's hear it from Dr. Karan Rajaggi.
Thank you, Dr. Shekhar, sir. I hope everyone can see my screen.
Yes, we can.
So, yeah, it's visible. Can I request the other people to please mute themselves? I think Dr. Bhavuk Garg's screen is still on with the volume on, and it may disturb the stock.
Sir, I am muted. Raju, sir, I have muted him.
All right. Thank you. So, good afternoon, everyone. My name is Dr. Karan Rajaggi. I specialize in regenerative orthopedics. I did my undergraduation and post-graduation and subsequent surgical training from Delhi University in Delhi. And then I went to UK for my super specialty training in regenerative orthopedics. I currently work at Fortis Hospital, Vasant Kunj. And I wanted to thank the Delhi Orthopedic Association and especially Dr. Dhananjay Gupta for giving me an opportunity to talk about PRP. And essentially, whenever we talk about PRP, it's a very polarizing topic amongst orthopedic surgical groups. And one of the major reasons for that is that PRP today shows drastically different results for two different surgeons. So no two surgeons today agree completely about PRP. And one of the most important reasons I think that this is there is that today there exists no standardized protocols either for PRP preparation or for clinical decision making and patient selection while giving PRP injectable therapies. And there's also varied differences that exist in the mode of application of PRP. So I'll just go through them, over the course of the next maybe 5-10 slides. And essentially, I want to highlight that today, there a single spin versus a double spin. There are a wide variety of commercial vendors who will come with, first generation, fifth generation, 10th generation PRP kits, and they will all claim that their PRP kits are superior than anything else that you can find in the market. And although this might not be an area where orthopedic surgeons get into directly, I think it is always wise for us at least to know the basics of the methods of PRP preparation, even if we don't get into them directly. And then the second, the clinical decision making itself. So, knee chondral lesions are today probably one of the most prescribed and used areas for PRP, but that itself is a fairly large bucket. Are we talking about traumatic chondral lesions? Are we comparing them to degenerative chondral lesions? Degenerative chondral lesions, again, further should be classified. Is it predominantly patellofemoral, predominantly tibiofemoral? Even in the tibiofemoral, is it associated with degenerative medial meniscal pathologies? So, these are some of the things that I want to highlight in the subsequent slides. So I think today there is enough evidence about the use of PRP. And like I said, let's start with a specific example, which is knee osteoarthritis. And this is a landmark study which was published in 2020. And this is a meta-analysis of 34 randomized controlled trials. And what the authors have done very well here is obviously there is 1,400 plus knees in both the PRP and control groups. But what they have proved quite unequivocally is that PRP is clinically and statistically superior than placebo, than hyaluronic acid, and it's also superior to steroids. What is important here is how is it superior? So what I want to highlight here is that you can see that at a 12-month follow-up, PRP is clinically superior in terms of the WOMAC score. And this sort of benefit is retained across all categories, even in hyaluronic acid, even in steroids. This is another study from 2020, which tells us more or less the same thing, that intra-articular PRP is more efficacious. And again, what the authors have done, the metrics that they have used have all been patient-reported outcome scores, the WOMAC score, the WAS score. And the authors have confirmed the same, that PRP is superior to viscosupplementation at a 1-year follow-up. This is another meta-analysis, although this is just 4 studies. The authors have told us majorly the same thing. So today, I think there is high-level evidence that suggests that PRP, intra-articular PRP injectables are superior to hyaluronic acid and to steroids at a 1-year follow-up. And let's just go back and try and understand why that is. So if we go towards the pathogenesis of osteoarthritis, although it is a degenerative disease, at the core of that degeneration is a chronic inflammatory cascade. So there is a cytokine storm that happens, there is cytokine release that activates the MMPs, that causes articular cartilage damage, that also activates osteoblasts, which results in osteophyte formation. So if we consider osteoarthritis having at its very core a chronic inflammatory pathway, some of these clinical discussions become a lot easier. And this is a slide that goes back to our pathology days. And this is a classic chronic inflammatory cascade. The circle that you see, or the peak that you see in dark brown, is your stage of inflammation. The one in light brown is the stage of early repair. And the one in gray is the stage of late repair. So now steroids will act only on the stage of inflammation. That they are excellent in giving us a short-term control over the inflammation, reducing synovitis, but they, like I've mentioned, act exclusively on the stage of inflammation. They have little to no effect on the stage of early repair. They have little to no effect on the stage of advanced repair. Viscosupplementation, on the other hand, predominantly works through its mechanical properties. There are reports which say that there are some evidence of decreased production of matrix metalloproteinases. There is decreased synthesis of prostaglandins. But the major action of hyaluronic acid is the viscoelastic effect that it does. And now once we start coming and analyzing how PRP actually works, PRP and all platelet-derived products essentially work on release of growth factors from activated platelets. And on the screen, you find the 4 most important growth factors, which is the VEGF, PDGF, TGF-beta, and IGF. And essentially, all of these growth factors contribute towards neoangiogenesis, contribute toward MSC chemotaxis, MSC differentiation. And this essentially highlights how PRP and other platelet-derived aggregates essentially act on all stages of the repair pathway, which explains why the benefits of PRP at a 1 year and subsequent follow-up are significantly higher and better than hyaluronic acid and steroid. So I think this is one of the first points that I wanted to highlight in the talk today. But coming back to these three meta-analyses that I had shared with you, and I had mentioned in passing that they've all kept the VAS score, the KOO score, essentially patient-reported outcome scores as their outcome measures. So yes, PRP is clinically and statistically superior in terms of patient functional scores. But what is the actual radiological improvement that we have with PRP? And surprisingly, this is an area where we have very, very little literature that exists today. I'm, very honestly very surprised by the paucity of literature that we have. But this is one of the, again, a landmark study that was published in 2013, where they took only 15 patients, single injection of PRP, and they compared a pre and post analysis. So, and the authors found that in 73% of the cases, which I've highlighted on the bottom of your screen, had no radiological improvement in their cartilage, knee cartilage volume and other radiographic parameters. Now this leads us, this is where the confusion now starts happening or occurring. We have meta-analysis, 34, 20 RCTs saying that there is functional improvement. And then we have studies saying that there is no radiological improvement or little to no radiological improvement. So why is there a discrepancy? So this was a recent study published in 2019, which cleared up some of those lacunae and some of those confusions. And what these authors did was that this was actually a randomized controlled trial. They had 46 patients, 23 cases, 23 controls, and the controls were placebo. And again, the authors confirmed the improvement in the WOMAC score. So all patient functional parameters expressed or showed clinically significant and statistically significant improvement. But the authors also demonstrated three important points. Now, the first of that was, as you can see, this is an image borrowed from the study itself, that they actually demonstrated that there was a statistically significant improvement in the tibiofemoral cartilage volume. The patellofemoral cartilage volume, as you can see on your screen. The tibiofemoral cartilage volume remained more or less the same. So there was a statistical significant improvement in the patellofemoral volume, but the tibiofemoral volume and the medial and lateral meniscal integrity was not clinically significant. So yes, there was an improvement, but it wasn't clinically or statistically significant, as you can see from the p-value. And then again, there was an improvement in the synovitis, but again, the significance remains to be seen. So I think at the end of this study, some of the controversy started getting cleared up with regards to the actual functional and radiological efficacy regarding PRP. And in the next two slides, I just took two patient follow-ups, which I think highlight, where PRP stands today, especially for patients with knee osteoarthritis. And these patients received 3 injections 4 weeks apart. There was, we've been using various variety of commercial kits, and as of now, although this evidence is not statistically significant as of now, but anecdotally, there is no difference between Arthrex, Remi, the various commercial kits that are available. The KOO score was utilized for this. And the first patient that I wanted to speak to you about was a 42-year-old male who was a squash player, came to me with a classic anterior knee pain. Radiographs, including skyline view, were normal. Following an MRI, he had a grade 2 chondral lesion in the lateral patellar facet, a grade 1 in the medial patellar facet. And his main problem was that he was unable to get back to his sports without experiencing significant pain. So now if we go back slightly to the literature that I've just shared with you, this is a patient who's relatively young. This is a patient who's got a focal chondral lesion. This is a patient who has got a focal chondral lesion in the patellofemoral joint. The tibiofemoral joint majorly is preserved. There are no structural scaffolding issues. Patellar tracking is normal. So this is a patient that theoretically should respond very well to PRP. And this is a patient where we had injected, and as you can see from the dates, this was just before the lockdown. This patient actually got back to playing sports, 2 months following the first injection. And, although he might not have played after that due to the lockdown, but at least, we did our job. So this I think is a classical example of a patient where the decision-making completely mirrored the findings that one would expect through literature. And now we contrast this patient to a 65-year-old female. So this was a patient who came to me with severe tricompartmental disease, had been advised multiple surgical options, was hell-bent on not getting operated despite all evidence to the contrary. And this patient, wanted to get a PRP injection done. This patient, although had degenerative medial meniscal tears, did not experience any mechanical symptoms in terms of locking, but had significant medial joint line tenderness, and McMurray's was positive. And despite explaining to this patient that the meniscal pathology is not expected to improve following a PRP injection, she was still very, very keen to undergo that. And as you can see, that there was improvement in the overall score, in her symptoms, in her stiffness, in her pain, but advanced function and quality of life remained majorly unchanged. And this, I think, again mirrors some of the findings that we've been discussing, that chondral pathologies, while they might not regenerate, at least functionally patients will improve. And we can attribute that functional improvement to suppression of the inflammatory cascade, suppression of the MMPs, suppression of the synovitis, and actually saying that PRP today regenerates cartilage, especially in the tibiofemoral joint, and it affects meniscal healing. To this date, although theoretically possible, has not been validated in literature as of now. And whenever we try and understand or try and get some evidence into our clinical decision making, this is the triad of regenerative medicine that is actually helpful in patient selection. And an optimum regenerative environment for patients includes patients having adequate cellularity, having adequate growth factors, and having a proper scaffold. So PRP, yes, it provides us with growth factors, and it does to some extent affect cellularity as well through MSC chemotaxis, but PRP clearly does not affect scaffold in any way or form. So patients who require scaffold or who require structural stability, there are studies today happening where patients with complete ATFL tears are being treated with ultrasound guided PRP injections, which, to my opinion at least, it doesn't seem to have a scientific basis for that. If you do not have a structural scaffold, injecting PRP will not work. And which is why, I don't want to there are speakers ahead of me who are speaking about Dr. Masker will be speaking about the various cartilage repair options. But essentially for ultrasound guided applications in cases with epicondylitis, in patients with tendinitis, since we do not have a structural scaffolding abnormality, PRP should be one of the first line of treatment options that we consider. And meta-analysis, again, I've tried to keep, level 4 evidence and above, and they've all, the 515 patients on the study on the left, 374 on the right, and they all say the same thing, that PRP is better than steroids. And now coming to one of the last points that I wanted to make was the mode of application. And we've discussed that there exists differences in patient selection, there exist differences in PRP preparation as well. But the actual mode of application also affects treatment outcomes drastically. And this is just 3 studies that I wanted to highlight. These are all studies treating partial ACL tears, all adult patients, no pediatric patients. And the only major difference that you can find with them is that the first study is an intra-articular study where the surgeons have injected intra-articularly simply, whereas the other 2 are intraligamentous. And both the studies at the bottom, although they are not high-level studies, they are case reports, report that patients have been symptomatically improved. So yes, while evidence might not exist today, it is in our interest to move towards collecting these evidences, keeping basic science in mind. And the last point is for medial meniscus as well. So PRP today has shown to retard cartilage degeneration. Yes. It has shown to improve patellofemoral cartilage volume. Yes. Tibiofemoral is questionable. The impact on medial and lateral meniscus per se as of now is again questionable. So patients with degenerative meniscal pathologies, especially if they are severely symptomatic because of meniscal pathologies per se, probably are not suitable candidates for PRP, at least intra-articular PRP. Intra-meniscus ultrasound guided intra-meniscal injections while anecdotal case reports, are present here and there, as of now, the evidence suggests that these patients might be better served with surgical option or a combination of bone marrow aspirate concentrates and fibrin scaffolds, which Dr. Vinod sir is already speaking about, so I won't get into that. Finally, this is just a slide which summarizes the discrepancies that exist in the PRP preparation protocol today. So you can see that, intervals for application vary from 2 weeks, weekly, every 3 weeks, monthly on the studies on the table on the right. And then you have the differences in approach. So high level, I think I just wanted to highlight 2 important differences. The first thing is that we should always be aware whether we are using a single spin approach or a double spin approach. A single spin approach does PRP sedimentation and concentration in the same sitting, whereas in a double spin approach, obviously we have the sedimentation first followed by the concentration. The proponents of a double spin approach say that the double spin yields a better platelet yield, but the proponents of a single spin approach say that the double spin actually affects platelet morphology and interferes with growth factor release. So as of now, this is an area of immense controversy, and there is enough evidence on both sides. So I think this is an area for future research, but at least as surgeons, we should be aware of what PRP we are injecting. And the second is actually, are we using an activated PRP or not? Now, this is an area which is potentially less problematic, because chemical activation of PRP has globally been accepted as probably the standard of care. Calcium chloride and thrombin are the 2 most commonly used ones, either individually or in combination. And these are 2 questions I think that we should always, or 2 answers that we should always be aware of when we are injecting PRP. And these are just some of the discrepancies or the unanswered questions I've gone through this. So finally, as a take-home message today, PRP serves an identified therapy gap. Yes, it has excellent short-term results. So today, literature that exists surrounding PRP is a 1 year, 12-month, 18-month, at best a 24-month follow-up. We need longer-term results to make a definitive statement about the use of PRP. Functional and pain improvement is now being proven inconclusively. So I think that there is absolutely no doubt that patients respond better in terms of pain and functional scores. Radiological outcomes, on the other hand, are slightly inconclusive. Tibiofemoral patients probably behave a little better. Patellofemoral behave probably a little better. Tibiofemoral probably not as much. Cartilage regrowth as of now has not been conclusively proven. So finally, I think the most important tips are that we have a proper patient selection, proper communication, and obviously one of the most common, we avoid NSAIDs 3 days prior and 3 days post any PRP injections. Thank you.
Thank you, Karan. So we can take few questions now. Karan, initially, previously there was a lot of talk about leukocyte rich and leukocyte poor PRP. Now, yes. So does it still exist? Do we use the same kind of PRP for tendinitis and for arthritis or chondral defect?
No, absolutely. I think that's been proven now, sir. So for intra-articular injections, leukocyte poor PRP. For tendinopathies and intraligamentous and intrameniscal, it is actually leukocyte rich. We actually now have reports of concentrated growth factors being used instead of PRP. So we have now CGF or GFC. There are products available which actually take away the platelets themselves, which is actually a very interesting concept, because they say that the actual activated particle in a PRP is the growth factors themselves. The platelets themselves do not do anything. And which is why now there are kits available which actually cause chemical activation, release the growth factors in the serum, and that is then collected and inserted. So for intra-articular pathologies, there is absolutely no doubt that we need to inject leukocyte poor, but for ligament and tendons, it is leukocyte rich.
Dr. Shekhar, can I ask you a question?
Yeah.
Dr. Karan, excellent presentation. I would just ask you a very basic question. Who would be the ideal patient for a PRP injection in a case of osteoarthritis? Who will be your ideal patient to inject PRP?
Yes, sir. Sir, I think an ideal patient would be somebody, let's say 30 to 40 years of age, having a focal, traumatic, purely chondral lesion of less than 1 centimeter square. And I think all of these 4-5 parameters are important. So age of patient affects the regenerative potential. Traumatic, purely chondral, not osteochondral, but purely chondral pathologies, especially if they are, like I said, in the patellofemoral joint, not the tibiofemoral. Are, I think, patients who are ideal candidates for intra-articular PRP injections. Clinically, for the knee joint, ultrasound guided has not been proven to be beneficial as compared to a clinical injection, because I think, for the knee, we are fine. For intraligamentous, especially for rotator cuff pathologies, obviously an ultrasound guided is probably the treatment of choice.
Dr. Karan, I think Dr. Sharath probably meant the kind of osteoarthritis patient that walks into us, not the 30 to 40 that you are referring to, maybe the higher age group, let's say 50 plus. So what, according to you, would be your indications for, because if I can just make a devil's advocate kind of a comment on both the cases that you presented, maybe a lot of placebo role also played. The squash player would have been very keen to get something into his knee so that he could start playing squash. The lady who was reticent for a knee replacement would be similarly keen to get something into the knee to not get a knee replacement. So what is your indication for OA?
So for degenerative pathologies, I think it should reasonably be a purely degenerative pathology. Patients either should not have degenerative medial meniscal tears or lateral meniscal tears, or even if they, commonly we will find patients having these tears, at least they should not be symptomatic from a meniscal point of view. So 50 to 60 years, patellofemoral osteoarthritis more than tibiofemoral osteoarthritis, have relatively asymptomatic from a meniscal pathology, having patellar symptoms being prominent. I think these would be patients who, should be considered for PRP prior to any surgical intervention. But having said that, as of now, honestly, there is no standardized protocol that dictates, this is just evidence-based medicine that has been collected over time, and this could be a personal opinion as well.
And this is a very valid point, because patellar patients traditionally do very poorly with viscosupplementation. So maybe PRP is the answer for them.
But I think for patellofemoral pain, there are lot many other factors. So I think let's move on to the next topic, because we are already late by almost 1.5 hours. May I invite Dr. Vinod Kumar, and he'll be speaking on BMAC. Is it the magical potion we have been hoping for?
Yeah, good afternoon to all respected seniors and dear friends. I hope I am audible.
Yes, we can hear you properly.
Yeah, screen is visible.
Yeah, we can see you. Please go ahead.
Yeah, so thank you. So thanks to Dr. Dhananjay and all team to allow me to share my views on this. Although the language of the title is very fascinating, given to me, that BMAC, is it the magical potion we have been hoping for? We all know that nothing magic in medicine, but yes, we will try to analyze the literature and see where does it stand today. So like we all know that the stem cell are actually the basis for regenerative orthopedics, and mesenchymal stem cells retain their properties after culture expansion. And this is the feature which is unique, and probably the chondrocytes which does not maintain their phenotype after expansion. So this way, these cells probably seems to be having better potential. Sources of these mesenchymal stem cells are various: bone marrow, adipose, umbilical cord blood, and all these periosteum, dermis, etc. But for orthopedic purpose, this probably bone marrow origin mesenchymal stem cells are the best. So what actually this bone marrow aspirate contain? Majority is basically these neutrophils and erythroblasts, and the neutrophils concentration is lower in male, while these erythroblasts are more in males. And this constitute almost around 60% of this. Rest are these lymphocytes, eosinophils, blast cells, etc. And these actual cells of interest, these are the mesenchymal stem cells, are very few, that is 0.01 to 0.01% only. What was yeah. So just to have few important things about the technique issues, I'll not go into detail. There are various techniques, but the most favorite site is basically the iliac crest, and posterior iliac crest gives better cells, that is more than 60% higher than from anterior iliac crest. And technically, there are few points which are worth to understand if we are going to aspirate from iliac crest, that there are anatomical studies which clearly guide us that how we should proceed. If they have divided this iliac crest into 6 zones, and only these second, third, and sixth, these are the 3 zones which are actually safe and as well as provide better concentration of the cells. There are definite risks also to aspirate from these areas. They are not without risk. There are chances of external iliac artery to get injury if you are taking from anterior side and you get suddenly slipped under pressure. And there are also chances of even sciatic nerve injury if you are aspirating from posterior iliac crest. And there is, if you see, if you insert the trocar in posterior component more than 6 centimeter and deviate more than 5 degree, then there are chances to penetrate the cortex. So as you go deep, chances of tilt injuries are higher and higher. So you have to be very careful. Just don't take these things lightly. And another important thing is that size of syringe also surprisingly matters, that the concentration of mesenchymal stem cells were approximately 300% higher if you have used 10 ml syringe versus 50 ml syringe. And this looks against that, but yes. So we have to use the small volume syringe and to perform the aspirations from multiple sites rather than to use a big size this thing. So in the same way, the ideal volume aspirated from each area also varies, and the limiting aspiration volume, if you want a good concentration, is not more than 2 or 3 ml from one site. So it is better than you should take from different sites rather than to collect all from one area. Now question comes, why we want to convert this bone marrow aspirate into the concentrate? And reason is very clear, that as we know that the cells concentration is very less, and which probably is not optimal for most of the means regenerative procedures. So there are 2 methods to increase the concentration of these mesenchymal cells. First one is the culture, that you can isolate them and send them for culture. And second is that you can concentrate and increase their concentration. So we have to understand both methods. There are advantages as well as disadvantages of each. If you are culturing these cells, then this has an advantage in terms of that this gives a homogeneous cell population and the number of cells is really very high. So these 2 are the advantages. Vis-a-vis this BMAC has a heterogeneous cell population, and this has a you can say the limited capacity to increase their concentration, that is almost around 5 times. What this study says that normally this is around 600 cells per ml, and if you concentrate it to 1/5, make it 1/5, then accordingly the 5 times, roughly around 2500 cells per ml is the average which you can get by this BMAC. But there are the other sides of this, that disadvantage of this method are that question of sterility, genetic stability, and these ethical issues. Probably that's the reason why these are not approved by FDA, and the high cost, and they are the 2-stage procedures. So these all are the limited factor in spite of having these biological advantages. However, in this BMAC, these all are the advantage, that it's just a 1-stage procedure which can be done in the same sitting on the same OT table, and this is definitely cheaper, and there are no ethical issues that this comes under a minimal handling of the tissues. Now, the mechanism of action of BMAC is basically by both ways. One is through the mesenchymal stem cells directly, which are the multipotent cells, and they have the quality of immunomodulatory capacity as well as the multilineage differentiation, and they can transform into different cells, maybe vessels, bone, cartilage, or fat and muscles, etc., depending on the milieu and these other modulators available at that particular site. And the second important thing is, as in PRP, that all those factors, these platelet derived factors, growth factors, are also there, which have some impact on the chondrocyte proliferation as well as in the healing through the collagen synthesis. Now we have to understand what are the indications of this BMAC in orthopedics. There are these four main indications, that is in bone defects, avascular necrosis, tendon injuries, and cartilage defects. So I'll just go briefly one by one. BMAC has been used to augment, in some cases, to replace the bone graft with the aim of improving the incorporation of bone graft. These are the various studies which have used BMAC along with grafts as well as alone, and there are encouraging results. Even the study says that injection of pure BMAC also helps in osteogenesis and management of non-union. However, we have to understand that non-union is a complex situation. We cannot just expect from BMAC to treat all non-unions because it requires a lot of mechanical things and other things also. But yes, there is an evidence that it has a good osteogenic potential and may help in achieving the union. Now, another indication is avascular necrosis, which is commonest in the femoral head. And there are these 3-4 studies which clearly says that this use of BMAC along with the core decompression definitely gives better results than core decompression alone. So this is one area where this can be successfully used. Results are encouraging. Now into the tendon injuries, there are not many studies on this. There are only these few small studies which have used this BMAC in rotator cuff repair procedure as an adjunct. And these studies are suggestive that this BMAC has a potential to increase the healing, but probably this part is not very well supported by some randomized trials and all, so require larger studies. Only some few pilot studies are there. Now coming to this last one, which is the most important challenge, that is the cartilage repair. Where does BMAC stand? And the BMAC has definite place in procedures treating the cartilage, and the modalities how you have to use are also variable in literature. It has been used alone, just like an injection intraarticular. It has been used then gradually in BMAC with scaffold, and it also used along with some other procedure as a concomitant along with other microfracture, etc. So let us see how this technique in the cartilage is basically the same, that first you have to evaluate the defect, then you can aspirate and prepare the bone marrow aspirate concentration. I'll not go into the detail. Basic philosophy is that it is based on the centrifugation principle, differential centrifugation principle. You have to do twice. In first cycle, you make it 3,500 RPM for 5 minutes, and it separates the RBC in the lower chamber and buffy coat having all the mononuclear cells in the middle and plasma in the upper. So then you just lock the RBC chamber and mix the rest too. And then after that, you put this PD back in the centrifuge machine and spin it again for 3 minutes at lower RPM of 3,200. And then finally you aspirate this concentrate and prepare it with mixing with the thrombin and fibrin and load it in the dual syringe having this mixture and fibrin. So there are different techniques of this with the different available kits. So you have to read those instructions. It's not so important, but yes, now there are professional kits available how you should do this and these kits are very handy now. Now coming to the results in cartilage repair, on exploring the literature, there are two type of evidence, that is the translational and clinical. Now first, these translational studies are, majority of studies are favoring that probably this BMAC is giving better results than microfracture alone, and these were done in goat and horse. So by getting encouragement from these studies, these clinical studies also started. The first study was in 2009, and then till date almost there are 17 studies where this has been used for cartilage defect. These 7 studies were used for only full thickness cartilage, and 10 were used for osteochondral lesion. Out of these, a majority were for knee, but also in talus and patellar defects as well. This is according to this review. Now, the few important studies which have seen these results, this Gobi has done really the pioneer work in use of BMAC. So he has studied and seen that it is actually helping, and it has been compared by other modalities like PRP and others, and they find out that probably its results are better and encouraging. However, the good clinical efficacy of BMAC, both as a concomitant with cartilage restoration procedure as defined time after surgery and as isolated injections, is almost there. Early clinical data results, BMAC helps stimulate more robust hyaline cartilage repair tissue response, but still there are some questions like cell source, cell expansion, optimal pathology where you have to use, and the timing of injection, and what should be the ideal quantity. All these things still are not very standardized. Now, there are few studies which have compared directly with the other cartilage restoring procedures like this microfracture. So this BMAC provides better clinical outcome and more durable cartilage repair than microfracture alone. Now, there is only one study which is also has compared this BMAC with the MACI, that is ACI third generation. And this is again with having 3-4 years follow-up by Gobi again. Both the techniques were viable and effective, but these were for patellofemoral condyle lesions, not for tibiofemoral. The deterioration in MACI and improvement in BMAC group scores were noticed from 2-year to final follow-up, but there were no difference. These MACI patients with trochlear lesions showed better results than patellar lesions, while location was not a prognostic factor in BMAC group. So this is only one study which has directly compared. I have some experience to doing this procedure for last couple of years. Only these 1 or 2 cases I am sharing on cartilage defect. So this is the first case, which is a 24-year male patient diagnosed with a grade 4 osteochondral defect. You can see that it's a huge defect, and even significant bone loss is there. So I think this is the condition where definitely these MSCs take over the pure ACI, because here we have multipotent cell which are expected to take care of these bone defects as well. This is a clinical picture, so in a very bad shape. And here I have done this BMAC with all standard procedures. So I have filled it completely. After preparing the defect, it became quite big, almost 6-7 centimeter square area. And this is a 6-month follow-up. So it's almost no stiffness, walking painless, doing all his day-to-day activities. And this is the MRI picture of 6 months after, which is suggestive of some healing response. You can see not completely healed, but definitely this is a healing response is there. And I think it's early to say. Probably in a later MRI, I will be in better position to tell you. Still patient is in follow-up. This is the second patient, which is again is a young guy, 35-year-old person. He's having the same features of recurrent effusions, pain, and his diagnosis is again is a major osteochondral defect, grade 4, even visible in X-ray. You can see yes, almost half of the condyle, and even in lateral view, there is a major collapse. These are the MRI pictures, and see all this. These are the very vague sort of osteonecrotic patch, probably, although there was no history, but these type of pictures sometime is there in steroid-induced osteonecrosis. We are not sure about this, but it was a very funny picture. But there was a massive defect in the osteochondral defects. So this is the peroperative picture. Again, there is a massive defect, very poor quality of cartilage as well as bone. So it was actually an indication for a allograft osteochondral, but somehow we don't have this facility. So here the depth of defect was more, so I was not very sure, and I put this autogenous osteochondral grafts from the lateral condyle. These were the 8 millimeter in diameter. I could harvest 5, but in spite of that, there were definite area which still were uncovered. And here to take care of this area, I used this technique as a hybrid use of BMAC, and I filled all this area by that. I could find out in literature only one case in talus like that, and there was no case report in the literature in knee. So somehow I was reluctant, but I performed because I was having no better option other than this. So I tried this, and now results are encouraging. This was just 3 months, 3 months post-op, and he was having no stiffness and pain relieved. General physical activities resumed. This is the MRI picture at that time. They are getting well incorporated, although it's very early to say because 3 months is too early for it. And actually, I just called him just once I got the talk invitation. He's from Bhopal. So he was unable to come because of the fear of Delhi that it's the panic is there. So I requested him to send me some functional video, and these are the video prepared by patient attendant himself, and he just sent me on my WhatsApp. So he's looking I think quite good, and he's comfortable. He has no complaint now, and I could not get MRI. Probably he will come in after this COVID, and then we'll see in MRI, and then exactly the pattern of healing. But this clinically seems to be good results. So dear friends, here take home message is that probably BMAC is not a magical portion, but definitely has an emerging potential. The early results are promising, but still this technique is evolving, and large multicentric studies are needed to exactly standardize the procedure, the cell source, expansion, optimal pathology, and timing of injections. So thank you to all of you for your patience hearing. Thank you. Now, any query or any question, I am ready.
Vinod. It was a really very good presentation, and your results have shown the good work which you have done.
Thank you.
So, do you use ACI technique also?
Yeah, I have used initially, not for last, I think, 2 years because of this problem of that it was got banned by the ICMR, but I have experience of around 10, 15 cases before. And ACI also is good. So I have not done any comparative in my hand. And literature also is silent on this, except one study which I have quoted. So it's not an evidence base to say which one is better till today. But theoretically, I see some advantage with ACI in terms of more concentration of available homogeneous chondrocytes. So probably the cartilage repair should be faster and better. But the deficiency is that it is a selective. So if there is any osteochondral defect, then it may not take care of the associated subchondral bone problem. In that way, probably BMAC may take better. But I think till today, I cannot say that which one actually is better in large defects. Difficult to say.
Okay, and histologically with BMAC, we get a superior fibrocartilage.
This actually hyaline like rather than fibro means it is better than microfracture. It is almost you can say same as ACI in early. It's not, you see, even in ACI it is not the true hyaline because the pattern of collagen parallelity and all that is still could not be achieved in those 5-6 years. That may take long time. So they say in ACI in BMAC that it is close to hyaline. It's hyaline like, you can say. Nothing is a true hyaline.
Okay. Do we have any more questions from the panelists?
No, I think, Shekhar, in the interest of time, let us move on with an excellent talk by Dr. Vinod. And I think let's invite the next speaker, Vikram Maskar, to give his talk. And I would request all subsequent speakers to please kindly stick to the 10-minute allotted time.
Thank you.
Thank you so much, Dr. Raju, and thank you, team DOA, Karan, Dr. Dhananjay. And it's a real honor to be able to present a lecture on a very, very important topic, which is an enigma in itself, in front of such an esteemed panel. And I hope to demystify this to some extent with this lecture. So cartilage lesions can be classified into focal cartilage lesions, which is the topic of concern in our present talk, or diffuse like osteoarthritis, which I would not stick to because it's a topic in itself. And when you manage it, you take into consideration the size of the lesion, you take into consideration the pathology, the cause of the lesion, and the depth of the lesion. So these are the three things you consider before you decide on a particular modality to treat it. And size, we divide it into those that are less than 1 or 2 centimeters squared, we call them small lesions, something like this. Those which are 2 to 4 centimeters squared are called medium lesions. And those that are greater than 4 centimeters squared are large lesions. So this is something we quite commonly encounter in our orthopedic practice, an MRI like this with a lot of bone edema. So this could be due to an acute incident or a traumatic or a chronic incident to the bone or the cartilage. Now, whether acute or chronic, the causes are variable. Could be osteonecrosis, traumatic, very common, overloading, OCD, osteochondritis dissecans, or steroid usage. And depending on the size of the lesion, it could be either small or large. So we know that articular cartilage has various, cartilage is made up of various layers, starting from the articular surface to the superficial deep layer, and ultimately the subchondral bone and the calcified layer that separates it from here. So grade 1 lesions, it's important to know these grades because your treatment is dependent on them. So ICRS and outer bridge are the biggest grading systems. So ICRS refers to those where there's a little bit of softening of the cartilage is grade 1. Grade 2 are those that extend variably within the cartilage layer depth. Grade 2, outer bridge also takes into account the diameter of the lesion as less than 1.5 centimeters, which is ICRS, which is outer bridge 2, or greater than 1.5 centimeters. And those lesions extending all the way down to the calcified layer, but not through it, are ICRS grade 3. And grade 4 are those that extend all the way into the subchondral bone. Now, subchondral bone is extremely important for nutrition. It helps in load bearing, and it's a warehouse of bone marrow stem cells and growth factors. So before any cartilage repair, the take home message is consider subchondral bone. So if we look at this is the layers of the cartilage. They act like the subchondral bone acts like a trampoline. So it basically takes the load off the cartilage layer, as can be seen here. So what are our management strategies? They are divided into, for simplicity, repair, which involves refixation of lesions or microfracturing of lesions, regenerative procedures where we try to create more cartilage, like autologous chondrocyte implantation, better known as ACI, or reconstruction, which is your Oates mosaicplasty, allograft transfer. So we can broadly classify it into these 3 categories. So let's start with refixation. So typical traumatic lesion that we received is one of my patients. You can see the lesion arthroscopically. I like fixing them arthroscopically with multiple biopins to stabilize them, as can be seen here. which stabilize the lesion and help in healing later on. The other possibility is to do a suture bridge fixation. So you may have a large osteochondral lesion like this. I like fixing them with bead pins carrying non-absorbable sutures like the suture tape that are delivered on the lateral or medial cortex. So I put them in a cruciate fashion and tie them over a bone bridge, or you can even use a sort of implant on the lateral or medial aspect. Microfracture is something wherein we stimulate bone marrow stem cells to be released to produce fibrocartilage over our lesion. So look at this typical lesion. First thing you do is debride it till you reach the calcified layer, then use a curette to remove the calcified layer. Once that's done, using a bone awl, multiple trephinations are made in the bone to reach all the way to the subchondral bone to release bone marrow stem cells, which ultimately lead to healing with fibrocartilage. So certain technical tips here, so should be done in outer bridge, 3 or 4 lesions. Your pick should be directed perpendicular to the lesion. There should be at least 3 to 4 holes per centimeter that are 3 to 4 millimeters apart and about 4 millimeters deep. So how do you know you're deep enough? You'll see fat droplets. So that's something to look out for. Then we move on to osteochondral autograft transfer, Oates, mosaic-plasty. They're both more or less the same. It's just the company, one is Smith & Nephew, one is Arthrex, that manufactures these kits. They are used for more active patients. And typically these are the lesions that you get. First thing is to measure the lesion with a tamp. Then to go through adequate depth to the lesion to accept osteochondral plugs that have hyaline cartilage in them. These are harvested from non-weight bearing areas like the lateral femoral condyle or the intercondylar notch. So these plugs are taken and then fixed into these lesions as a press fit sort of fixation. So you do 1, 2 or whatever, depending on the size of the lesion. And this ultimately leads to a hyaline cartilage cover. So best done in those less than 45 active people, and the bone plug length should be at least 15 millimeters, if not more. It should be kept proud rather than subsiding them because bone overgrowth rates are less, and best results are with 1 to 2 plugs. More than them, the results are not as great. Next, we come to autologous chondrocyte implantation. So this is best done for active people with larger lesions. And when the lesion is more than 6 to 8 millimeters deeper than the subchondral bone, we may have to graft it first, because remember the subchondral bone is very important for cartilage regeneration. And this is always a 2-step procedure. So what do we do first? We first clean up the lesion a little bit. The next step is to again harvest cartilage bits from non-weight bearing areas. These are then taken to a lab and put into a medium which is cultured. These are then harvested from this after about 5 to 6 weeks, mixed with a fibrogel. They are injected into the lesion, and over a period of time, they form hyaline-like cartilage. Now, sometimes, as I said, when it's deeper lesions, you need to bone graft them first to get a good subchondral bone before you do the ACI procedure. So greater than 6 to 8 millimeters deeper, do a bone grafting, and then do a ACI after that. Now, sometimes you have massive lesions, very, very big. You know that ACI may not help. And in those cases, osteochondral allograft transfers can be done. Difficult to get them in India, but there are a lot of companies that manufacture them where you get these osteochondral allografts that you can put in a press fit manner after preparing the bed. So this is my algorithm to manage a case with a cartilage lesion. So these could be the reasons for the cartilage lesion: OCD, trauma, OCN in a patient who's younger than 50 years old. If the lesion is less than 2 centimeters, low demand patient, first choice, microfracture, second choice, osteochondral transfer. High demand, active chap or woman, first choice, osteochondral transfer, second choice, ACI or autologous chondrocyte implantation. 2 to 4 centimeters, low demand patient, microfracture first, OCT, osteochondral transfer second. High demand patient, first choice and only choice is autologous chondrocyte implantation. Let's say we have a failure here. What we do is a redo ACI or an ACI if any of the other procedures have been done. Those greater than 4 centimeters, low demand or high demand, you do an ACI and or a bone grafting along with it. So important factors to consider before doing anything. Alignment. So unless you correct biomechanics, you are not going to cause the cartilage to heal up again. So biomechanics extremely important, and greater than 5 degrees mechanical valgus, very important. Habit, smokers, healing is worse. Age, best done. Best results of these procedures are in patients less than 40 years of age. And if you have a ligamentous deficiency, correct that before doing any kind of cartilage procedure along concomitantly or otherwise. So this is a animation showing you why when you do a cartilage procedure, it's very important to unload the compartment where the cartilage procedure is done by doing an osteotomy so that the alignment is corrected along with a regenerative procedure. So what are our recent advances in this? So this is the latest thing, particulate articular cartilage. These are two types, which is the CIAS, which uses a autograft, and de novo NT, which uses juvenile allograft cartilage, which are particulate cartilage. So they basically, in CIAS, you basically take cartilage from the patient itself. It's a one-step procedure. Advantage over ACI, you take it out, you take a little hyaline cartilage, you make it into small 1 to 2 millimeter pieces, and you put it into the lesion and then put a fibrogel over it. In de novo NT, the same thing essentially, but they have a prepared juvenile allograft which you can put in, which is small 1 to 2 millimeter chips. Advantages of this, which are very preliminary, 1 to 2 year follow-ups, have shown that the shape of the cartilage chondrocytes are more spherical, more like the original hyaline cartilage rather than hyaline-like cartilage where it's spindle-shaped. And of course, the latest is augmentation of microfractures with scaffolds that are available like Cargel and stuff like that, that have these factors that stimulate cartilage regeneration. So ultimately, we have this hyaline-like cartilage. We want the one to your right, which is hyaline cartilage. And that's what Thank you.
May I ask a question?
Yes, please.
Yeah, Shikhar. Vikram, excellent talk. You did mention, I think in between, wanted to find out, like some of your cartilage procedures, would it be useful because to increase the concentration of cells to use, as we have heard in previous speakers, mesenchymal
I'm sorry,
cells
I
of
lost
PRP?
you. Did you? I'm sorry, I lost you. I'm just back into the this thing again. Was my presentation complete?
Yes, I think we saw.
Yes.
Okay, you can please ask me your questions again. I'm sorry, I couldn't follow you. My internet connection was dodgy.
Sure, I've been having the same problem. No problem. Vikram, it was an excellent talk. Just wanted to find out, you did mention about mixing, scaffolds sometime with mesenchymal cells, but I was thinking for cartilage repair procedures like you do microfractures and other things, would PRP and mesenchymal cell in association with the procedure would increase the result? So maybe sometime we have very little chondrocytes. So if we augment it with MSCs, mesenchymal stem cells, they would have a better outcome?
I agree. I think after listening to Karan's talk, I decided to just stick to the surgical aspect. But I think there's a variety of options, and any of these, though I don't have any personal experience of using PRP along with these cartilaginous procedures that I do, but I'm sure
I think we've lost Vikram again. Maybe Dr. Pratik, you can listen to his reply a little later. If you kindly permit, can we move on, or are there any other, I think questions would be impractical because he's not able to join. Shikhar, shall we move on to the next talk?
Yes, Raju.
Yes. Right. So it's my pleasure to invite Dr. Sandeep, who would be speaking on biological factors in soft tissue healing. Dr. Sandeep, you would need to unmute yourself, please, first.
Am I audible now?
Yes, sir.
Yes, yes. Yes, please go on.
So at the outset itself, I express my extreme thanks to Delhi Orthopedic Association, particularly led by President Dr. Dhananjay Gupta. Please.
Sir, either you stop your video because your internet connection is some sort of instability there. Can you stop your video, sir?
So I think that's the next speaker knocked down by a poor internet connection. And Dr. Pratik, if I may ask you, it was very interesting in Vikram's presentation that there was no mention of BMAC. So we had Dr. Professor Kumar speaking solely on BMAC, and Vikram in his nice algorithm didn't even mention about it. Do you use BMAC in your practice till the time we are able to get Dr. Sandeep back? Dr. Pratik, you are muted.
Sorry, yeah, it's interesting, Raju, you're right. And I was going to ask, again, thanks to internet connection, I could not. In BMAC, you see, both studies have shown that even after concentration, the amount of mesenchymal cells that we get is anything between 0.01 to 0.001%. So how much applicable it is to increase to bring the results. So there have been various studies, and there is a plethora of heterogeneous material used. So I am not using it at the moment, because in usual practice we use PRP, which is much simpler procedure to do, less cumbersome as compared to BMAC. But obviously in certain indication, like Dr. Vinod showed some fabulous results with such a big lesions, where my heart would be little not allowing me, but he showed tremendous results. So that encourages us to maybe use it next time.
True. And the biggest drawback is the need to flip the patient around to go to the posterior iliac crest. Even though people have used it from the anterior crest and some from the tibial plateau as well, but
yeah, and it's very painful. And it's very painful as well.
Yes.
When the patient lies at home, when he lies on his back, which the people mostly do, it is painful. So we have done few for AVN, early stage of AVN. I've done few, but that is my only indication is AVN, where we are seeing in stage 1 or a pre-collapse stage, where we decompress and then we put BMAC and then seal it with the bone wax. So, but it's jolly painful.
Raju, can we take the last talk?
I think so. Let's do that.
And then we'll come back to him.
Yeah. So Shekhar, please go on and invite. I think the last speaker is Dr. Vivek Mahajan. He'll be speaking on the role of biologic arthroplasty. Dr. Vivek, are you ready with your talk? Can you upload it right now?
Yeah. Good afternoon, Dr. Raju. Am I audible?
Yes, loud and clear. Your screen is not visible though as yet.
So, the screen is visible?
Yes, indeed. Please go on.
Okay. Just give me. Well, good afternoon, respected panelists, moderators, and I would like to thank Dr. Dhananjay for giving me this opportunity. Well, most of my talk has already been covered by Dr. Vinod and Dr. Vikram. So this might be a summary of what you have heard before. So I'll be talking about biological arthroplasty. Is it the future of regenerative orthopedics? Well, we already published a chapter on this in this cartilage book by ICRS. And to begin the talk, this is what we call as orthobiological surgeon's prayer, is to have the ability to help when you can, the judgment to know when you can and cannot help, and the wisdom to know the difference. Well, when we talk about the biologic arthroplasty, I want to make it very clear that we're talking about the focal defects which can be managed, not about the generalized osteoarthritis where the patient needs the joint replacement. In my practice, the indication for biologic arthroplasty is focal, full thickness, articular cartilage defects, osteochondral defects, localized avascular necrosis as shown very well and beautifully by Dr. Vinod, and early degenerative defects. I usually don't try to do these techniques in older individuals who are more than 60 years, obese with a BMI more than 30, tricompartmental severe OA, untreated malalignment, knee instability, any patient who have undergone a multiple steroid injection in the last 3 months of biologic arthroplasty, and patients who are non-compliant to rehabilitation. Just to share with you, this is a soccer player, grade 4 defect, patella defect with the anterior cruciate ligament rupture. Defect was quite big, so we discussed all the options with the patient from microfracture, ACI, BMAC, cartilage plug, patellofemoral replacement, and even to leave the sports. And eventually BMAC was done. He was back to doing sports at 1 year of follow-up. MRI showed the almost complete filling of defect at 2 years of follow-up. 2 years follow-up arthroscopy showed almost the complete healing of defect, and biopsy was taken which show type 2 collagen. It was hyaline like cartilage, not the exactly hyaline cartilage. Well, our goal in biologic arthroplasty is the restoration of the structural and biomechanical integrity of the articular cartilage. If we talk about ideal cartilage regeneration, we need something which should not have any fibrous tissue, which should show a good basal and lateral integration. It should have abundance type 2 collagen and proteoglycans with no advancement of tide mark, and it should protect against the osteoarthritis in future. But at present, we don't have something which we can call as an ideal regenerate. In last 20 years of evolution in orthobiologics or biologic arthroplasty, there have been two big steps, which we can say the steps forward. So one is we know the disease mechanism in a better way, and there have been dramatic enhancement in terms of biotechnology. So probably now a chance for articular regeneration does exist. If we talk about the global options, either you replace the cartilage using an auto or allograft, or you do a transplantation by ACI, or do a mesenchymal stem cell stimulation either by microfracture or BMAC. Microfracture has been a good step, but maybe not ideal, because the clinical effect, it tends to decrease after some time. The repair tissue or the fibrocartilage, it tends to deteriorate after some time, and whatever functional or athletic activities achieved, they tend to decline after some time. Moreover, sometimes a microfracture in almost 30 to 50% of the patient, it causes the formation of intralesional osteophytes or a bony overgrowth. Due to alteration in
Hello,
the
is that Dr. Naveen Talwar? Good afternoon, sir. This is Dr. Karan Jaggi. I am calling on behalf of the Doacon team.
I would request the non-speakers to mute themselves.
So
This
you were
is
invited as a panel member for the discussion on national telemedicine guidelines.
Well, due to alteration in the subchondral bone and intralesional osteophytes, a lot of time what happens that if you need a subsequent cartilage repair, it tends to fail, especially the failure rate of ACI increases almost by 3 times if you have attempted the microfracture. So microfracture dictates a worse outcome for the next cartilage surgery. So it is not as benign as we always assume, and it does burn the bridges if we talk about the next or subsequent cartilage repair. So maybe we should change our protocol and try to avoid doing microfracture in defects where we expect the high failure rates, especially in patella or trochlea, because these defects might need a subsequent cartilage repair. ACI, 25 years of clinical experience, fantastic results, durable, good clinical results. However, it involves high costs because it involves the cell cultivation and scaffolds and 2 surgeries, of course, and it does not address the subchondral bone. If we are doing a pure chondral treatment like ACI, it will not have any effect on the subchondral bone and the joint microenvironment. Maybe it's a time to think that when we are addressing the cartilage issues, we need to look after both the subchondral bone as well as the cartilage, because the subchondral bone matters. And we have learned it the hard way. Like in this case, you can see there's almost grade 4 defect. Subchondral bone was involved. We did the cartilage repair. It has given us fantastic results, but still you can see the subchondral bone, still it has not regenerated. So probably we should have done some procedure for the subchondral bone in the beginning. Because no matter how beautiful your cartilage repair is, if your subchondral bone is not strong enough, eventually this cartilage repair can collapse. Due to these assumptions, Sanchez proposed the sandwich theory, which presumed that probably the primary driver for the cartilage repair are subchondral bone and synovium, because these two structures are highly vascular and highly supplied by neural tissues. Cartilage by itself is avascular and aneural tissue. If we talk about a biological arthroplasty timeline, we started off with ACI, first, second, third generation. Then new scaffolds have come up. Slowly, we are moving towards a one-step surgery using BMAC. Dr. Vinod has spoken beautifully about all things related to BMAC. So I'll just brush through this. BMAC, why we prefer it? Because it's easily available, high proliferation capacity, can differentiate to chondrocytes for cartilage regeneration, and moreover, it's a one-step surgery. That all steps are very simple. You just need to prepare the defect, harvest the marrow, prepare it, and do the final implantation. We evaluated 25 patients with large defects using BMAC and published our results at 2 years of follow-up. We concluded that probably the BMAC is capable of regenerating a repair tissue for chondral defects. But is there any evidence in literature for a biologic arthroplasty? The results of biologic arthroplasty or using BMAC and collagen matrix has been published with 3 years of follow-up showing promising results. This paper reference has already been given by Dr. Vinod, that if you compare BMAC to ACI, both techniques are viable and effective for the large patellofemoral chondral lesions at a minimum follow-up of 3 years. Another interesting paper which has come from Nick, that in this paper, it was compared ACI oats and BMAC for talar lesions, and the author concluded that probably BMAC is a treatment of choice for primary osteochondral talar lesions. Just to share with you a case, this gentleman, young chap, 22 years old, had a full thickness cartilage defect over the medial femoral condyle with anterior cruciate ligament rupture. So I did anterior cruciate ligament reconstruction by all inside technique and the cartilage repair. And you can see on table, taking the knee through a range of motion, you can see the cartilage repair looks quite stable enough. So biologic arthroplasty is a user-friendly technique which involves the various cartilage repair techniques. However, we need prospective randomized studies at long term, especially in large lesions. If we talk about bucket of wish list for a surgeon involved in biologic arthroplasty, we need a scaffold which can give good integration to the bone, subchondral bone, as well as the cartilage. We need an optimized chondrocyte source. We need growth factors. Surgery, which is a single stage, can be done arthroscopically, cost effective, with a low complication rate and a high success rate, and which in the end should give us a normal cartilage. My humble advice is that each available technique at present has a role. Always consider the local, regional factors and the comorbidities. There is no single option at present which can establish the hyaline cartilage seen naturally. To conclude that we need a new framework which can improve the efficiency and rigor of cartilage repair clinical development. And it needs collaboration between the industry, regulators, patients, academicians, and clinicians. At the end, we all are trying to find a biological solution to a biological problem. Thank you so much, gentlemen.
Thank you so much, Dr. Vivek. It was a very nice talk and a very good summary. Do we have Dr. Sandeep? Has his internet connection been restored and is he able to join us? I guess not. Dr. Shekhar, then let's take one or two questions and then we can wrap up this session. So Vikram has joined back, and Vikram, it was an excellent talk. My question to you would be, you mentioned the role of osteotomy in cartilage unloading whenever a cartilage surgery is done. What is the threshold value beyond which you would consider a proximal tibial or a distal femoral osteotomy? The angular threshold, that is.
Thank you so much, and my apologies for these technical glitches. It worked throughout, but thank God my lecture at least could be completed. Well,
you've heard of Murphy's Law, surely?
Yeah, I'm sure it is. So it's very important to see the physiological varus or valgus that you have. So comparing it to the opposite limb is very important. For me, the threshold is usually 5 degrees of mechanical valgus. So if it is more than that, then concomitant osteotomy should be performed, because the cartilage is going to find it very difficult to heal up unless you correct
5 degrees absolute value or 5 degrees
of
of side to side difference, Vikram? So I'm sorry to interrupt. 5 degrees of side to side difference or 5 degrees?
Right. So literature says 5 degrees mechanical valgus. For me, it is basically a difference of about 3 to 5 degrees as compared to the other limb. So if there's a difference of 3 to 5 degrees as compared to the other limb, I would go ahead and do an osteotomy along.
Correct, because it's a major procedure
Factors
to offer
consider
to
here, of course. Absolutely, I agree with you.
Dr. Raju, I have a question for Dr. Vinod.
Please go on, Dr. Manocha.
Dr. Vinod, I heard you speaking that BMAC is best taken 2 to 3 ml from one point, and you told there are 3 points on one side. So considering that you need about 30 ml, that means it will be exhausting all the points, and then only will get a 30 ml of a BMAC. So I am getting the BMAC kits this year. I was not aware of this point. Will you please elaborate on this?
You see, you are perfectly right. That is the ideal. You see, suppose you require a 4 ml concentrate, depending on the defect area, which can cover around 2 centimeter square, then it is better that you can take from 2 sides. But like what we have used, and you are probably asking for that, there is a huge defect. I require around 10 ml concentrate, which requires at least 60 ml of aspirate, because I concentrate it 1/6 time or 1/5 time to get this thing. Then it is advisable that you should try to get in different ratio. Like if you want to take 60 ml, you can take 10 ml or 20 ml from 3 sides. It's not possible to limit yourself in each case of 2 ml or 5 ml. What the study says, that if you are aspirating, the first 2 ml concentration is actually optimal. After that, for your psychology, you may draw 20 or 40 from one, but that has hardly any mesenchymal cells. So you should optimize both ways, seeing the theoretical advantage as well as the practical situation, what is permissible in your hands. You have to compromise in between. What that 2 ml is a theoretical experimental study that yes, beyond that concentration decrease significantly. But it doesn't mean that we can reproduce that in each and every case. I agree with you. It may not be practically possible.
Right.
Yeah. I think, that's correct, Dr. Vinod. The studies have shown that the first 1 ml has got maximum mesenchymal cell, and rest all 9 ml out of 10 have very little mesenchymal cells. So if you take at different spots, you are likely to get a better concentration of mesenchymal cells.
Oh, that's a validation of an English proverb as well. First impression is the last impression, or the best impression.
And one thing I want to add here, what Dr. Prateek was asking, that about PRP. You see, once you are using BMAC itself has a bone marrow derived platelets. So there is no use to add PRP with BMAC if you are using for cartilage. So I think BMAC is not merely the mesenchymal cells. It has bone marrow derived platelets, which can give all the advantage of growth factors, which are there in PRP.
No, Dr. Vinod, I was meaning microfracture along with that, not PRP with BMAC.
Okay. Microfracture with
or other
PRP.
cartilage procedures
Okay.
along with that PRP or BMAC or PRP. That will enhance the procedure.
Definitely.
And Dr. Vinod, are there any other sites from where you can take bone marrow, like trochanter and all?
Yeah. You can take from so many sites. Like best one is the osteoiliac crest, what I have mentioned. Then the sternum, then the lower end of femur, upper end of tibia, and even calcaneum. So you can take from many. It's not a problem.
Okay.
Sir, I have a question for Binod, Dr. Binod,
Yes,
sir.
Yes, sir.
Sir, you mentioned about 10 ml syringe and 50 ml syringe.
Yes, sir.
It means that if less amount we are taking,
Yes.
so cells will be more.
Yes. Yeah, that is very important to understand, because if there is a study on that, that if you take 10 ml, then the concentrate has better number of MSCs than if you take 50 ml. And reason is that if you use high pressure, then with the same pressure, the chances of liquid come and diluting effect become more and more. So you should not use the bigger size of syringe. We should use 10 ml syringe or even small syringe depending on our need.
Yeah.
Use it multiple time rather than one straight 20 ml or 30 ml.
So that's why I asked you this question. And tell me, it depends upon the bore of the needle also? No.
I don't think so.
Any idea about that, sir? Just
I
asking.
think that is the standard Jamshedi needle which we use. I think 23 or some goes. I am not exactly remembering. I don't find any study which has compared needles. There may be effect.
Okay.
I am not aware, sir. I couldn't find anything on this.
I just inquired, sir, because more bore needle will get better cells or
yeah, I agree with you. I agree with you. There may be impact, but again, the question come of balance. As Dr. Pratik was saying, if you use more and more, then you may have more and more pain, and chances of perforation and all those things will increase.
Definitely.
So somewhere you have to, and if you will take bigger, then it may even get blocked. You will have a bone. It will become a cannula or bone biopsy needle rather than aspirate. If you want to aspirate a liquid, then you can't go beyond a level of diameter.
True. And it is probably best to follow the manufacturer's recommendations.
Yeah.
Dr. Shekhar, shall we wrap up this session with your summary?
Yeah, I think you can just summarize the salient points and then we close it up.
Right. So I think the very subjects which most orthopedic surgeons would have spent their least time studying in the MBBS, hematology, has come back to haunt us with PRP and all these biologicals. The nomenclature keeps on changing. The preparation methodology keeps on changing. Single spin, double spin can sometimes lead to a lot of head spin to the orthopedic surgeon. But I think the best is to read latest evidence, and evidence can actually go in either directions. The important take-home points in this session were PRP is good evidence in knee osteoarthritis, as we heard from Dr. Karan's talk. And Dr. Vinod's talk, the very important point is not to take the entire sample for BMAC at one go, but to harvest it in 3 to 4 installments of 10 ml each. Excellent talk by Vikram, in which he explained all the options for cartilage repair. Unfortunately, we couldn't have the talk by Dr. Sandeep, and a very nice summary towards the end by Dr. Mahajan. So I think it's been a very fruitful session. Would like to thank all the speakers, my co-moderator, Dr. Shekhar, and Dr. Pratik. Thank you very much. Dr. Dhananjay, please take over for the next session.
Thank you.
Thanks.
Thank you, partner. Thank you so much. It's been a great discussion and a great talks. I really appreciate. Dr. Karanraj Jaggi, are you there?
Yes, sir.
Fine.
Yes.
Then please take over the next session. Thank you.
Yes, sir. Thank you, Dr. Shekhar. Thank you, Dr. Pratik. Thank you, Dr. Raju. Thank you for a wonderful session. Okay, so now moving on quickly to our last session, we have Dr. Varun Gupta, who's the VP of Medical Affairs at 1MG Technologies, and he'll be speaking to us about the National Telemedicine Guidelines. All of us have heard a lot about telemedicine and the role going forward in the COVID scenario and even in the post-COVID scenario. So let's have Dr. Varun Gupta talk about this. And Dr. Varun was instrumental in actually getting these telemedicine guidelines implemented. So I think he's the the best person for us to hear this from, Dr. Varun. And I'd also like to get the panel in place. So we have Dr. Sharad as a part of our panel, and we have Dr. R.K. Mishra. Sir, please, if you could chair the session. Thank you. Dr. Varun, please.
Thank you, Dr. Karan. Thank you very much. And it's a pleasure to be part of this privileged audience. And I would thank you I'm really thankful that I've given me an opportunity to present this guidelines. I'll present my screen. Should I start or Dr. Karan?
Yes. Yeah, please go ahead. Please go ahead.
Yeah, okay. I'll share my screen. So that's the topic of the session, decoding telemedicine practice guidelines. Before starting this, a quick introduction. I am part of the leadership team at 1mg. I'm a senior vice president and part of the core team at 1mg and part of different industry associations like FICCI, IMI, digital health platforms, and so on and so forth, and have been involved into different stakeholder consultations, specifically regarding this telemedicine practice guidelines. So, I mean, there was a long thought process that went inside the formulation of those guidelines. And I start with, interestingly, I was on the weekend, I was cleaning my shelves, and then I got this document. I thought I would use this as one of the reference documents. So this was when we were, as a part of the industry stakeholder consultation, we were preparing those guidelines. We prepared this dossier where we looked at all the international guidelines and thought that what is going on in telemedicine across the country, across the globe, and what is the missing link for us, and in our context, what is more important. So that's, as an industry stakeholders, we were trying to put something which is more practical, which is important for, should not be too technical in the terms of legal. It should not be a legal document. It should be a practical document, and that's the context. So one of the things which was the basic context of the entire telemedicine guidelines was that if a physician or a surgeon is practicing in his offline clinic, that should be the basic premise, and that should be replicable to the telemedicine also. Telemedicine should just be a mean to enable practice. There should not be additional layer of compliance, additional layer of regulations that should come in and inhibit the practice. So I'll start this, and this is, if you look at this is the first important slide where I would also want to show the document per se. Sorry. So if you look at this, this telemedicine guidelines is part of the Appendix 5 of Indian Medical Council Professional Conduct and Etiquette Ethics Regulation 2002. That's the first important point to note, that this is an amendment in the IMC Professional Conduct and Ethics Regulations, because that's the basic premise that determines the practice of a registered medical practitioner, and this is an amendment within that IMC Act. So that's the important point. Then what the overarching principle is a practical advice to doctors. It encourages the use of telemedicine as a part of normal practice. It provides effective and safe medical care to ensure patient and provider safety, realize the full potential of advancements in the technology for healthcare delivery. It's a practical framework. And it has been divided into 5 sections. First section includes the definitions. Second section includes the elements of telemedicine consultation. Third includes duties and responsibilities of IMP in general. D is framework for telemedicine, and E is a guidelines for technology platforms which enable telemedicine. Platforms which enable telemedicine, there's a set of guidelines for them. So let's go section by section. First is the definition. And there is a definition which WHO guidelines, WHO definition has been taken by this telemedicine guidelines definitions. But the important point is, I want to highlight three important words is used for, they have included diagnosis, treatment, and prevention of the disease. Telemedicine can be used for all the three of things, and it can be used for injuries, research, evaluation, and the continuing education of healthcare workers. So the point I'm trying to make is, if you look at the definition and if you look at the intent of Board of Governors is to make it as broad as possible, so that all facets of healthcare education as well as management are covered within this definition. Specifically, very, very important, the journey of telemedicine in India started in 2005, where there was a document that was launched by Ministry of IT, and that included a lot of hardware related specifications. So good point is that within this guidelines, they have given specific exclusions. They say that this specifications for hardware or software are not a part of these telemedicine guidelines. Data management systems, standards, and interoperability is not part of this. Use of digital technology to conduct surgical or invasive procedures remotely, they have not been included within the scope of these telemedicine guidelines. Other aspects of telehealth, such as research and evaluation, has not been included and does not provide for the consultation. And this is a broader point because this is a paradigm shift. As I look into the history of telemedicine within India and within the globe, the last guidelines which we had was more on the hardware and software kind of specifications, and there was nothing for doctors. There was no framework for the doctors. And in this, they have taken a change that this is for the doctors, nothing to do with hardware and software. And that's good. They have not gone into the details of hardware and software because that's keep changing, and this is a good step forward. Then initially, broadly, they have divided into four pieces. They have said it is telemedicine applications could be based on mode of communication, and they have kept it very, very broad. It could be text, it could be video, it could be audio, everything, any mode of communication is part of these guidelines. Then second point is purpose of consultation, whether it is a first time consultation or whether it is a follow-up consultation. And for part of these guidelines, mind it very, very important, they have defined what is first consultation and what is a follow-up consultation. And they have defined that if it is within a 6 months period time with the same physician, then is a first consultation. First consultation is any consultation that is first. Follow-up consultation is if it is within 6 months of the first consultation and the same physician. So there was this point of debate, and that was interesting. The purpose this was defined was, let's say, if a chronic disease patient like diabetes patient or hypertensive patient has been on medication for so many years, and he's consulting not his primary physician but a new physician, right? Now this is a continuum of care, this is a follow-up treatment, but will that be a follow-up consult? According to the guidelines, it's not a follow-up consult. If this is a new physician, it's a new consult for that physician. It's very logical, but they have put that explicitly in the guidelines. That's the important point, that if a physician is looking at I will use for the consistency purposes, they have used the word RMP, registered medical practitioner. So I would use RMP for all the registered medical practitioners. So if RMP is looking at the patient for the first time or within the 6 months of the first consultation, that's the first consultation. If it is within the 6 months, then it's a follow-up consultation. And if it is beyond 6 months, it will again counted as a first consultation. So that's the purpose of consultation. Then they have defined as timing of information transmitted. And across this is, I think, according to the global standards, they divide telemedicine consultation as synchronous or asynchronous. If it is a real-time chat, it is a real-time video consult. If it is a real-time audio consult where the information is transmitted real-time, that's real-time. If it is asynchronous, that somebody has forwarded the details on WhatsApp chat and that's not real time, a physician or RMP is responding to that after some time, or responding to documents on the email, that is asynchronous. So the purpose is they're saying that it both synchronous and asynchronous, it is part of these telemedicine guidelines. And then they've included individuals involved. It could be a patient to RMP, it could be a caregiver to RMP, it could be an RMP to RMP. All such interactions are part of these guidelines. So the point I'm trying to make is that with this, they have set the context that, look, telemedicine, according to them, is very broad. Two, it does not include hardware and software. It does not include data management systems, so on and so forth. Three, audio, video, text, everything is included. First and follow-up is included. Synchronous and asynchronous is included. Doctor to patient and caregiver to doctor, as well as doctor to doctor, is also part of this. And fourth, they have defined care through health worker, consultation through health worker. So this is the broader context they have set. Any questions at this point? Should I move forward?
Dr. Varun, this is Dr. Sharad Agarwal.
Yes.
Can I ask a question? I mean,
yes, please.
I'm surprised that you said the journey started in 2005. And what I remember is that it quotes even the beginning of 2020, we were told that the penalties for giving any advice on phone or telecommunication is going to be very severe. And suddenly everything has changed the moment the pandemic struck and the telemedicine has become a very sort of sought after thing. How do you explain this kind of a contrast?
Sir, the journey of these regulations, when I said 2005, I was referring to the first document by any ministry of the government on telemedicine, right? So that was a document that was published by Ministry of IT and Ministry of Health. That was a MIND panel. But having said that, pandemic, I would say, because I was involved in the entire piece of the journey, I would say the pandemic was just a facilitator because the work on these final telemedicine guidelines was on. And the reason it was on is because there was a Bombay High Court case that was talked about, that case that the Bombay High Court has banned telemedicine, and that was being circulated all across, right? And under Ayushman Bharat, there are wellness clinics, and one of the important component of wellness clinic is telemedicine. So to enable those wellness clinics and telemedicine within those wellness clinics, there was need of the telemedicine guidelines to enable even the Ayushman Bharat program. So broadly, there was the work that has been started on telemedicine guidelines, I would say later 2019 or early 2019. It started again where the momentum was built to come out with those guidelines. It just happened that the guidelines were ready and the pandemic stuck. If you remember, it was published on 25th of March, right? That was just immediately after the lockdown. The detailed guidelines could not be worked out in 2 or 3 days. It was a work of so many months. It would have taken much more time. Maybe it would have gone through round of consultations, so and so forth. But that piece of things were kind of circumvented, and it got published as early as 25th March.
No, but then is the judiciary accepted it? Because suppose there is another case comes and we get it is precedent by the court you just mentioned. The same thing is quoted again and again. The doctor is penalized. I mean, how will that be? How do you protect from there? Is the judiciary
very relevant, sir. I think, Dr. Sharad, that's a very relevant, pertinent question. Now, the initial 2005 document was just an advisory, right? This is a part of Gazette notification. This is a Gazette notification. First time in Indian regulations, telemedicine has been a part of Gazette notification. When I say Gazette notification, that means there is a definition of telemedicine guidelines. There is a definition of what RMP is expected to do. So even so, there is a framework which is notified framework. So it's a part of regulations now, right? So now, if the reference point, let's say that there is a medical legal case that goes to the court, right? Now the reference point would be this guidelines as the reference point, whether the RMP or a particular case or a patient has they abide to these guidelines, then it is fine. If they don't abide to these guidelines and there are some gray areas, there is a discussion that goes on that, then there can be precedent. But it is it's a gazetted notification as a part of Gazette. This is so that's the answer. I would say that before that, it was not part of Gazette notification. Before 2020, it was not notified.
Right.
So it is similar to let's say IMC guidelines, or it is similar to any NMC. Anything which is a notified gadget, generally in a court of law, that becomes the reference point, and a person has to abide by the law of the land. So this is a law of the land now. So and very short, crisp answer to this is, before this, telemedicine was not defined in any of the laws of the country. This is the first time telemedicine has been defined, and a framework has been given for the RMPs that what they need to do to practice telemedicine. And now this becomes the reference point, that we can refer to this document and say this, look, I am on the right side of the law if I have this checkpoints, because this is what law expects me to do.
I am Dr. R.K. Mishra.
Yes, sir.
Hello, audible?
Yes, sir.
Actually, whatever you are quoting about 2005, definitely it was a suggestion, advice. But due to this pandemic and all, whatever the things is coming, it is becoming prompt. Better to say that is the need of time. That's why it came in this way. And whatever the Dr. Sharad Agrawal sir was telling about this court matters and all, always it is a gray area. It was, I mean to say, because whatever the court is deciding, they are deciding on the medical board's advice. They are not doing by themselves. Whatever the case, whatever the litigation or anything, whatever it is with court, they are asking medical boards, and medical board had no power and not to analyze anything without this gazette. Definitely after gazette, whatever they will say in the court as advice, definitely it will matter, and no courts on this basis penalize any doctor. Dr. Sarath, sir, is it clear to you, sir?
Yeah, I got the point.
Yes, sir.
Thank you.
Thank you. Proceed, sir.
Yeah, thank you, sir. Thank you for the nice explanation. I'll move to the next piece. That's the second section of the telemedicine guidelines. It talks about elements of telemedicine, and they are divided into 7 parts: context, identification of RMP, mode of telemedicine, patient consent, type of consultation, patient evaluation, and patient management. Let's go to them one by one. Let's first talk about the context. Now, this is very, very important base, one of the take-home message from the entire piece of the guidelines, professional judgment. And I think they have used this word professional judgment for at least for 10 times in the entire piece of document. And the entire document is based on this piece, that RMP should exercise their professional judgment to decide whether a telemedicine consultation is appropriate in a given situation, complexity of the presentation, or an in-person consultation is needed in the interest of the patient. So the basic premise in telemedicine guidelines is that, let's take an example of a person, of an RMP looking at a patient in a clinic, in an offline setting, right? Now the RMP has the entire treatment, entire diagnosis, entire approach depends on the professional judgment of the RMP. RMP is a trained person, is a registered person. He takes his professional judgment to see that what all investigation needs to be done, what all treatment can be done, whether it is a surgical case or it is a medical case or whatever. That all depends on the professional judgment. Similar to that situation, in telemedicine guidelines, everything, so telemedicine is just a means or mode. It does not change the context. Context remains the same, that patient and a doctor, a patient or RMP has a professional relationship, and RMP is the best person to decide whether this treatment, diagnosis, and so on and so forth is important for the patient. Similarly, RMP should exercise their professional judgment to decide whether telemedicine consultation is appropriate. And in the flow chart given later in the guidelines, what they have given is that RMP can decide to exit any time of the telemedicine consultation and say to the patient that, look, this particular case cannot be handled on telemedicine consultation. I can provide you a first aid or a basic guidance, but you need to go to the offline, you need to go and have an in-person consultation. That's at different points of RMC can exit the interaction between the patient and patient, right? So that's a very, very important point. And second is, of course, availability and adequacy. Before proceeding with the patient management, RMP should consider the more technologies available. That was the point of debate. Let's say I am doing a WhatsApp chat with some patient. Patient gives me a history on WhatsApp chat, and I don't think that WhatsApp chat is the right mode of communication. I can put my foot down and say that, look, this can only be done on a video consultation, and I'm available on this date. Consult my coordinator for booking an appointment. So an RMP should exercise his right to choose the mode of technology and adequacy for a diagnosis, whether that mode is adequate for the diagnosis or not. So entire context is that if one has to visualize the telemedicine guidelines, they have to visualize the normal in-person consultations. Same principles would apply to a telemedicine consultation. That's the context what they have explained. Second point, which they have been saying that multiple times, that telemedicine consultation is not designed to be anonymous, neither from a patient end nor from an RMP end. RMP should verify and confirm patient identity on the name, age, address, email ID, phone number, registered ID, or any identification that may be required. There are no hard and fast rules. They say that because in an offline, in an in-person consult also, when RMP feels comfortable that he knows that patient well, he moves to the next step. Similarly to telemedicine consultation, similar to this in telemedicine consultation, it is on RMP that he should verify the patient identity and he should be comfortable with the identity of the patient. And for patient should be able to verify RMP's identity, the credential, the contact details, and there should be a proper display of registration number accorded to RMP by the State Medical Council and National Medical Commission on prescription, website, electronic communication, receipts. So there should be a particular way. It doesn't mean that you start the consultation with saying that, look, these are my credentials, but there should be a mechanism for a patient to check for all these credentials. And the mechanism could be, as I said in the earlier slide, that we have to see an in-person consult. When RMP looks at the consult, all those credentials are available on the prescription, right? Similarly, if a end result of telemedicine consultation is a prescription and it has the credentials of the RMP, that is absolutely fine. So they have not defined that as black and white, but given a broader framework. And the point is that it should not be anonymous for the patient as well as for the RMP. And for the generation of the prescription, this is a little gray area. They have mentioned that age of the patient is mandatory if there is any doubt, RP to seek age proof. And for minor, prescription would be allowed only if minor is consulting along with an adult whose identity needs to be ascertained. Now they just touch this point, right? And they're not given the entire details of what does that mean. There could be different use cases for this, for which this may or may not be applicable. So they've just touched this point. That's on the identification of the RMP. Third, on the mode of telemedicine, anything can be used, audio, video, text. And as I mentioned, RMP must decide the best technology to use to diagnose and treat and may switch the mode of communication if required. Patient consent. Now that's interesting, right? So they have taken a very different view on patient consult. The reference point was in-person consult. When a patient walks into an OPD chamber, there is an implied consent of the patient, right? Similarly, if the telemedicine consultation is initiated by the patient, he gives the RMP a phone call or books an appointment or send a WhatsApp chat or an email that has been initiated by the patient. So the consent is implied, but explicit consent is required if the consultation is initiated by a health worker or a caregiver explicit consent, if it is required, that it can be recorded in any form. Patient can just send an email, text, or audio video message stating that yes, I consent to avail consult via telemedicine, or any such communication in simple words. So as I mentioned earlier, what I realized after reading this for multiple times is that it is very, very light on the legal side. So they have not used too many legal jargons to make it more complex. It is more practical framework for RMP to use. So that's on the patient consent side. Then types of consultation, first consult and follow-up consult. First consult is for the first time earlier, but more than 6 months have lapsed since the previous consultation earlier, but for a different health condition. That's what they have explicitly defined, that if a person was referring a internal medicine physician for diabetes and he has some other problem, let's say COVID, and he is consulting for the COVID now. In that case, that's for a different health condition, so it would be considered as a first consult, even if the consult is within the 6 months of the first consultation. So a lot of emphasis has been given of first consult and follow-up consult, and the reason they've given a lot of emphasis is that type of medicines that can be prescribed based on whether it is a first consult or a follow-up consult. And follow-up consult, patient is consulting within the RP within 6 months of his or her previous in-person consult. It is for the continuation of care and of the same health condition. It not to be considered as follow-up if any of the following is true. More than 6 months have lapsed from the previous consultation. There are new symptoms that are not in the spectrum of the same health condition. RMP does not recall the context of previous treatment advice. So that's to be considered as first consult, not as a follow-up consult. Then patient evaluation. So now it starts the exchange of information between the RMP and the patient. Again, the type of information, the quantity of information is based on the professional discretion. As I said, this word has been used multiple times and a lot of importance has been given to the professional judgment, professional discretion of the RMP. So it is depending on how much history, how much investigations, how much information is required for the professional judgment, that is based on his discretion, and the type and extent of patient information is also dependent on professional discretion. RMP can request for additional information, can request for physical examination or a surrogate physical examination or some lab findings or lab reports before taking a professional judgment. And RMP should maintain all patient records, including case history, investigation reports, images as appropriate. And there was a lot of debate around that. Do we need to store this? Do we need to store the video recordings? Do we need to store the audio recordings? There's a lot of debate that if you have to go abide by these regulations, do we need to store this? So as I said, the intent was that it is part of medical ethics guidelines, IMC 2012 guidelines, part of that. It is a chapter within that particular guidelines. So you have to look at these guidelines in the picture of the entire IMC guidelines, not as an isolated telemedicine guidelines. And at a lot of these points, it refers to the IMC guidelines as applicable in IMC. So we have to do whatever we do in our normal in-person consult. If a particular case requires records to be maintained in in-person or IPD settings, that needs to be done in telemedicine guidelines. If it does not require records to be maintained, you don't need to maintain the records within the telemedicine setup also. It is similar to what we do in an in-person consult. Patient management. So prescribing medicines. Again, they've used this word, that same professional accountability as in traditional in-person consult. If an RMP is writing any medicine, any treatment, that's a professional accountability, and similarly, that's true for telemedicine also. They've taken these lines from that Bombay High Court judgment, right? This is what was the judgment was, that prescribing medicines without an appropriate diagnosis, provisional diagnosis, will amount to a professional misconduct. So this is the quote unquote lines that were there in the Bombay High Court case. And that is what they have also referred to. And that is true for in-person consult. And there's a basic format of prescription that includes date of consultation, all the basic stuff is there. And a prescription can be a type of the prescription. It could be a scan of a signed prescription. It could be an e-prescription. There was a lot of debate that e-prescription has not been defined. What is an e-prescription? So that is in the process of clarification, that there's a chance that a clarification may be issued as what is in e-prescription. At this point, they've just left e-prescription open for interpretation, but given a format of the prescription. Transmit the prescription to the patient or to the pharmacy as appropriate. Patient management, they have defined the group of drugs, drug, health education, counseling and medication. That is what broadly, and there is no restriction of health education and counseling. That can be done on any mode of consultation, any nature of consultation. But for medicines, they have used two levers. One lever is which type of consultation is there, whether it is a video, audio or text, and two, what type of consultation is there, whether it is a first consultation or a follow-up consultation. And the basic principle is that if it is a first consultation, the basic OTC medicine kind of drugs can be prescribed on any type of consult. But if it is a first consultation and it's a video consultation, only list A medicines can be prescribed. And for the follow-up patient, that's a list B, that's a more broader list that can be prescribed only to a follow-up patient. Now, there's a lot of gray areas between list O, A and B. And what they are working, and there were some clarifications that were issued by Ministry of Health after 25th March that listed a lot of drugs that were in A, B and C. But the broader point which I see and can be used as a framework is, number one, if it is an health education, counseling or generally over-the-counter medications that are prescribed, any mode, any patient, first-time patient or follow-up patient, if it is a video consult, if it is a first consult, prefer a video consult to prescribe medications. If it is a follow-up consult, then also it is absolutely fine. I'll take a small halt at this point. If there are any questions, happy to discuss.
Sorry, Dr. Mishra, please go ahead.
No, sir, you continue, sir. Continue then.
So Varun, what I want to know that as I understand regarding the consultation, whether to continue with the consultation or ask the patient to be seen physically or to visit the clinic lies with the doctor. I understand? Right. So at times it may become very difficult to decide. The case which have probably been mentioned, probably Bombay High Court case is same, that elderly gentleman called the doctor for a fever, that I got a fever. And naturally any of us would first day they take a tablet of paracetamol, see if it doesn't settle in a day or two, then you seek advice. The same was done probably in that case, and that gentleman developed some complications of a dengue fever and died ultimately. So this this kind of error, what I'm trying to say, this kind of error can happen very easily on a teleconsultation. You talk to a patient calls you, you think that is it something which can be tackled on telecommunication, and ultimately in a short period of time there a complication develop and the patient has a problem. Does this whole act of all guidelines do and give any protection to the doctors from these kind of error of judgment if they are given on phone?
Yes. So coming to your first point, I have reviewed that Bombay High Court case in much detail, and I've gone through each of these documents. So there were a lot of things that happened in that particular case, and it was a case where the patient was admitted in the nursing home of that doctor, and the discharge card was even given to the patient a day before he left the city, right? And there were so many nuances in that case. That was not only one of those incidences of consulting on telemedicine. There was and I'm not commenting on that, but at least the honorable court has observed that negligence was at many points, at least 10, 15, 20 points, right? So they have noted and observed that. So tele part was just one piece of it. Having said that, the question you asked is, they have kind of defined, if you look at this is what they have defined, that they have given some framework that patient identification, consent, and if quick assess if emergency care is required. If yes, advise first aid, immediate relief measure, guide patient for referral as appropriate. So one of the things they have been mentioning, it is similar to offline in-person consult. Let's say I am an internal medicine doctor and there is a patient which is beyond my capacity and ophthalmological case comes to me, right? And but he comes to my clinic. I have to take a stand. Look, I don't know about this domain. You better refer to an ophthalmologist. I may prescribe some symptomatic treatment and document that you need to refer to an ophthalmologist for this condition. This is beyond my scope, right? So similar to that, at least theoretically, they have mentioned that RMP has to exercise his right and say that this cannot be done on this professional. Prescribe only if he's comfortable prescribing that. If he has gathered the adequate information that all the checks and balances have been taken care of, that's what at least that framework is. Uh, Plus, as they have mentioned that it is the professional judgment, and if prescribing paracetamol for a particular case of fever, if there is a professional, if we have reason 1, 2, 3, 4, the reason we have prescribed a particular medicine for that case, and if you are able to produce that in a, let's say I'm hypothetically saying court of law, that's professional judgment, right? That's part of RMP's professional judgment that I thought that I prescribe this particular medicine for reason A, B, C, right? So one can justify those reasons, then it is absolutely fine. Did I answer, Doctor?
Just a little more clarification I want on that. What I'm trying to say is that if the RMP thinks at the first consultation that this problem can be solved on telemedicine, and he does prescribe something, and unfortunately turns out to be something more sinister, and very quickly patient develops some complication in the next 1 or 2 days. Is there any there is obviously an error of judgment on the part of the RMP in deciding whether it was a real emergency or it was just a simple problem. Is there any protection for the RMP to making this kind of error of judgment?
Dr. Sharad sir, I have a follow-up question on that, just to build on this, because this was discussed multiple times, and the way it was built was that let's take similar scenario in an in-person consult, right? An RMP looks a patient and takes a professional judgment of prescribing medicine, and that may be an error on the part of the RMP, right? Now, what happens in a normal in-person consult?
Okay, I agree.
It will depends on the whether that, so the particular, if the patient puts up a complaint, it would depend on that particular case, whether that professional call was part of the judgment, or was it, because there is a thin line that differentiates between the judgment and negligence. So that would be decided by a board or ethics committee of NMC, and so on and so forth. That depends on the particular case.
So my only point is that in person, the doctor RMP would have more data to decide on. On telemedicine, not that it cannot examine the patient, cannot see all the parameters. That's why it is more chances of doing an error on telecommunication. That's what I'm trying to say. You'll have more data.
I agree. I completely agree in the sense that if, let's say, I am arguing that case in a court of law, I cannot argue that because the RMP has done a teleconsultation, there is a case that can be filed. I cannot argue on the telemedicine as a means, because that's a telemedicine is an accepted gazetted definition is there. Before March 2020, I could have argued that telemedicine is not an acceptable mode of communication or mode of consultation. I would have argued on that also. Now, my sub-arguments depends on a particular case, but as you rightly said, it has its own limitations. Telemedicine has its own limitations and strengths. So it is on the professional judgment. It is similar to, so there can be such scenarios in different kind of in-person consults, and OPD versus IPD versus or whatever. There could be different, and RMP would have different data points or different variety of data points at different levels. So based on that, a person takes a call or professional judgment. Similarly, in telemedicine also. I mean, but as you said, it's too early. There would be all these litigations would come in the year to follow, and we would see that how it evolves. Right. So.
Right.
Can I add one thing to Sir? Sharad sir?
Yeah.
You asked one thing, sir. Your question is very valid, sir. One thing, firstly, you told, sir, that in emergency, if anybody is consulting me for telemedicine, definitely, according to his symptoms, we can prescribe the medicine. And if we think it is a case of an emergency or it is not to be handled by me or by the better person, I mean to say RMP of that particular thing. So in that condition, we can tell them or make a note of that as early as possible to visit to the I mean to say consultation. Or if we are writing anything, whatever we are writing in giving in video, audio or anything, it is documented. So nobody will say why you are not given any referral to other person. Let's say might be in mid of the night, some of third person, you have not seen that patient before, telling you, sir, I have heard your name by a name of orthopedic surgeon. I am getting pain over any part of that body or something. Just you can give a medicine to get relief from the pain, और वैसे कंडीशन में बेटर टू टेल देम कि आप कंसर्न, मेरे को लगता है कि ये भी पॉसिबिलिटीज हैं, तो यू बेटर कंसल्ट टू द नेक्स्ट कंसल्टेंट और इट्स बेटर टू विजिट देम. Definitely, sir, telemedicine is a very good thing. Even then, physical examination of the patient is always will be there, and it will help a lot, sir. So many things can be changed on telemedicine and physical visit verification visit of the patients. This one. Yes, doctor, am I right or wrong? What is your opinion?
Absolutely. Telemedicine is just a tool. It's just a tool. It's the RMP to decide whether to use this tool or not to use this tool.
Definitely. Telemedicine was started with a thought that anytime somebody is in remote, the person can get the benefit of best of his doctor. If somebody is sitting in Delhi and sees and patient is sitting in somewhere in any part of India, and that is in remote area, definitely if he has number or contact number or by any means he can get better treatment, he can do this. लेकिन सर इसका थोड़ा सा गलत भी यूज हो रहा है. That is, we will talk afterwards. Doctor, you have mentioned one thing, that first consultation and follow-up consultation. First consultation was not defined before this telemedication. First consultation after 6 months, if anybody is coming to doctor, even he is on, but he or she on the particular this one treatment, it will be considered at first only. Is it clear?
Yeah.
Huh?
Yes, sir.
Because so many times it happens, you have written patient, prescribed patient for 6 weeks or 3 months or 2 months. But after that, the patient has not come for follow-up. He is coming after 6 months, 8 months, 9 months, 10 months, and will tell you, I was continuing this medicine only. What it may get complicated due to those medicines also. Sometimes it happens, whatever he is telling, that is not the true also. In that condition, this telemedication gadget has given a very good explanation that in that condition patient should be treated as first consultation, because कि आपको नहीं मालूम है कि इस 6 महीने में उसने क्या दवाइयां ली या नहीं ली या वो किस कंडीशन में था. It is a very good one according to me. Am I right?
Yeah. Yes, sir.
Okay. Please, sir. Continue, sir.
And
sir, we can move forward, sir. Sarat,
yes,
sir.
sir. Okay.
Yes, sir.
Okay. Thank you, sir.
Would like to move quickly now because it is getting late. So we'll now finish your talk, then we'll discuss.
Okay, thank you.
Okay, sure. I'll just take 2-3 more minutes and finish this. So there is a list of prohibited medicines that has been published, and mostly it includes the anti-cancer drugs, narcotics, such as morphine and codeine. But my take on this list is that it needs to be evolved, and in subsequent years you will get a detailed list of such medicines can be prescribed on what consult. But from a direction perspective, this gives us a direction. What is the direction that needs to be taken? So that's how we should look at it rather than looking at it academically. So that's on the duties and responsibilities. That's the next section. And broadly, they are saying that medical ethics, data protection and privacy, penalties, this is as per the prevailing laws. There is no new thing that has been introduced in this guidelines. And that's the important point. Technology breach. As an RMP, I am very happy to see this line. RMP will not be held responsible for a technology breach or breach of confidentiality, privacy by a person other than the RMP, because as we use telemedicine, there are multiple stakeholders we have to work with. If there is a particular problem with a particular stakeholder, RMP is not held responsible. There is a protection for the RMP for the technology breach and misconduct. Next section is misconduct. Actions that willfully compromise patient care or privacy and confidentiality or violate any prevailing law are explicitly not permissible. So broadly, if I have to give one of the things after reading this, I got it is that whatever is there in IMC, Indian Medical Council Ethics Act, that's the prevailing law that is also applicable while we practice telemedicine. Maintain digital trail and documentation. It is incumbent on an RMP to maintain and retain the following for a period of as prescribed from time to time, similar to what we do an in-person consult for an OPD or IPD interaction. Similar to that has to be maintained in telemedicine. Explicitly, they have mentioned for telemedicine fee for telemedicine consultation. Consultation fees as appropriate, an appropriate fee can be charged depending on the type of consultation, experience, so on and so forth. But I mentioned the receipt of the fee charge should give a receipt invoice the fee charged. That is what they have explicitly mentioned. Is a step forward. I don't think I've ever seen a document where these things have been mentioned explicitly. Summary, that's the last slide. Summaries, do's and don'ts. Do's is assess the context and appropriateness of teleconsult. In this remote world, we get a lot of calls, messages. We have to put our foot down, maybe prepare some templates to which if an RMP does not have enough time to reply to all those messages, at least those templates could be pasted that go and refer for an in-person consult. So that's important to assess the context and appropriateness of teleconsult. It's important to at least document the identity of the patient and the caregiver while documenting the teleconsult. Inform about your identity. There should be a link or there should be a signature in the WhatsApp messages or wherever where the registration number and identity can be done. So that is important. Confirm the patient consent. Prescribe in according to the guidelines. Broadly speaking, if it's a first consult, better use a video consult to prescribe any medicine. That's in general would be the safe mode. Maintain the patient records as applicable. Don't do an anonymous consult. Do not continue if you are not comfortable. Do not breach the confidentiality. Do not deny emergency consult. They have mentioned that a person, an RFP can give first aid and refer to the appropriate care. Do not prescribe from the prohibited list. So professional judgment should be the guiding principles. Same principles apply irrespective of mode, video, audio, text. Exercise professional discretion for the mode of communication, not to proceed. And there's a right for the RMP to discontinue the conversation. That's broadly the essential principles. I would end my presentation over this point with this, and they have given the detailed flow charts which one can refer to, that what needs to be done in the first consult. And this is just a flow chart. Whatever we have discussed in text as given in the flow chart. And there are some guidelines for technology platform which are enabling telemedicine. These are not applicable to RNPs. For the technology platforms, they are obligated to ensure consultancy. They need to report non-compliance. AI, and this is an important point, artificial machine learning can assist and support RNP, but not consultations. So that's an important point. Explicitly, they are mentioned that all the AI and machine learning tools need to assist the RNP, should not directly interact with patient in any form or manner. That's important. Proper mechanism to address queries and grievances, and violators should be blacklisted, may be blacklisted. One line about what is 1mg. This is a healthcare tech startup, and why we kept it as 1mg, because our first office address when we started late in 2014, our office address was 1 Mahatma Gandhi Road, and it was also kind of related to medicine strength. So we thought that it was a sciencey name. This is a management team, globally experienced team, management team. We want to do information engagement, internet, hospital, data science, and AI-enabled models. Personalized health management is where we want to reach.
Can we just stick to the academics? Is it over, sir?
Yeah, that's it.
Is it over?
Yes, sir.
Dr. Sharad, Dr. Rakesh, over to you, sir.
Yes, sir.
Any other panel discussion, sir?
I think, Dr. Varun, you have very explicitly, clearly defined what the guidelines for telemedicine. What I could gather is, and we have felt it also, that there are certain gray areas, and how it is going to proceed in that line will only time will tell us. When, as you said, the litigations and that other things may come up in future. And second point I gather is there are certain guidelines which are to be followed, certain methodology which to be followed, like keeping records and keeping consents and all those things, which many of us may not be able to do at this stage, and slowly that system has to develop. But it is an end thing, it has to stay, it is not going to go away. And thanks for your nice presentation. Dr. Mishra? Unmute yourself.
निशा जी अनम्यूट करेंगे.
मैं करता हूँ. सर मेरी तरफ से नहीं हो रहा है, उनका शायद.
हाँ, हो गया. Sir, very good presentation by this Dr. Varun. He is elaborated so many things, and whatever the cons and pros of this telemedicine he has told. Sir, one very good point is there, that you may or may not keep the whatever the things you have talked with or chat with your patient, but it's better, according to me, that we should keep it as our record. We can keep all the photographs, all the documents with ourselves. It is always legal for us. In any time, it will help us anytime, sir. And any litigation or any point is not coming after 4 to 5 years. It is definitely within 6 months, 1 year, 2 years, 3 years, not more than that. So and nowadays it is not very difficult to keep it with us. So कहीं भी रख सकते हैं सर, गूगल ये वो बहुत डॉक्यूमेंट्स हैं, वहां हम लोग डाल सकते हैं, और इट्स बेटर टू कीप इट, क्योंकि हम लोग जितनी बार प्रिस्क्रिप्शन लिखते हैं, दैट इज वी आर नॉट कीपिंग विद एज रिकॉर्ड, बट विद टेलीमेडिसिन वी कैन कीप इट. सो सर ये हमारे लिए फायदे की चीज है, और बाद की जो चीजें आएंगी वो तो समय के साथ पता चलेगा कि टेलीमेडिसिन में क्या प्रॉब्लम है और कैसे है. ठीक है सर?
Right, Dr. Mishra. It's a developing science. We'll all learn it. Thank you. I think we can end the session.
Thank you very much.
Over to Dr. Dhananjay for final.
I think we should declare the close of the academic session of Doacon 2020 with your kind permission, sir. It has been a marathon run for any state conference, and I'm really glad that we still have so many runners still on their legs at the end of the session. And I would like to request Dr. Hitesh Lal to take over from there and announce the winners of the competition session of the various papers and the posters which was held yesterday.
Thank you, sir. These are the results of the competition held during this Doacon 2020. For the PG competition, the first prize goes to Dr. Arpit Sahu. Second goes to Dr. Shahrukh Khan Ahmed. Third goes to Dr. C.H. Nipuni Ova.
I think 3 cheers to all the winners.
Yes, sir. Cheers, sir. Cheers.
For non-PG contest, first prize goes to Dr. Ankit Khurana of ESI Rohini. The second prize goes to Dr. Bushu Harna of Max Patparganj.
Wonderful.
Very good.
Yes, for them also, sir.
For the poster competition, first prize goes to Nishank Mehta. Second goes to Dr. Narottam Das and Dr. Kulbhushan Kamboj. Third prize goes to Dr. Sudha Varapu, Praveen and Sagar Bagwe.
I hope they are here to appreciate their hard work, fetching them nice.
This is the International Paper Awards. In the more than 40 years category, it goes to Dr. Anil Arora. And in less, first prize goes to Dr. Pramod NK. Second goes to Dr. Kunal Arora. And third is Dr. Ronak Keshian and Dr. Mohammad Danish.
Wonderful. I mean, it simply showed we had such nice quality of the papers over here. It was a tough call, and I think all the people, the margin was hardly 0.5 marks or 1 point. If there's, do you want to carry on with your exchange of medallion with your DOA activity, or I just simply present the vote of thanks and
do it virtually?
It's my pride privilege to hand it over to Dr. Mani, Lalit Mani, and thank you.
Yes.
Thank you very much, sir.
Dr. Lalit Mani, you just need to bow your head also like this.
And I put it there, right?
Bye, Lago, sir.
So the symbolic part is over. Now we come to the most important part of this particular conference, the vote of thanks. It gives me great pleasure and great honor to share all the accolades with my team, which have been working very, very hard, honestly. For any just such conferences, the objective remains good academic content for the delegates. So I'm indeed thankful to all my faculty, the speakers, and especially the presenters. I mean, you'll be surprised, as we had discussed earlier also yesterday, that this particular generation of residents, they are very well aligned with the latest developments, thanks to media, thanks to the net, and their paper presentation skills, paper preparation skills, they have been outstanding, really. I mean, of course, we are quite senior in that matter. When if we compare, we cannot compare ourselves from them when we were there at that stage. The sort of resources which we had, they were quite restricted, but still their confidence and their workmanship, it was outstanding. So I'm indeed thankful to all the people who came over as faculty, as presenters, and as the speakers. We are really thankful to all the delegates who took efforts, logged in. I still don't have the numbers exactly. I'm trying to get them from the platform. Moment I get it, I'll share it with you. Then the whole process, you have men, the machine or the media, and the money. So the men, I would say, I mean, you can see Ravi Chauhan has been sitting there throughout. I really hope that his chair is quite good. Otherwise, he'll be visiting someone with the coccydynia. I mean, outstanding effort. Thank you so much, Ravi, for being there all the while. Needless to say, Hitesh Lal, Amit Kansal, they have always been the backbone. I mean, anything you get stuck, you just call them over and tell them, and that's it. I mean, blink of the eye, ho jayega. That's it. Those magical words, and you can always count on them. Sharad Agrawal, I mean, I must have called him up so many times for his guidance, for his advice. And I mean, I was never ever left wondering high and dry, ki nahi, ye kya ho gaya hai apna wo. Regarding the scientific program, Dr. Anil Jain has been there at the forefront. I have had some great input from the people like Dr. Lalit Mani. I shared the program with him, and his input was quite, I would say, appreciated. Dr. Rajiv Joshi, he was my senior at Sancheti Institute of Orthopedics. Even his input about the topics and other subjects was quite nice, rather. Karan Raj Jaggi, I mean, that man has got a wonderful mind. He can just sift through. He just sits down, ki, "Acha sir, kya karna hai? Ye session hai, so let's see, let's think what topics can be taken up over there." So his contribution in the scientific program was quite outstanding also. The toast of the evening, the so-called cultural program, Dr. Yash Gulati, Dr. Anmol Maurya, Dr. Rajiv Jain. I mean, these guys, they were so passionate, they were so upfront, and they mobilized everyone over there. And it was really heartening to see one of the executive committee just throwing their mask away and joining the dance, at the stage. It was very nice. Thank you so much, guys. As an organizer, it gives you sort of happiness that yes, everyone was able to enjoy it. The machine or the media, the Author TV platform. I mean, honestly, I'm telling you, Dr. Ashok Shyam, Dr. Neeraj, and Mr. Rajiv Menon also, the 27th November program, it wasn't in the schedule. Still, these guys, they came up on board, they prepared the whole platform. I mean, it was wonderful, honestly. I would say 75% credit goes to them for building up such a nice platform. The feeling as such, that you are entering into a wonderful arena and you have lecture halls, you have poster hall, exhibition area. It was wonderful, really. My first experience, but it was very nice. Thank you so much, team. And again, like today we had to run a special program. So these guys again built up they gave us the connection for the hall B again. So they were always upfront trying to help us out, and we really appreciate their help. Coming to the money part, of course, it would have been possible without the financial assistance which we received from our sponsors. The outstanding have been Zydus Cadila Ortho Division. I mean, you can call them platinum plus platinum plus platinum. Almost 50% of our budget came through them. I'm indeed thankful to them. Then we had so-called platinum sponsors, IPCA Orthopedic Division. They have been, I would say, they have committed. They are yet to deliver, but I can count on them. They won't let us down. Torrent has also not come forward in the terms of the amount which they'll be sharing, but they have been coming forward that yes, we will support you. Evis, Bone Max Division, then Novartis, Panacea Biotica, Dr. Reddy's Prolia Lab, they all have been gold sponsors. And I'm sure at the end of the audit, Dr. R.K. Mishra will be able to tell us how much we have managed through DOA coffers and without the DOA coffers, or rather how much they are going to contribute. They're still open-ended. And thank you so much, gentlemen. It has been a great journey. And I think it's been a fulfilling ending to my association with the Delhi Orthopedic Association. As a past president, I can happily retire now that yes, I've done my part. Thank you so much.
Dr. Dhananjay, nobody will let you go retired. And
you are not yet retired, sir.
And 3 cheers for Dr. Dhananjay. Excellent job.
Thank you. Thank you so much.
Excellent culmination of DOA EC 2019-20.
Thank you so much, sir. Thank you.
Bye.
We can call it off now, sir.
Yes.
Thank you.
Thank you.
Yeah. Off live now.
Can I stop the streaming?
Yeah.
Okay, sir.